care for them locally is an excellent idea. I hope that this clinic will offer a platform for research, development of local expertise, and training, and I hope from this clinic we'll have further bridges and cooperation with King's College. I thank you very much, and especially thank our patients who are our inspiration, and our aim for giving them the best care is what keeps us going. Medicine is a tough job, and every day I wake up with a prayer, please God, let me do the best for my patients. I hope we can do the best for our patients, and I hope we can improve their quality of life. I would like to thank the speakers who took their time from their busy schedules to come and enlighten us today on this very important topic. Thank you very much. Enjoy the conference.
Thank you, Madam. Next, to welcome the international faculty and delegates to Bahrain, I would invite Dr. Mohammed El Mahdi and Dr. Mohammed Al Ben Falah on stage to give a welcoming note.
Good morning. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to this first movement disorder conference in Bahrain. Thank you so much for Bahrain Specialist Hospital, Dr. Najah and Dr. Qasim and Akh Majid for this fantastic initiative. And special thanks to King's College for considering Bahrain to host such a prestigious meeting. We don't have much action these days in Bahrain, so having such a very specialized neurology and movement disorder specialty conference is a very exciting moment for all of us. I would also like to welcome and thank all our speakers for joining us today and enlightening us with their great knowledge and wisdom. Thank you so much.
Assalamu alaikum. Good morning, everybody. I'm proud to say that we have now organized the first international Bahrain Movement Disorder conference. I asked my dear Dr. Adil Jeshi if there has been ever a conference for the movement disorder in the country. He told me no, so I dared and I asked to say that we have the first movement disorder conference in collaboration with King's College Masterclass, led by Professor Ray and Dr. Vinod and our dear guests, international faculty. Hopefully we are doing such conferences to establish a world standard of neuro care, and there is more coming for our lovely kingdom Bahrain. So I want to welcome everybody. I want to thank Bahrain Specialist Hospital who have done enormous effort to establish such a great meeting. And I want to thank King's College. I want to thank my colleagues, and hopefully will benefit from our conference today. Thank you.
Thank you, Dr. El Mahdi. The first symposium is on advanced Parkinson's disease overview. It's my humble privilege to welcome the chairperson, Professor Vinay Goyal, Professor of Movement Disorders, Institute of Movement Disorders and Parkinson Center, Medanta Hospitals, Delhi, India. Dr. Majid Al-Abdali, Consultant Neurologist, Neuromuscular Disorders, Assistant Professor of Neurology, King Fahd Hospital and University. Dr. Katarzyna Poplowska, Department of Neurology, Poznan, University of Medical Sciences, Poland. It's a privilege to have you here.
Good morning, everybody. It's nice to see that everybody has come early morning to attend this session. And to begin with, we have Professor Parodi. He's going to talk about advanced Parkinson disease and overview. Professor Odin is head of the department of Lund University, Sweden, and he is a world-renowned person in the field of movement disorder. As a student, we all have read his papers, so let's hear what he has to say. Professor Odin.
Yeah. Thank you very much, and thank you very much for the invitation to this wonderful country and this impressive Congress. So I will speak a little bit about advanced Parkinson in general as an introduction to the lectures that will come later. I will slightly touch on several subjects that you will hear much more about later today. My disclosures to begin with. Well, we all know that we have to do with progressive disease, which starts much earlier than we thought, probably several years or 10, 20 years before we have the motor symptoms, the disease process starts. And we have learned during the last decades that we can have a lot of non-motor symptoms before we get the motor symptoms. The more specific may be REM sleep behavior disorder and olfactory loss, but also constipation, anxiety, depression, and many other symptoms can come before we get the typical motor symptoms and can set the diagnosis. And when we have set the diagnosis nowadays, we probably, most of us, start the treatment immediately. And the patients will have often some quite good years with good effect of the treatment and where they do not notice so much from the disease. But almost all our patients will come to the advanced Parkinson stages, and including then motor complications, not least wearing off, and also dyskinesias and gait problems, balance problems, dysarthria, dysphagia, and many other symptoms, and a large number of non-motor symptoms, including cognitive difficulties, dementia, psychosis, depression, and many other. So motor fluctuations is a key problem in these stages of the disease. We get more and more symptoms with time, as we see here to the left. And this can include tremor and speech difficulties, weakness, problems with balance, and many other symptoms. And this situation that the patient doesn't know when he can move normally and cannot move normally, this really influences the quality of life of the patients, as we see here to the right, that motor fluctuations will influence quality of life considerably. Many of our patients also get dyskinesias. It has been much discussed over the years how much the dyskinesias influence quality of life, but I think we can now agree on that also dyskinesias have a quality of life effect. This is one of the studies showing this. It's a multivariable linear regression analysis evaluating the association between dyskinesias and health-related quality of life from 817 patients in 5 European countries. And what we can see is that the dyskinesias do negatively impact several domains in the quality of life, including ADL and stigma and cognition. Advanced Parkinson is also problematic for the caregivers. This is one study illustrating that, and to the left here we see the increasing caregiver burden when the patient is moving from early to intermediate to advanced disease. And this can also have effect for the caregiver's own health, as we see to the right, increasing amounts of anxiety, depression, problems with mobility, pain and discomfort. Advanced disease also means a lot of non-motor symptoms. This is from the PRAI study from Italy, published 2009. And what we see is the occurrence of different non-motor domains in the patients when they are in the different Hernier stages. And to the right, we see the advanced disease with Hernier stage 4 to 5. And in brackets, we see the percentage of patients having the non-motor symptoms in question. And we see that here, many of the non-motor domains occur in more than half of the patients. In some cases, even more than 80% of the patients have the problems, for example, psychiatric symptoms. It is also expensive with advanced disease. This is from the Institute for Health Economy in Lund, Sweden, and it's the costs for Parkinson in Sweden when we have Hernier stage 1 to 5. In Hernier stage 1, we have relatively moderate costs, as you see, around 5,000 euro per year and patient. But when we reach Hernier stage 5, we have more than 100,000 euro per year and patient. And the cost-driving factor is, as you see, mainly the formal care of the patients. This is a similar thing, but here we have grouped the patients after how the large percentage of day they spend in off. And we see that when they have much off, we also have higher costs. So it is important to see when the patient is moving from the phases where he has good effect of the medication, moving into advanced disease. And why is that important? Well, it is because we have possibilities to treat this in a good way. We have the advanced therapies, and here we have first then deep brain stimulation, which you all know well, which is on the market since the early 90s and has very good effects in stabilizing motor fluctuations and improving dyskinesia and tremor and many other things. And we have the advanced pharmacological treatments based on the continuous dopaminergic stimulation, building on the fact that we know that the normal physiological situation in striatum is that we have relatively constant dopamine concentration, but when we give tablets of L-dopa, especially when we do not have so many dopaminergic neurons anymore, like in the middle here, we get very fluctuating dopamine concentrations. And we have learned that if we can mimic the normal situation instead and get a more continuous concentration of dopamine, we will have better effects. This has been shown in many animal studies, of course, and is also now clinical truth. Here is an animal study with MPTP lesion monkeys who get apomorphine injections or apomorphine continuous delivery, and we see that the ones that get injections, they very quickly get dyskinesias, and the ones who have a rod of apomorphine delivering apomorphine continuously, they do not get dyskinesias at all. And results like that and the clinical experience has led then to that we now have a large number of treatments on the market which are based on continuous dopaminergic stimulation and continuous drug delivery. And we will get even more, I'm sure. The most effective ones probably being the pump-based therapies that you will hear more about today. Apomorphine subcutaneous infusion with portable pumps coming to the market from England in the early 1990s. The L-dopa, carbidopa intestinal gel, LCIG, duodopa entering the market in 2004 in the first countries, developed in Uppsala, Sweden, and where levodopa carbidopa gel is delivered to the proximal part of the small intestine where it can be absorbed. And we have another version of that, and that's this levodopa entacapone carbidopa intestinal gel, LESIG, available now in 21 countries, Lesigon. Here it's very like duodopa, but we have entacapone in the gels, meaning that we can have a smaller gel and a smaller pump, and some patients like that, of course. And we have the newest treatment, foslevodopa, foscarbidopa, infusion with portable pumps subcutaneously, so now we can give L-DOPA subcutaneously since about 2 years now on many markets. And all these pump treatments are based on the thought that we should we will get a more continuous plasma level of L-DOPA if we give the treatment with pump. And this has been shown in many pharmacokinetic studies, like this one with LCID DOPA. Here it is 18 patients getting L-DOPA infusion over 16 hours, and we see that we have a very constant level over the day. So what does this lead to in clinical effects? Well, if we want to treat Parkinson well, we all know that we have to think about many things, and this is nicely illustrated by Ray Chowdhury's dashboard that you see here, that we have to think about motor symptomatology, treat that well, but also non-motor symptoms, gut problems, bone, and also co-medication and comorbidities and side effects have to be taken care of. So what does then the advanced therapies bring in this respect? Well, let's look at the motor first. We have many studies now showing the nice effects of the pump treatments and of DBS in reducing off time per day. This is probably one of the most well-known ones from Molenov et al. From 2014. It's a double-blind, double-dummy study, so all patients had pumps, all patients had tablets. In half of the patients, the pump were active, and in half of them, the tablets were active. And one could here, under controlled conditions, show in these 71 patients that going to pump is more effective than trying to optimize the peroral therapy in these patients. And the effect we get, the typical effect we get when we move from tablets to pump is that we get rid of about 60% of the off time, or about 4 hours less off per day, and a corresponding improvement of the good on time without dyskinesias. This has for LCID, for DOPA, it has been shown in a lot of studies now. Angelo Antonini has done this systematic review, 21 patients, 1,875 the 27 studies, 1,875 patients being treated for 1 to 10 years. And again, we see the typical effect with 60% reduction of off time. So it's not 100% effect, but it is 2/3 of the off periods disappear. So it's a very good effect. For long, it was not clear if we can also improve the dyskinesias with pump treatment. With DBS, it is clear, it has a clear antidyskinetic effect, but we now also know from the pump treatments that they have an antidyskinetic effect. This has been shown in several studies. Now, this is probably one of the most well-known ones, the Discover study, again with LCID DOPA compared to best medical treatment. And we see that when we put the patients on pump, we get rid of a lot of the dyskinesias already within 2 weeks, and the effect then seems to be stable up to 12 weeks, which was the length of this study. How is it then with the non-motor effects of the advanced therapies? Well, we also have non-motor effects, and that was seen at an early time point when Ray had developed the non-motor symptom scale. The first treatment that we looked at with that scale was DOPA LCID. This is another LCID study, the Gloria Registry study, a real-life study over 24 months, where 375 patients were included. And what we see is the significant and nice improvement of the non-motor scale total score. So the load of non-motor symptoms improves when we move to pump treatment. And which part of the symptoms do react best then? Well, as we see here from the subscores, sleep fatigue, mood cognition, but also the gastrointestinal domain seems to be strongly improved. But there is a broad effect on many non-motor symptoms when we go to DBS or to pump treatment. This is the well-known EuroINF2 study where we compared DBS, LCID, DOPA, and apomorphine to each other. And what we see is the effect size in the figures here, and an effect size of more than 0.5 is a big effect, a large effect. It was an open-label prospective observational study, so it was not randomized. In 173 patients with DBS, 33 with LCID, and 39 with apomorphine. And what we can first of all see is that they all have a very nice effect on UPDRS-4 as a sign of stabilization of motor fluctuations. But they also have a nice effect on the non-motor scale total score. And if we look on the sub-scores of the non-motor scale, we see that there are some differences in effect between the three treatments, where we see especially good effect on sleep with duodopa, LCID, and with DBS, and on mood with LCID and apomorphine. And all of this results in what we see at the top, an improvement of health-related quality of life according to PDQ-8. And this improvement seems to be similar with the three treatment options, DBS, LCID, and apomorphine. So nice effects on motor and non-motor symptoms, but there are also other good things with the advanced therapies, and one of these you can see here. It concerns impulse control disorders. As you all know, impulse control disorders can be a big problem when treating Parkinson, especially with peroral dopamine agonists. And we have learned now that with the pump-based therapies and with DBS, the risk of impulse control disturbance is very low. So low that, for example, the German guidelines now for Parkinson treatment, they say that when you have impulse control disorders, first step is, of course, to reduce dopamine agonist, but second step can be to think about advanced therapy, because that can be part of the indication for advanced therapy if you have impulse control problems. So many effects on motor and non-motor and side effects, and all of this results then often in improvement of the quality of life for the patients when they move to advanced therapy. And this improvement seems to be of a similar degree with apomorphine, LCID, and STN-DBS. So it's important to realize when the patient is in need of advanced therapy. And this is not always so easy. You see the patient repeatedly, and you can easily miss that now is probably time to think about advanced therapy. So over the years, we have developed a couple of algorithms to improve the sensitivity for detecting this. We have the Navigate PD program developed and published in 2015. We have a Delphi program published in 2018. We have the Managed PD program, and there are several other such developments to be able to identify patients who need advanced therapy. The Navigate program was a program with 103 movement disorder experts from different European countries, and the idea was that they should agree on a consensus concerning how to handle advanced therapies. And the first and most important question there was, when should we think about advanced therapy? And this group of 100 experts agreed on the 5-2-1 rule, which is now quite well known, that when you have at least 5 doses of L-Dopa per day, and in spite of this, the patient spends at least 2 hours in off, or 1 hour with troublesome dyskinesias, that is the time point when we should think about advanced therapies. The Delphi program was then processed with 17 movement disorder experts using a Delphi method to reach consensus about advanced disease, what is advanced disease, and also when shall we use advanced therapy. So for advanced Parkinson, this is what the group thought, that it can consist of motor symptoms, but also non-motor symptoms, and also functional impairment that can indicate that the patient is now in an advanced stage of the disease. On the motor side, as you see, at least moderate level of troublesome motor fluctuations, at least 2 hours in off, at least 1 hour with troublesome dyskinesias, moderate level of dyskinesia, dysphagia, and oral levodopa at least 5 times per day. Again, we have the 5-2-1 rule coming back here. But also non-motor symptoms can, of course, make a disease advanced. And this includes not least dementia, but also hallucinations, psychosis, non-motor fluctuations, and nighttime sleep disturbances. And also functional improvement when, for example, falls and needing help with ADL, and non-ability to perform complex tasks, and impaired mobility can be things that make us feel that this is advanced. So what shall lead to advanced therapy then? Because that is not always the same thing. All patients with advanced disease should not have advanced therapy. But this was what the group thought that could indicate that advanced therapy could be a good thing. Troublesome dyskinesias in off periods, at least 2 hours in off, of period postural instability, dystonia, and freezing of gait during OFF can be indications for advanced therapy. But also sleep problems in the night can contribute to the decision, and also impaired ADL. There are now more advanced algorithms around. AbbVie has developed the Manage PD tool, which you can find on the web under managepd.com. So this is a tool where you answer a number of questions concerning the patient you have in front of you, and then the system will tell you, is the patient well treated or not so well treated, would need modifications, and is the patient good for advanced therapy. So this is another algorithm that can help you finding the right patient for advanced therapy. And of course, also monitoring of the disease with accelerometer-based instruments like the Parkinson kinetograph, PKG, or PD monitor, or there are many others on the market now, can be helpful to see that the patient really has motor fluctuations and maybe dyskinesias in front of the decision to use advanced therapy. So to summarize, advanced Parkinson's disease can have very substantial negative effects on quality of life, both for the patient and the caregiver, but advanced therapies can then offer improvements in many areas that are covered by Ray Chowdhury's dashboard, including then stabilization of motor fluctuations, improvement of dyskinesias, but also improvement of many non-motor problems, especially sleep, fatigue, but also mood, and also gastrointestinal symptoms and several others. And thereby we can offer an improved quality of life for patient and caregiver. And I think a key to success is to identify the suitable patients at an early time point and start the therapy. Thank you very much for your attention.
Thank you, Professor Odin. Great lecture. I think they keep the question for the rest of the session. Yeah, at the end, as we are behind the schedule. So our next speaker is Dr. Guy Chuang-Fei. He will speak about gastrointestinal dysfunction, Parkinson's disease. Dr. Fei is a lead of Department of Gastroenterology in King's College Hospital, London. Dr. Guy, please.
Good morning, ladies and gentlemen. Thank you very much. The Parkinson's disease is thought to be a disease mainly of motor complications, but actually it's a systemic, a multisystemic disorder. And one of the main systems affected in Parkinson's disease is the gut, and I'll show you why that is in next few slides. As you know, gastrointestinal dysfunction is one of the most common problems in Parkinson's disease, and it's common in all stages of Parkinson's. In fact, at 4 years of diagnosis, up to 2/3 of patients will have some form of gastrointestinal problems. And it starts all the way from the top of the mouth, all the way down to the colon. In the mouth, as you can see, you can get reduced swallowing, and as a result of people get excess salivation and drooling, which can affect the perioral mucosa. As we heard yesterday during the talk, it's quite common for patients to experience a lot of oropharyngeal dysphagia, which can lead to problems with aspiration pneumonia, acid reflux, gastric problems such as dyspepsia, indigestion, or H. pylori, which I'll mention in a little while, and also gastroparesis is relatively common, and I'll explain the reasons the reasons how that affects Parkinson's disease. The small bowel is intimately affected, and I will again show you how that is in terms of bloating symptoms, but also dysbiosis, which can lead to problems and problems with Parkinson's and drug absorption. And yesterday, again, we heard from the patients malnutrition and weight loss is a problem, not just of calorie deficit, but also of the nutritional, such as vitamins and minerals. And finally, the colon, which is the most common symptom affected in terms of constipation and defecative problems. So together, all these symptoms can lead to significant reduction in the quality of lives of Parkinson's disease patients, and also an increase in their disability. So H. pylori is a very common bacteria that lives in the stomach. It was only discovered, all the peptic ulcer has been present for many, centuries. It's only discovered a few decades ago, and actually won the discovery of the Nobel Prize for Medicine. And it's common and causes a lot of disease states. And it's actually relatively common in Parkinson's. Between a third to 2/3 of patients with Parkinson's will have H. pylori. Often it's silent. And in fact, studies have shown that in patients who have H. pylori infection, they're more likely to have Parkinson's, develop Parkinson's disease versus matched controls. So whether there's an etiological background behind this, and multiple studies have shown that if you have H. pylori in a patient with Parkinson's, they have a poorer motor outcome, a worse scores, and poor response to medication. And also, most studies, again, have shown that if you do eradicate H. pylori in Parkinson's patients, there's improvement in their clinical outcomes. In fact, 4 out of 5 studies have shown this. There's one negative study, but in most studies have shown there's an improvement. So I think it's worthwhile noting that it is a relatively common infection in patients with Parkinson's disease. Doesn't always cause symptoms, but it's associated with the poorer outcomes and poorer response to medication. And most studies have shown that if you do eradicate H. pylori, you will actually improve the outcomes in Parkinson's disease. And it's very easy to do this by using test and treat approach. So you test for H. pylori by doing either breath test or stool antigen test, and then you treat it over the course of antibiotics, 2 antibiotics and a PPI for about a week to 10 days. But apart from the problems with Parkinson's disease that it causes, it's also associated with significant problems with gastrointestinal tract. For example, you can see it causes a lot of gastric ulceration over here, which can lead to bleeding and ultimately cancer over here on your left, on my left. So I think it's worthwhile bacteria to one, look out for and to eradicate. And most gastroenterologists believe that the only good H. pylori bacteria is a dead one. So delayed gastric emptying, I think this is a significant problem with patients with Parkinson's disease. It can cause a host of symptoms which are very non-specific at the top over here, such as nausea, vomiting, lack of appetite, reflux, abdominal pain, and bloating. And also the systematic reviews have shown that over a third of patients with Parkinson's disease have gastroparesis, whether they experience symptoms or not, they have this condition. And what it does is that it leads to an unpredictable delivery of the drug to the small bowel where the drug is absorbed. So therefore, patients, when you give them the drug, they may have a long on before they have the on time because the drug is delayed into the stomach before it reaches the small bowel. And that can be associated with sort of problems with motor fluctuations as well as off states. So as you know, with Parkinson's disease, on your left over here, you can see as the disease progresses over time, the actual therapeutic window for the medication gets much smaller. So therefore, even if you did increase the medication dose, you're more likely to get dyskinetic effects or more off time. So it's actually harder to stay within that narrow therapeutic window in patients with advanced disease, which is where the gut comes in. So what we do with patients with intrajejunal levodopa infusion is that we deliver the drug directly into the small bowel where levodopa is absorbed. It's absorbed in the proximal small bowel in the duodenum predominantly. So we put a normal PEG tube, gastrostomy tube, which we use for feeding, and through that we pass a small a small jejunal tube which goes directly into the proximal small bowel, and there we can deliver the drug at a very precise dose to stay within that narrow therapeutic window without causing too much sort of dyskinetic by giving them too much drug, and without being off by giving too little drug. So it can stay within that narrow therapeutic window. As you can see over here on the graph here, so the point is not working. So the top part of the graph is, and the little round circles is the intrajejunal levodopa. You can see you have more on time with the drug and less off time as well by the using intrajejunal levodopa compared to a liquid levodopa. So I think it certainly improves the on time without with less off time, and reduce the dyskinetic problems. And in fact, in one of the first papers which published with Professor Chowdhury some 15 years ago, we showed that as well as significant motor improvements you get with patients who have with intrajejunal levodopa, you get a corresponding improvement in their non-motor scores, and also improvement to the quality of life. In fact, this was one of the first papers to show this effect of on non-motor improvement scores. Next, we come to constipation. This is the most common problem in patients with Parkinson's disease. And this is what Dr. Vinod Mehta likes to refer as his Burj Khalifa moment. So as you can see in the X-ray, the patient has got a lot of fecal loading, both on the left side of the bowel and on the right side of the bowel as well. So I think when the patient is so sort of constipated and fecal loaded, the whole gut transit is delayed and there's a problem with drug absorption. But I think it's more akin to like one of the traffic jams on the Sheikh Zayed Road, or whatever the main highway, the Saudi causeway over here. But if you have a standstill of traffic, then none of the gut moves. You get a backlog all the way up into the small bowel, which can affect constipation. So I think it's important to identify and treat constipation. And it's the most common symptom in Parkinson's disease patients. Up to 50% of patients are affected by constipation. And what's interesting is that constipation can actually predate the onset of Parkinson's symptoms by up to 10, 20 years. And it's not clear why the mechanism is. Could be due to lots of reasons. It could be due to the dysautonomia that we heard a lot of patients have. It could be due to the medication they take, which have a constipatory effect. It could also be due to other factors, such as a lack of mobility and maybe the diet. But constipation, and this is a paper we published a few years ago now, shows that actually if you have constipation at the time of the diagnosis of Parkinson's disease, you are more likely to develop cognitive impairment later on in the course of the disease of Parkinson's. So I think there was a strong analysis, strong association in 2 international cohorts, independent cohorts. So the treatment is to make sure they have a lot of fiber on board, lots of fluids, and the use of laxatives as needed. However, I must caution you as a gastroenterologist is that if a patient has new onset constipation, particularly in elderly patients, other things can become more common, such as colon cancer, and you should actively think, could this be colon cancer? And the way to do that is to try and do either FIT test, which is a fecal occult blood test to look for presence of blood in the stool, which would alert you to something else going on, or refer to a gastroenterologist. So this is a very topical area, and there's a lot of research into this. And the reason is because of this. In your gut, in your microbiota in the gut, it accounts, there's about 10 to the 13 bacteria that lives in your gut. And in fact, the total number of cells in your body is only 10 to the 12. So you have more gut bacteria than you have cells in your body. And in terms of the genome expression, the genes expressed in your gut is far, far in excess of what the actual genomes that you actually express as a human being. So I think this is crucially important in terms of lots of other disease states. And as I said, this can be, the quantity of bacteria can vary, the quantity and also the composition of bacteria can vary depending on which part of the gut, from the stomach, small intestine to the colon. And also, your gut bacteria is a very unique, each one of you has a very unique gut bacterial fingerprint. It's like a fingerprint, it's unique to you. And it's determined by a whole host of different things. For example, the genetics, who your parents are, where you were born, which part of the world you were born, whether you were born by cesarean section or natural delivery, what your diet is like, whether you have other factors in terms of physiological factors, gastric secretions, your immune system, your motility, how old you are, whether you take antibiotics or not, whether you're under a lot of chronic stress that can affect your gut bacteria, whether you have when you do exercise. So all these things can interact. And the gut microbiota is thought to be involved in not just Parkinson's, but a lot of other disease states, cardiovascular disease, inflammatory bowel disease, obesity, type 2 diabetes, and as well as thyroid problems. So it has a lot of, possibly a lot of implications, a lot of disease states. So how does the gut affect the brain? Well, there's the main superhighway, which is the vagus nerve, connecting the gut directly to the brain. But also there are a lot of the ways which the gut can interact with the brain and vice versa, such a lot of the cytokines, a lot of the small molecules which can go through the bloodstream and lead to changes in the brain. So there's this thing called Brack's hypothesis, which suggests that Parkinson's disease may actually originate from the gut. Although it is a disease mainly of the brain and the nervous system, it may actually originate in the gut. And the reason for this is because the actual marker of Parkinson's disease, the alpha-synuclein, is expressed throughout the gut, even in healthy individuals. And in patients who have prodromal Parkinson's, before they develop Parkinson's disease, there's an aggregation of these alpha-synuclein markers in the gut versus those who don't develop Parkinson's. And it's been shown that if you have a lot of dysbiosis or sort of like inflammation in the gut, you can accumulate these markers. And also a lot of data, both experimental and animal data, have shown that you can actually induce some form of Parkinson's disease in patients, either by injecting these molecules into the gut, which then cause a Parkinson's-like syndrome in the brain, or in knockout mice who don't develop Parkinson's disease if they're brought up in a germ-free environment, but if they're brought up in a normal environment where germs are present in the diet, they develop a Parkinson's disease condition. And also, this one was interesting in transgenic mice who've been bred to develop Parkinson's disease. If you transplant stool, feces from patients from Parkinson's disease, these are real patients, into these mice that develop Parkinson's-like syndrome, whereas if you transplant stool from non-Parkinson's patients, they don't. So they suggest there is actually something going on in the gut which could predispose to Parkinson's disease. So what are these changes? Well, I won't go through all the details because it's a very complex area and also very confusing, but essentially what they found when they've done these meta-analyses of the gut microbiome is that there's a reduction in these bacteria which are producers, the butyrococci and the ruminococci, which are producers of these butyrate and short-chain fatty acids, which are anti-inflammatory and sort of chemicals which have a beneficial effect in Parkinson's, but also in a lot of other disease conditions. And so how can this actually affect someone with the brain if you have dysbiosis in the gut? Well, this is an interesting study. It wasn't in Parkinson's disease, but it was a condition which is strongly associated with Parkinson's, in other words, dementia or cognitive impairment. So what they did was they got 140 healthy individuals, these were in the sort of framing of a heart study, and they analyzed their gut microbiota, and also they did the PET scans to look for these amyloid and tau proteins, which are markers of dementia or cognitive impairment. And what they found was that when they did multivariate analyses, is that patients who had these expression of these proteins in the brain were more likely to have lower levels of these butyrococci and the ruminococci, which I've shown you before is prevalent in Parkinson's disease patients. So therefore, we know that these are producers of butyrate short-chain fatty acids. So therefore, a buildup of amyloid may be due to these changes in the gut. And so this is a study which is actually now in press with, led by Professor Chowdhury, but published by, led by Valentina Letta. And this is looking at probiotic. Can a probiotic affect Parkinson's? Can you give something into the gut to actually have a beneficial effect of Parkinson's? And this is a probiotic called Simprove, which has been originally developed in veterinary medicine, but actually found to be beneficial in humans, both in inflammatory bowel disease and IBS. And we tested it in Parkinson's disease as a randomized, controlled, double-blind, placebo-controlled study. And what we found was that by actually giving patients this probiotic, you were actually to change the composition of their bacterial composition in the gut. And that led to a pro-inflammatory environment in terms of reduction of this inflammatory cytokine anti-TNF plasma. Plasma levels were noted for patients who had the probiotic. And also, the benefit to Parkinson's disease patients was a reduction in the time to on, and also an improvement in the non-motor scores. So as you can see over here, so the improvement in non-motor scores driven mainly by things like sleep, fatigue, and gastrointestinal symptoms, and the on time was improved. What about if you went even further, if you did fecal microbiota transplant? Now, that sounds disgusting, especially after breakfast, but these are patients who you would actually take healthy stools from patients with healthy patients and transplant them into disease states. And it's very, very effective of conditions such as Clostridium difficile. This is a condition where you give patients antibiotics, they develop a diarrhea, and then you try lots of antibiotics, but often the antibiotics fail or patients get a recurrence. But the most effective treatment in antibiotic-resistant Clostridium difficile infection is a fecal transplant. And so it works very, very well. So can you do this in Parkinson's disease? Well, actually, there has been quite a few studies, but these are the two more notable ones. The first one was published in the New England Journal last year, and they looked at 46 patients, 22 and 24 in each group, and they infused the fecal transplant via an NJ tube, and either through healthy donors or their own stools. And they noticed at 12 months there was an improvement in the UPDRS scores in the healthy donor samples as opposed to the placebo group. However, there was also a negative study which showed that although it was safe and had minor side effects in terms of symptoms, it did not improve any of the symptoms. But there was a meta-analysis looking at this, and they looked at about over 150 patients, and in fact, 4 out of the 5 studies have shown an improvement, that it was well-tolerated, safe, and also relieved Parkinson's disease symptoms. So, but I think these are early days and larger studies that need to see whether this is something which is viable. So this is something which I think a lot of people have heard of in other states. This is the so-called GLP-1, glucagon-like peptide 1 receptor agonists, which have really taken the world by storm. These are the new weight loss medicines, and I'm sure you've heard about them, the Ozempics and Mounjaros of this world. And in fact, some the very famous people, well, everyone's on it, even the most famous people. This is one of the most famous successful tennis players, Serena Williams. As you can see, she's admitted to the use of Mounjaro, and she's lost a significant amount of weight, which she was never able to do, even when she was a top athlete, #1 in the world, and I think she's got 23 or 24 Grand Slams in the world, which is one of the top women players in the world. So these drugs are highly effective in weight loss. And also, coming to you very soon, as well as having injections, which used to have once a week, now we have it in tablet form, available in tablet form. So I think this will increase the market for these drugs. Now, can they be effective in Parkinson's disease patients? Well, certain preclinical studies have shown in mouse models that they are effective and neuroprotective in Parkinson's disease patients. And this was a double-blind phase 2 study, placebo-controlled study, where they have daily injection of this GLP-1 agonist called lixisenide, which showed in 150 patients, which showed that at 12 months, there was a reduction in the progression of Parkinson's disease in patients who had the injection versus those who didn't. And this persisted even after the drug was stopped. But the main problem with this is, as you are aware, they can cause side effects, and the main side effects are GI, because it causes nausea, vomiting, and diarrhea to some extent. And I think that's just how the drug works. When you take the drug, they make you feel full. They send signals to your brain to say, you've had enough to eat, stop eating. So these side effects, although they work, they're very effective for weight loss, may not be acceptable for patients with Parkinson's disease. But there was also a negative study which showed that this drug was tolerated but didn't have any effect on Parkinson's disease. But again, when you do the meta-analysis, there were 4 randomized controlled trials looking at 3 different forms of this medication with a total of 500 patients. And on the whole, they found it improved their motor function during the off time, but didn't show an improvement in quality of life. So it does show there's possibly, again, some benefit, but again, you've got to balance that between the cost of the drugs, side effects profile. But I think this is something which I think is worth further investigation. So final thoughts, I think GI symptoms are very common in patients with Parkinson's disease, and I've shown you the gut is very intimately involved with the brain, particularly in the pathogenesis of Parkinson's disease. And can we identify any specific bacterial or environment which actually predisposes to Parkinson's disease? And can we actually alter the gut some way which actually will benefit patients with Parkinson's? And I think the gastrointestinal tract shows a novel aspect, a way of treating Parkinson's disease patients. And I think there are certain promising candidates, as I've shown you earlier. So really, I just would like to thank my colleagues, Professor Chowdhury, Dr. Vinod Mehta, who together, we've gone on this journey for a while now. But also, I think this is very supported by our team who helped with the work. All the nurses, Teresa, Clara, Afsal, Kamar, and all the other team who helped support this work. And of course, Ms. Kimberly Pierce, who's been supportive of our work throughout her time at King's. And finally, I'll leave you on this note that, we all know how Dr. Vinod, how energetic, how intellectual he is, but where do you think all that is coming from? It's coming from the gut. Thank you very much.
Thank you, Dr. Fay, for this very important topic. So we heard gastroenterologist's perspective on Parkinson's disease. And now it gives me a great pleasure to introduce Dr. Samir Hassan Naik, which is a consultant pulmonologist from King's College Hospital, Dubai. And now we will have incredible opportunity to listen the pulmonologist perspective on Parkinson's disease. So Dr. Naik, the stage is yours.
Thank you very much. Till they set up my slides here. Good morning, everybody. Now, we had a very first 2 lectures telling you about advanced Parkinson's, various treatments, and what happens to the guts. Now, we'll move between the brain and the gut, that is the lungs. Now, what has lungs to do with Parkinson's? We know that brain is the bandmaster of the whole organ system. So anything not functioning well in the brain obviously does affect our whole other systems as well. So I'll try to keep it brief. We get mostly involved in the later stages of Parkinson's. So the better treatment, the better care a Parkinson's patient gets, the later they end up coming to us. So that is just, I will give the introduction till my slides are up here. Okay, thank you very much. So I don't want to go into the history because I'm sure because there's more of advanced Parkinson's. The essay on shaking palsy by James Parkinson's already Dr. Vinod Mehta in his talk yesterday has told. What is important is that respiratory disorders are very common in most of the Parkinson's disease. And what happens with this is they lead to reduced quality of life, frequent hospital admissions, and more morbidity and early mortality. That is what we need to look at. And the alterations associated are mostly in the form of mortality. Half of the Parkinson's patient eventually succumb to the disease due to the complications that lead to respiratory ailments, especially aspiration pneumonia, sepsis, and death. So it's a complex disease. We know that lots of things are affected. Predominantly when it comes to respiratory system, it's the aspiration pneumonia, the dysphagia, and the sleep disordered breathing, along with restrictive and obstructive lung disease, apart from all other things that we. Now, the dysfunctions, is it peripheral or is it central? Now, it is basically a combination actually due to the muscles of breathing that are involved, including vocal cord, how your upper airways are designed, and central due to the brainstem nigrostriatal pathway or limbic pathway system that regulates your breathing and everything. What is the prevalence? The prevalence ranges in various studies they have done. It can as low as 7% to almost 70%. And we have obstructive as well as restrictive changes that can change depending upon what study you're looking at, how well controlled it was. But the worst thing is the mortality from aspiration pneumonia is as high as 70%. Most of the patients have respiratory dysfunction even when they are well. You might not realize that. That is, you might think they are slow, they are sluggish. Are they feeling breathless? Is it just a subjective symptom, or is it something else going on there? That's important. And when they are asymptomatic, it's necessary for us to look out for those things, diagnose early so that we can materialize. Now, Dr. Guy clearly mentioned there is a lot of gastroparesis and other things that itself can lead to microaspirations, that can lead to inflammation, and that can lead to subjective breathlessness, breathings. Again, oropharyngeal dysphagia, constriction, obstructions, these also make their quality of life, day-to-day activities difficult, that stops them from doing what they want to do. Right time medication is the main key cursor. They don't take medications, they don't eat, they don't perform, they don't exercise. That leads to deconditioning, and it becomes a vicious cycle, making their life more difficult. Again, now, as I said, the cause is neurodegenerative dysfunction in the medulla oblongata, and the etiology of the respiratory dysfunction is related to the lung volumes and the ventilatory capacity that gets affected as the patient progresses in his disease. This is a very complex network that we know that it's very difficult to understand God's creation, how what works where. We try our best to correlate one to another, but for example, Dr. Guy said about Monjaro and Ozempic, and I was thinking, hang on, they themselves cause gastroparesis, and we don't want gastroparesis. So that is the balance. It's difficult to understand where exactly what we are going to do. What are the different symptoms they get? Coughing, obviously, it all depends upon the salivation and other things, irritation of the airways, dyspnea or feeling of shortness of breath, pneumonia and aspirations. Exercise tolerance is significantly reduced, not only because they have difficulty in initiating movements or working, but also because the obstructive and restrictive element in the airways reduces their oxygenation. Speech modifications, voice hypophonia, and whenever there is a lot of aspirations and other things, you've got atelectasis leading to reduced ventilatory effects, reduced oxygenation, and eventually sometimes they can retain and go into type 2 respiratory failure as well. So there are lots of studies being done on the symptomatology, and about 35% of patients did experience shortness of breath on exertion. We had about 18% who reported cough, and these are mild to moderate patients, not the severe ones who are not moving much, getting recurrent infections or anything, and people did have productive cough as well as a part of that. As there is decreased level of activity and sedentary lifestyle, these people don't express their symptoms. As the disease progresses, you find that they are most bed-bound or chair-bound, and they don't do much. As a result, they don't come and tell you, or that is reported that, oh, I get breathless unlike any other person. Shortness of breath is very common, and we have seen that all the advanced treatments ensures the continuous delivery of dopamine to keep the on effect. Now, the minute the patient gets this wearing off effect, these people get more short of breath. So a regular medication which keeps them into the on effect is very important to reduce the subjective feeling of shortness of breath. And we can see that the minute they take medications, they start feeling better. As the medication wears off, when they're taking oral medication, they start getting more symptomatic. And that is one of the things. Dyskinesia is also very common, and they start having this rapid, irregular breathing, huffing sometimes, and the speech, because it's affected, the monotonous order of speech, you think like, okay, you can't differentiate between are they trying to say something or their speech is getting affected, and you can't speak properly because of the dysphonia that they get in addition to that. This is also associated with anxiety. These people get very anxious, and it's like stammering. You know that stammerers tend to not to talk because they feel embarrassed. Sometimes they also, most of these patients are older, not like kids and other things. So they start getting anxious that, okay, if I'm going to able to complete my talk or speech or what I'm going to say, that can be, so anxiety also makes them breathless. Aspiration pneumonia, again, advanced Parkinson's, they have difficulty in swallowing, end up with lots of aspiration, resulting in choking and eventually death in many cases. So non-PD health issues are also common, depending upon what their lifestyle was, whether they're exposed to a lot of environmental dust, smoke, cigarette smoke, smoking habits, allergies, asthma, they coexist. They have heart conditions, heart failures, congestive cardiac failures, all these things. So we also need to parallelly look at non-PD related medical conditions that contribute to respiratory symptoms, be it COPD, asthma, bronchitis, allergies, and also I'll come to sleep apnea a bit in that. Now, speaking and swallowing impairment is very important, though it's not respiratory, but we all consider single airway, single disease here. So asynchronization of the normal speaking and swallowing is one of the main reasons with pooling of secretions that leads to aspiration. So they have hypophonia, they have lots of sleep disordered breathings with increased somnolences during the day. So this needs to be looked at. Sometimes we think, oh, they have a sedentary lifestyle, they're just sitting there doing nothing. That might be the reason. But on the contrary, they might not be sleeping well. They might have a lot of hypoxic burden at night due to obstructive sleep apnea. And that is the reason they are sleeping. Actually, we need to look at that. And eventually, they can also go into respiratory failure due to restricted defect, obstructive defect, and sleep apnea with all these combinations, in addition to other comorbidities they may come across. Perioperatively, or any patient who needs any surgical interventions, one of the risk factors is difficulty extubation. So anesthetists always need to be careful, look into their Parkinson's history, how bad it is. If they're going to be kept nil by mouth, what are the things they're going to look at, and the chances of difficult extubation, consideration of NIV during weaning, that is what we need to be looked at before we consider. Even for day cases with deep sedation, we need to always think whether this person might need HDU after the procedure rather than just come to the normal routine post-recovery wards. So upper airway muscular is affected. There is also impairment in airflow, which can be revealed to obstructive spirometry. Again, they have different types of postures that contribute to restricted defect, sometimes obstructive defect, like scoot posture, camptocornea, chylosis, and scapholysis. Chest wall volume and asynchronicity. As I told you, they have both a restrictive and obstructive defect, and all these things do contribute to their unsynchronized contraction of the respiratory muscles. More importantly, medications. Effects of ergoid dural therapy are a risk factor for restrictive function in Parkinson's. So medication itself, on one hand, sometimes can contribute to the symptoms of respiratory system. Obstruction, again, prevalence is between 7 to almost 70%, leading to airway limitation, and that can lead to retained secretions, atelectasis, aspiration pneumonia, which can be fatal. Tonic activation of the adductor muscles can lead to decreased laryngeal diameter, and this is also related to upper airway, leading to reduced peak flow meters, and many of them, they have a FVC of 50%, suggesting there is a restrictive element as well. Lower respiratory tract system is the same. Prevalence of breathlessness is almost 40%, and it correlates with the severity of the disease. The bad the disease goes, the worse it is. And mechanism is, again, all the combinations as I told you. And all these things lead to decreased quality of life in this group of patients. Speech, I'm not going to go into the details. It affects the quality of life. It affects about 2/3 to almost 4/5 of the patients, leading to different kinds of speech. Some high-tone, low-tone speech training has observed to give them better quality of life and improve respiratory outcomes as well. Expiratory muscle strength rehabilitation improves cough regeneration, swallowing capacity, and reduces aspiration. As I told you, 80% of patients, they develop dysphagia, and this appears at least a year after the onset of disease, and the symptoms of dysphagia approximately, patient realizes takes about 10 years. Survival period once they develop dysphagia is 1 to 2 years. This is like a death sentence when a person starts aspirating due to dysphagia. You know that there will be frequent hospital visits. We can consider the prophylactic antibiotics, safe feeding, consider parenteral feed, NG food or NG feeding, depending upon, and this is the group where we can't even consider prokinetics to just give the things like metoclopramide, domperidone are contraindicated, as you all know there. So it's present in half of the patients, aspiration pneumonia, and silent penetration and aspiration is the commonest cause that leads to this. This is the principal cause of mortality in Parkinson's disease. As I mentioned in my start of my talk, that these people end up to us as pulmonary physicians when the disease is too late. Sleep disordered breathing, again, this is very common due to fragmented sleep, poor quality of sleep. They have restless leg syndrome. Yesterday in the talk, we were talking about this, what is happening there, and they can end up with respiratory failure, REM disorder, breathing as well. It's a very important component. Sometimes by diagnosing sleep apnea and treating them sleep apnea gives them a good daytime. They're more awake, they're more alert, they get their medications on time, they do their physio and everything regularly. So central dysfunction is the common cause in many of these patients with brainstem pathology, and main treatment is CPAP, most of these things. And there are different studies done to this, which shows beneficial effects in non-motor symptoms globally. Now, medications itself, levodopa enhances the quality of breathing itself, but other medications can produce dyskinesia. So balancing is very tricky in this group of diseases. Very rarely with bromocriptine, you do get pleuropulmonary fibrosis leading to further restrictive lung disease. They have dyspnea, sometimes pleuritic pain, and cough are the side effects. Infiltrates and effusions, we do see sometimes in groups of these patients, majority are secondary to aspiration pneumonia and infections. So to conclude, Parkinson's is commonly associated with pulmonary impairments. Dysfunction, respiratory dysfunction remains most common cause of death in patients with Parkinson's disease. Most important on patient's life is significant, and then the patient's quality of life is significant, and it represents components of mostly the neurodegenerative disease instead of distinct disorder as such affecting the lung. Treatment should become considered to improve pulmonary activity, prevent and actively treat aspiration pneumonias, treat obstructive sleep apnea, speech disorder, and symptomatic treatment. Greater awareness of respiratory dysfunction in Parkinson's is necessary to pick the symptoms earlier, do screening tests, and prevent complications. We need to ask about respiratory symptoms specifically and look out for that rather than wait till the patient presents with frank conditions. Thank you very much. Thanks for your patience here. Happy.
Thank you, Dr. Samir. We will have questions at the end of the session. Right. So next speaker is Dr. Rukmani Mridula. She is a senior consultant in Hyderabad, a very well-known figure in India, well-published, a lot of articles on movement disorder. She's going to talk about urinary dysfunction in Parkinson's disease, neurogenic, urogenic, or both. Dr. Rukmani, please.
So thank you, sir, for your kind introduction. At the onset, I'd like to thank Dr. Vinod Mehta and Professor Ray for giving me this opportunity to be present here. It's an exciting moment. I am really glad that we have people interested in movement disorders. So this one. Yeah. So I'll just start with a case scenario till the presentation is on. So this is very common actually. Urinary dysfunction is fairly common, and it's something which everybody thinks that there is, it's probably related to urology, older age, and then you know that there is some amount of neurological dysfunction because of Parkinson's disease itself. So you have a patient who is Parkinson's disease patient who comes up with complaints of urinary dysfunction, and he says that there's increased frequency of urination 8 to 10 times per day in 1 year, nocturia 4 to 5 times, no history of urinary incontinence, dysuria or pain, and he has a history of slow stream but able to completely evacuate his bladder. So this is very common scenario. So what we think is that you look at other comorbidities, look at hypertension, diabetes, look for neuropathy, you have look for medications that he's on. A lot of times when you have hypertensives, you put on diuretics, make sure that they are not on diuretics. Patient is well controlled in motor symptoms, has got with 5 doses of levodopa. Complete urine examination is normal, there's no urinary tract infection, ultrasound abdomen is quite good. You have a mild prostatomegaly. The post-void residual urine is around 60 ml. Normally, up to 100 ml is considered okay. So if you have more than 100 ml, that means that there is some amount of obstruction. In some patient, you may think about 200 ml also, but it's 100 ml usually. So this is a patient with Parkinson's disease with urinary disturbances secondary to Parkinson's disease itself. Now, urological problems have been described since 1817 by James Parkinson himself, and we know that it is, just like you have already heard that there are gut problems, there are respiratory problems, and obviously there are urological problems in Parkinson's disease. And you have multiple subtypes which have been very well described by Professor Ray Chaudhary. As are the motor subtypes, you have non-motor subtypes, and urinary dysfunction typically falls into the autonomic dysfunction period. Now, it's one of the most common autonomic disorders seen in Parkinson's disease, and this was the first study where you had almost 55% of people had urgency, and more than, 60% had nocturia. And this is something that we have also seen in our studies, where we've seen that urinary disturbances are quite common, maybe around 70 to 80%. And it also changes as the duration of the disease increases, and you get more and more. And this was a recent study which has been done by Dr. Asha Kishore, and we are all a part of the whole group, where we have seen around 10,000 patients with Parkinson's disease, looking at the genetic background. And same here, if you look at the urinary incontinence, so if you look at the urinary incontinence is very common in patients who are men. It's more common in patients who have got PIGD dominant patients, as well as patients who have got late onset Parkinson's disease. So if you look at the urinary tract symptoms, you can actually divide it into irritative, obstructive, or mixed. Most common is irritative. 2/3 of them are irritative. Normally it is thought that Parkinson's disease produces an overactive bladder, but it is not always true. You can have an obstructive symptom. Nocturia, frequency, urgency, urinary incontinence are all irritative symptoms, whereas the obstructive symptoms include hesitancy, incomplete evacuation, poor stream and straining, and you can have combination of both. And if you look at the prevalence of the urinary tract symptoms, the lower urinary tract symptoms, or the symptoms of urinary urgency, nocturia are much more common, overactive bladder are much more common than that of the retention problems. So are there any associations with urinary problems? Yes, urinary urgency is definitely more common, can happen in the premotor phase, but it is associated with older age as well as with higher motor disability. So people who have urinary disturbances tend to have more cognitive decline faster. They also tend to have more severe motor symptoms as they progress a little more faster. What's the pathophysiology? Still, we are not sure so clear. We know that there is a cholinergic innervation from S234, as well as which facilitates voiding by causing detrusor muscle contraction. The adrenergic innervation from T1 to L2, which inhibits the parasympathetic stimulation by acting on the beta-3 receptors, and urethral contraction by the adrenergic alpha-1 AD receptor. This is the lowermost part of the urinary flow, and when we look at where in terms of the brain, the pontine micturition center as well as the cortical centers work on these two aspects, the parasympathetic and the sympathetic outflow, and then you cause voiding as well as retention. I will not go too much into detail. I have been asked to cut my talk short by 5 more minutes. So what I want to say is that the effect of basal ganglia on micturition is thought to be inhibitory. So the D1 pathway is inhibitory, And PD causes, that's why it causes overactive bladder, because you have a loss of the inhibition of the bladder. This is just a very rough idea. So if you have a patient who has got Parkinson's disease and bladder dysfunction, you have to assess the bladder function to say what kind of bladder dysfunction they have. So you look at the comprehensive history, make sure that you take whatever drugs that they are taking, look at nocturia, look at the medical comorbidities which can contribute to urinary dysfunction, and then you use the medication which are used. There are multiple questionnaires which are available to assess the urinary dysfunction. What is very important is that you have to have a bladder diary. The reason why I'm saying that there is a requirement for a bladder diary is that there are two components when you have nocturia, which is very common. It could be just nocturia or nocturnal polyuria. The definition of nocturia itself is very vague. A lot of people use it a lot of studies have used multiple definition, but what is commonly used that even if you have to get up one time in the night, it's called as nocturia. So one time or more, it's called as nocturia. Nocturnal polyuria is increased production of urine in the night, and this is more than 33% of the whole 24-hour urine output during sleep in elderly, or more than 20% in younger patients. So if you have more production in the night, it is called as nocturnal polyuria, because the treatment will differ whether you have a nocturnal polyuria or you have a nocturia. You look at the physical examination after you figure out what are how the bladder diary is, and then look for motor symptoms, non-motor signs, autonomic dysfunction, look for orthostatic hypotension, other comorbid associated features which can help you determine that there is an autonomic dysfunction which is causing the urinary dysfunction here. How do you investigate? Look for complete urine examination. Anybody who comes with an increased urgency overactive bladder, make sure that you're not missing out on urinary tract infection. Look at ultrasound abdomen, look at the uroflowmetry, urodynamic flow studies, which can show you whether there is a normal functioning of the detrusor, overactive detrusor sphincter dysenergy, all of which can then help you in treating. So treatment is individualized. Obviously, it depends upon what kind of dysfunction that you have. Treat the comorbid condition. Do a lot of changes in their fluid intake. Make sure that they're restricting to morning times. Reduce alcohol, caffeinated drink. Do a lot of bladder training. Exercises are there, Kegel's exercises, which can help them to prevent urinary urgency and urinary incontinence. And then you do a bladder scheduling. Look at how well the dopaminergic therapy is going on. If the patient is more off, they tend to have more urinary dysfunction. So dopaminergic therapy itself can help in urinary dysfunction in a lot of patients. Make sure that it is optimized. Rasagiline, one of the drugs, it's supposed to have an improvement in the increased volume, but we're not. Every medication has its own role. Subcutaneous apomorphine infusions can actually help improve the urinary dysfunction. DBS has also been used, seen that you can have increase in the improvement in the urinary dysfunction. So any of the continuous dopaminergic stimulation, if they are not well treated, would improve the urinary dysfunction. This is one of the non-motor symptoms actually very well corrected by all of the dopaminergic therapies that you have, which are available. In the oral drugs, estradiol, which is common recently, alpha-2 agonist can also actually, adenosine alpha-2 agonist can also help in reducing the urinary dysfunction. When you have all these all these are being titrated, and then patient comes to you with nocturia or urgency, overactive bladder symptoms, you don't have any evidence of detrusor sphincter dysenergia, you don't have any evidence of urinary retention. If you have a patient who's got a urinary retention, the only treatment option would be for them to go for self-intermittent catheterization. It really doesn't matter which medication you use, if it is pure neurogenic. If you have a prostatomegaly, obviously you can have medications which can help in reducing the size of the prostate. So once you're sure that there is no urinary retention and the patient only has an overactive bladder, the first drug that is best available is a beta-3 adrenoceptor agonist, mirabegron, which is commonly available. You can start the patient on 25 milligram at night and increase it to 50 milligram at night. The only side effect that you should be careful when you're using mirabegron is that the patient can develop supine hypertension with mirabegron. So make sure that the patient doesn't have a blood pressure fluctuation when you're starting the patient on mirabegron. Antimuscarinic agents have been used till date. A lot of them have been used, oxybutynin, tolterodine, sulfasenacin. These are the more selective antimuscarinic agents which can be used, darifenacin, phosphatidylene or trospium chloride. Now, the problem with antimuscarinics are that they can cause cognitive impairment, they can cause dry mouth, they can worsen the constipation sometimes. So you have to look at it and check again. Again, urinary retention can be a side effect of these medications, so be careful that you don't have a comorbid urinary retention. Alpha blockers can be used to treat the detrusor sphincter dyssynergia. Baclofen, benzodiazepine, dantrolene have all been used. Now, when you come to invasive procedure, botulinum toxin can be used to treat overactive bladder. You can use something called as a percutaneous or transcutaneous tibial nerve stimulation. You can treat with sacral nerve modulation. These are all methods which have been used to improve the urinary overactive bladder mostly. Sacral stimulation actually reduces, it is supposed to be even okay in retentive urinary dysfunction, but most commonly it has been useful in overactive bladder. It reduces the incontinence by around 70%. You have to look at the other comorbid condition, and it is important to know that if you have a patient who's got a concomitant prostatomegaly and benign prostatic hypertrophy, when the patient goes for surgery, it is important to tell them that the improvement may not be complete. So you have to evaluate them in detail before asking them for, advising them to go for surgery. I'll just end up with a small case scenario because it's something which we've come recently. I think Professor Rupam also had a mention of this. There's a 70-year-old patient who was operated with DBS 10 years ago, and he came with the complaints of gait disturbances with urinary disturbances and urinary urgency and urgent incontinence. The reason why I'm saying is that when you have a patient with Parkinson's disease and you're following up the patient for Parkinson's disease for a long time, or any patient who comes in and they say that, oh, they have been on medication and they're responding to levodopa, carbidopa, in spite of the fact that, that it seems like it is all Parkinson's related or urological related, don't forget the brain. Get an imaging done. You may be having a patient with normal pressure hydrocephalus, and this is a patient who underwent DBS, because when we do deep brain stimulation for patients with Parkinson's disease, we don't really think about them developing normal pressure hydrocephalus. But this is something which has been seen with patients with progressive supranuclear palsy, where when they have progressive supranuclear palsy, they can develop secondary NPH, which is a difficult call to make. But when you have a typical picture where you have the frontal, this is called as DESH, where you have disproportionate enlargement of the sylvian fissure or the sulcal spaces with the frontal crowding, you know that you're dealing with normal pressure hydrocephalus. And then the treatment of it is quite simple because you just do a shunt and the patient improves. This is the gait that I'm showing, but the other aspects also improved. And this was our publication where we actually saw a series of patients who had post-DBS had undergone NPH. So thank you for your patient listening. I think I finished in time.
Thank you, Dr. Mirdula, for this interesting talk. And now I would like to introduce the last speaker, the Professor Damija, Professor of Neurology and Director of Institute of Human Behavior and Allied Science from New Delhi, India. Professor Damija.
Good morning to all of you. At the outset, I must express my gratitude and thanks to Professor A. Chaudhary and Vinod Mehta and the local organizing team from Bahrain Specialist Hospital for inviting us and giving us this opportunity. We had an excellent session yesterday evening with the patients and caregivers, and we had lots and lots of questions, and some of the questions we hope to answer in our presentations today, and my talk is also related to the questions which were asked yesterday by the carers, the families and the patients themselves yesterday evening. This is an exciting because this is the first International Movement Disorder Conference being held at Bahrain, and it's my first visit, and I'm really excited to be here and looking forward to be here again and again for the benefit of our patients and scientific community. It's two-way learning experience. It's not one-way traffic. We learn from each other. And that is the way the science is there, and the benefit of science should reach the patient, which is the end user, and that's what we aim to do in our profession. So you just heard various aspects of Parkinson's disease in terms of some of them have been covered in autonomic dysfunction by Professor Medula as well as Professor Guy. My job is very simple. I have been given only 15 minutes, and in those 15 minutes I'll try to cover up only cardiovascular autonomic dysfunction in a patient with Parkinson's disease. It's a very common problem, and it's a very, very easily diagnosable, easily treatable. If we know, the only thing is we need to be aware of this, and just creating awareness is very, very important. I'll also start with a case vignette. This 68-year-old female right-hand dominant patient who was diagnosed with idiopathic Parkinson's disease. It's gone. So this patient is the known patient of Parkinson's disease and has been having many symptoms. Can we have my laptop if there's a problem? So once you have the advanced Parkinson's disease of 8 to 10 years of duration, you tend to get all the complications, and managing advanced Parkinson's disease is a skill. And that skill is very, very important because these complications tend to reoccur, and some of them are potentially manageable. I can have my own laptop. Just a moment. Laptop shut down. Just a moment, sir. Thank you. This up and down. Okay, thank you. Thank you. So this patient diagnosed about 8 years ago had a left-handed tremors of about 2 years before it was diagnosed, and had other symptoms like decreased handwriting size and having some unsteadiness, falling down. His medication included levodopa 700 milligram with dopamine agonist and of course Celgene and amantadine. This is a typical scenario which we have 8 to 10 years of duration. Initial 5 to 7 years we call them very nice honeymoon period when the doctor is happy, patient is happy, but after that we have all these problems. So this patient actually after the symptoms was less confident going out, had problems with dressing and bathing, and no problems with bed mobility, depression. And then at the same time, the family noticed that he's not going out, he's having a problem with the vision. I think there's some problem with the laptop. Let me have my laptop. इसमें कुछ अपडेट आया लगता है। So one of the main complaints that the family noticed was feeling dizziness, which is very common, and lightheadedness, which is sometimes taken as a normal with the aging. Patient also had a little bit of visual blurring, feeling vague, and had a fainting attacks, sometimes with or sometimes without warning. He also had a little bit of memory problem, cognition problem, also had constipation, frequency, and nocturia. So all these features we have just recently seen from Dr. Midula and Dr. Gayatri, talking about constipation, frequency, polyuria, nocturia in the night particularly. So what we normally do in our clinic is now to have a 24-hour ambulatory blood pressure monitoring for all these patients who come with advanced Parkinson's disease. That's a standard protocol for us that we get 24-hour, and you can see the 24-hour cycle in this. You can see very typical postprandial hypotension in this patient after breakfast, after lunch, and after dinner. At the same time, you can also see in the night time, during the night time, there is the nocturia also, and there is a blood pressure is going up rather than going down. So the red line is the systolic blood pressure, the blue line is the diastolic blood pressure, and of course in the morning the blood pressure has gone down. So this patient has typical orthostatic hypotension, which is orthostatic intolerance, as well as supine hypertension. That is a new term which not many of you may be aware of that. So this patient has three things. One is that he has a nocturia with the postprandial, the nocturia with the supine hypertension. He also has a postprandial hypotension, and he also has a orthostatic hypotension. So all the three things, all the cardiovascular autonomic dysfunction, you can see nighttime as well as daytime and 24 hours. So going across to all the autonomic dysfunctions, what can happen in Parkinson's disease? These are some of the organs which are involved. Some of the autonomic dysfunction, whether it is constipation, whether it is sexual dysfunction, hypersalivation, or it is cardiovascular, or it is respiratory, or it is urinary. So almost everywhere you can see the people with Parkinson's disease having autonomic dysfunction involving almost all the organs. And that is, I just want to compliment Professor Mehta for having this first study of sexual dysfunction in Emirati and non-Emirati Parkinson's patients in the UAE. So this was published last year, giving an importance to the subject which nobody wants to talk. Not many of us would like to discuss, neither the families nor the patients, that patients has in sexual dysfunction. But that is very, very important in terms of quality of life, in terms of that. So to this 15 minutes, I'm just going to cover up only orthostatic hypotension, supine hypertension, postprandial hypotension, exercise-induced hypotension, post-exercise hypotension, and dipping, non-dipping, and reverse dipping. The rest of the things have been covered, whether it is urinary dysfunction or it is the constipation, gut dysfunction. So I'll just restrict myself to all these features, which are very, very common, treatable. My talk is very simple for the general neurologists and family physicians, as well as the movement disorder neurologists. These are the things which we should be aware of. The idea is to create an awareness so that people, the doctors are sensitive to this. So the first thing is orthostatic hypotension. Patient will have a falls, patient will have a dizziness, patient will have other things. So neurogenic orthostatic hypotension, we just generally define the reduction of blood pressure of 20 or diastolic of 10 millimeter within 3 minutes of standing or held up till test of 60. If the patient has coexistent supine hypertension, then this is a 30 millimeter drop. So this is something, a very standard definition, everybody knows it. But the more important thing is that half of these patients who have orthostatic hypertension also have supine hypertension, which is very important to know and to measure. And what is supine hypertension? The hypertension only during the lying time or during sleep hours. So it is in a proven orthostatic hypertension, the systolic BP of more than 140 or diastolic BP of more than 90 measured after at least 5 minutes of rest in a supine position. So a normotensive patient or a orthostatic hypotension patient, a BP of 140 by 90 during sleep or lying down is very, very important, and that is a benchmark for definition of supine hypertension. It could be mild, moderate, severe depending on the numbers, of course, but the more important thing is that half of the orthostatic hypertension, they have the coexistent supine hypertension, which is very, very important in long-term complication as well as acute complications. Talking about the postprandial, we had discussion yesterday evening with two of the patients actually talking about orthostatic hypotension and management with advanced PD. So postprandial hypertension, again, a reduction in the systolic blood pressure of more than 20 when below the 90 millimeter mercury or a pressure of 100 millimeter. So anything systolic blood pressure of 100 millimeter within 2 hours of meal is called the postprandial hypotension, and that is again asymptomatic. Again dizziness, again visual blurring, again all these things, and the prevalence could be 25% to two-thirds of these patients, and that's very significant. And that can also have more coexistent disease like diabetes mellitus, spinal cord injury, and pure autonomic failure. And these are all things which we need to know it. And similarly, exercise-induced hypertension, a fall of 10 millimeter of mercury during the exercise. Again, normally what happens in exercise with blood pressure increases. You must have known that the treadmill test or the TMT or the stress test, when the blood pressure actually increases while exercising. But when it decreases for more than 10 millimeter, this is exercise-induced hypotension, that is more important in Parkinson's patient. And sometimes it can be sustained even after 2 hours of exercise. There is a prolonged decrease in resting blood pressure in the minutes and hours following the exercise. So that is one thing to know, that postprandial, post-exercise hypotension is very, very important. There is something called dipping, which is a normal physiological process. All of us have that normal physiological dipping. At the night time, the blood pressure usually falls by around 10%. So that is a normal physiological phenomena. If it falls more than 10%, it is called a non-dipping or a reverse dipping or a reduced dipping. So less than 10% is reduced dipping, and if it is actual, rather than going down, the blood pressure goes up, that is called the reverse dipping in an individual. So this is something called, this is our patient with 24-hour ambulatory BP monitoring, where you can see in the night time there is a 10% decrease, which is a normal phenomena, and this is reduced dipping, where you can see there is a dipping, but there is less than 10%. So there is a physiological phenomenon, but there is absolutely reduced, which should be expected to be at least 10%. And this is the reverse dipping. You can see the blood pressure actually going down has gone up during the sleeping hours. So this is reverse dipping, again a supine cause of supine hypertension, and that is something. So we did a small study in our center for the supine hypertension, cardiovascular autonomic dysfunction in patients with Parkinson's disease. We took about 60 patients, and out of those 60 patients, there are more or less similar parameters for males and females and demographic, typical Indian Parkinson's patient. But do you see this? Out of 60, 32 had supine hypertension, 50%. 28 had either reduced dipping or reverse dipping. Of course, the 10 has reduced dipping, another 18 had the reverse dipping. So it's very, very important to see that the magnitude of problem in a Parkinson patient of having supine hypertension is 50% of our population with the Parkinson's disease. So it's about, different studies have different, 34 to 46. But what I mean to say is, it is important to recognize that patients with autonomic dysfunction in Parkinson's disease can have supine hypertension, which is a significant cause of morbidity as well as mortality in long term. So there are many pathophysiological contributors, and some of them are derangement of baroreceptor arch, disruption of the renin, angiotensin, aldosterone axis, and denervation of supersensitivity due to impaired sympathetic transmission. So all of them together work together to lead to this, and most of these patients can be asymptomatic. That is why we want to do 24-hour ambulatory BP monitoring for all these patients, or they can have a non-specific complaints like headache, visual blurring, and dizziness. So, but during the night time, this is something which is important to know, that these patients will have natriuresis causing nocturia, sleep disturbance, volume depletion overnight, and worsening of orthostatic hypotension in the morning. So that is something very, very important. These are the three patients, a typical one. The first one you can see on this side, the blood pressure is high while lying down. When the patient is sitting up, blood pressure goes down, but not to the normal. When the patient is standing, the blood pressure is normal. So this patient has a typical supine hypertension. The middle one you can see, while they're lying down, the blood pressure is still high. Sitting, blood pressure has come down, and while standing, the blood pressure goes further down. So this patient has both supine hypertension as well as the orthostatic hypertension. While the last patient, you can see the lying down, the blood pressure is normal. Sitting is a less reduction. Of course, while standing, it goes more down. So this is a typical isolated postural hypotension. So all the three scenarios, one combination of postural hypertension and supine hypertension, one only supine hypertension and one only postural hypotension. There could be complications in the acute scenarios as well as in the long term. So acutely, we all know cerebral hemorrhage, stroke, pulmonary edema, myocardial infarction can happen. Of course, in a long term, there is a target organ failure which can happen, including the renal, cerebrovascular disease, as well as the cognitive impairment. So that is why we want to treat these patients, and treatment is very simple. It's important to know which drug works and which drug does not work. So that is something which is important. So it could be a non-pharmacological methods, or it could be the drugs or treatment. Very simple non-pharmacological methods. You can see the elevating, as simple as elevating the bed head, or having a snack before going to the bed is also important. Some of the drugs which can be stopped is fludrocortisone. We can change it to the short-acting pressure agents, and of course, we have to avoid the drugs which increase the blood pressure, like nasal decongestants, eye drops, and other drugs like NSAID. So important to know, even without drugs, the first thing is to control the supine hypertension with these measures, which are very simple and very easily done. The drugs, medications, most of them you all know. The cardiologists, they know it very well, and some of them are we usually, but I use hydralazine. That is a very simple drug, very important, 50 milligram at night time. If the documented supine hypertension is there, it's very simple. You can also use short-acting nifedipine, clonidine, and minoxidil. Of course, the postural hypotension, again a significant morbidity of these patients. They can have also cardiac causes, extracardiac causes, and of course the failure of baroreflex. Baroreflex failure is very important to know, and it is a circle of involving cardiac, extracardiac, as well as baroreflex. So what we do normally is, of course, office screening. When the patient comes to you, you measure the blood pressure lying down, standing, and supine. And of course, sometimes we do the home recording also. These days, everybody has the blood pressure monitors at home, but this gold standard is 24-hour ambulatory blood pressure monitoring. Very simple to do it, to document the orthostatic hypotension as well as the supine hypertension, whether there is a normal dipping, there is a reduced dipping, or there is a non-dipping. So that is something very important. How do we treat it? Again, very simple things. Yesterday we were discussing how to avoid it and how to treat it with non-pharmacological and with pharmacological methods. Simple things, avoiding of large meals, avoiding excessive exercise. As we told, exercise can also cause hypotension, and of course avoiding drugs which cause hypotension, and this is something like those. But increasing salt intake, increasing the volume, the water intake, and head up tilt at night, and physical counter admirals, I'll show you, and of course compressive stockings, abdominal binders, they are all known to improve the symptomatic Parkinson's patient with orthostatic hypotension. These are some of the physical countermeasures. They are not the exercises intensive, but countermeasures, simple sitting, standing on the stool, or cross legs, all of them can help to increase the blood pressure. In terms of medical management, of course, the gold standard is fludrocortisone or sympathomatics like midodrine, droxidopa, and there are others coming up, octreotide and desmopressin, and of course, the targeting is this. This is a very simple flow diagram. When we actually assess this patient, this is complete assessment, just a flow diagram of how to do it in terms of orthostatic intolerance or hypotension. Very simple, each assessment, each visit, you have to have a standard protocol of Parkinson's patient undergoing this measurement. Your resident can do it. It takes only 10 minutes to do it in this assessment. And this is something for both orthostatic hypotension as well as hypertension. Both of them can be managed very easily, whether alone or in combination, coexisting, simple non-pharmacological methods. The idea is to be aware, to recognize, to diagnose, and then of course a very simple non-pharmacological methods as well as the drugs. So just to conclude, ladies and gentlemen, it is commonly prevalent in Parkinson's disease to have cardiovascular autonomic dysfunctions. It is, of course, it can lead to development of cognitive functions, it can lead to recurrent falls and even mortality. These include orthostatic hypotension, supine hypertension, as I said, all these things, and one half of these patients would have it. They can coexist, they can be independent, and they can have a sleep disturbance, they can have visual disturbance, and of course, complicate in long run as well as in acute stages. With this, I think thank you very much, and thank you very much for listening. Any questions?
Thank you so much.
I hope that was very simple and very
yeah, it is.
to the
I think
point.
we have 5 minutes, I think, for a question before the next session. So if any question, you can ask all the faculty who did this first session.
No questions?
Then, yeah, there's one question. There is a question here, please. Second row and the first row.
Hello.
Mike, please.
Thank you, Doctor, for your presentation. Just for postural hypotension, regarding the use of L-DOPA therapy, also one of the side effects is postural hypotension. So how we can manage this? Is it due to Parkinson disease in advanced stage or due to the drug induced causing postural hypotension?
Thank you. Thank you for asking this question. Yesterday also we discussed this. This is very important to know and document. The medication charts, you have to review the medication chart every time and optimize the treatment. If the anti-Parkinsonian medication or dopaminergic medications, they are given in a slow, frequent doses of continuous dopaminergic stimulation, that is the one we want to achieve it. Rather than giving in pulsatile, in a big doses, in a short, in a longer intervals, that would affect more of a blood pressure lowering down. So if you reduce the dose, give more frequently, that is something which can be done. And secondly, of course, the reduction along with the other medication which can be used to know it. The idea is to document the postural hypertension, treat it, optimize the dopaminergic medication, and then do the non-pharmacological methods, and then followed by the medications which improve the blood pressure. Yeah, yes.
The question is balancing the control of the patient who is supine hypertension,
Yes.
but postural hypotension.
Yes.
This is very difficult. I met this with patients, and I want to know what is your criteria for changing medication, or what's the optimal blood pressure medication regimen you use. As you know, a lot of these people are elderly, so hydralazine may also induce cardiac ischemia by causing tachycardia. So you want to balance the act and not end up with a side effect.
Absolutely correct. So that is why the optimization of treatment and coexisting disease or comorbid conditions are important to know it. So in our experience, the 50 milligram hydralazine is very, very useful depending upon the other comorbid conditions. If the patient is already having hypertension or a coronary artery disease, so obviously you have to see the other factors. But simple thing, if the patient does not have any other comorbid condition and is stable, the 50 milligram is perfectly fine, and that is what we use it. Anything you want to add?
I think with the permission of the chairpersons, I just want to explain. So this is one of the commonest questions from family physicians, GPs, asking us yesterday. I'm not sure the family doctor is here.
Yes,
Her mother has Parkinson's, and she doesn't know how to manage the hypertension. So the hypotension is multifactorial, Dr. Nasser. So it could be related to, say, for example, low blood pressure can be long-standing for some elderly patients. And sometimes what we see, the prescriptions in Dubai, or there are 2-3 cocktail of hypertension, antihypertensives, hydralazine, amlodipine. So you need to do a selective, beta-1 selective, I'm sure the chairpersons, so which is safe, which doesn't drop the blood pressure quickly. So hydralazine 50 milligrams is a very old way of treating hypertension. Hydralazine is for malignant hypertension. You need to use a beta-1 selective. So normally we don't use hydralazine because it's a sudden
That's what the
episodic
question is.
drop.
But now we have the newer agents.
Yes, you should go for a AC2 receptor anti. And number 2, Parkinson's per se can cause hypotension. and the medicines can cause hypotension. So that's why we know it's very important to see whether it's a disease related or is it drugs related. And I just want to ask the experts here, so if you have a Parkinson's patient, what is the, if you see requires antihypertensive, what would be your choice? You're the doyen in cardiac dysautonomia.
No, now we have a plethora of medications. The initial, when the term supine hypertension was discovered about 2005 and 2006, at that time the hydralazine was given a preferred drug. But nowadays you have seen the other drugs which are available and which are with the safety profile, but we can use it. AC2 is what you told is quite safe and quite effective also. But more important is to see what timing of the supine hypertension, what the severity of the supine hypertension. If it is mild, you can use the non-pharmacological methods. If it is mild to moderate and it is more than 140/90 in spite of the medication, and that also with the postural hypertension or without the postural hypertension. So 50% of these patients will have coexisting postural hypertension also. So you have to optimize not only the antihypertensive medication, but also the dopaminergic medication also, because many of these will have the lowering effect, and many of these will have depending upon the duration of the illness. So it is all skill. That is why I started by saying that advanced Parkinson disease management is a skill, and that is very few people have it, and these patients should ideally be managed by the movement disorder neurologist, not by the family physicians and general physicians.
The second question I have, I'm a gastroenterologist. I often get to meet the Parkinson patient who's having dysphagia or dysphonia and choking on liquids to begin with, then on solids. It's very difficult to convince family to keep them without giving them liquids by mouth or avoid feeding, especially when they come with aspiration pneumonia and they say, you are depriving them of the pleasure of eating. So I want to know the opinion of the neurologist on when do you set the criteria for saying, no, this is not the right way to feed them, let's put a peg or let's do a jejunostomy feeding. This is always a controversial issue, and what criteria do you use for estimating severity or risk of aspiration?
So I'll just want to elucidate a little further. So swallowing difficulty is now known that in a very early stage of Parkinson's disease, very subtle swallowing difficulties or dysphagia starts. It's not the advanced Parkinson's disease. So what we normally do is a use of dynamic MRI. So dynamic MRI means that you dynamically, lively, you put a bolus of saline along with a sequence of MRI and see all the 4 phases of swallowing, 1, 2, 3, 4 phases, and see which phase is affected first, and you can diagnose quite early without any invasive video fluoroscopy as such. So dynamic MRI is coming up now, and that is, we have just presented at American Academy. It's a very safe, non-invasive method of assessment of swallowing in Parkinson's disease in early stages as well as in the mid stages. Coming to the aspiration pneumonia, this is very significant main cause of morbidity and mortality in Parkinson's patients, particularly in severe Parkinson and advanced Parkinson's disease. So there are various methods how to convince the family to switch over to the PEG or the avoiding of the aspirations. So there are many ways. One is of course the modification of the diet, as yesterday we spoke about, less amount of course the chewable and the other things, and of course non-pharmacological way of swallowing it, very little and very slow, and of course now in dementia particularly we do the hand feeding. That is also a very important method of preventing aspiration pneumonia. So in advanced dementia or Parkinson with dementia, hand feeding is a new thing which has come up, whether the family feeds with the hand and while sitting down, making the patient sit down, and then preventing this aspiration.
Dr. Najjar,
Dr.
I think
Guy
you asked fantastic questions, 2 questions which always come in our clinical practice. That's what, if a patient comes to you, you being a gastroenterologist, you can't say that straight to PEG. So they think, why is she saying that? So what we do, Professor, we developed called MDT clinics.
Yeah.
So myself, movement disorder specialist will sit. First we tell patient, Parkinson's tablet only works for 4 hours. So if they get struck up here, So it's only work for 2 hours. So the early warning signs of aspiration, we always say if he's coughing, then we need to say your Parkinson's medicine is not going to the brain, number one. So age related, then what he's saying that MR brain to make sure there is no vascular insult in the brainstem, and the peripheral video fluoroscopy. Then we say that you're absolutely, we can say that there is no relative risk, absolute risk of aspiration, and you can't do, so then we can go with the device-aided therapies. So that's one. So Rukmini, you want to add one more thing for hypotension before I forget? I always tell my trainees to look at the feet.
Yeah.
Always look at the feet. If there is a swelling of the feet. So you need to tell doctors here, how many of you ask your trainees to look at the feet? So yes, see, that's why you're a legend, Dr. Naja. So because some drugs in dopamine agonists can cause swelling, and also amlodipine, calcium channel blockers can cause swelling. So go on increasing buy one, get one free tablets, then the legs will swell up, and it's, so you need to be selective antihypertensive. Rukmini, do you want to add?
Yeah,
No,
I just wanted to add that quick
just
point.
Dr. Rukmini, I just take it from Dr. Vinod Mehta. The calcium channel blockers in particularly, amlodipine, it causes leg edema, it causes constipation. If the patient is taking amantadine also, again a problem with the leg. So these are the things which have to be avoided in this patient. Even if the patient has a supine hypertension, we don't give amlodipine because it causes again all the problems with the Parkinson's also. Dr. Rukmini.
Yeah, I just wanted to add to what Mehta had already said, that sometimes patients are not able to swallow just because they are in off state.
Yeah.
So device-aided therapies do help them in that state. I mean, there are people who actually had been on Ryan's tube, have been off the Ryan's tube just because they are on device-aided therapy. So they can become better. But when you have a patient who's got severe dysphagia, if the first thing that comes up is only the liquids. So even when they have, so we actually tell them that even if you're going to have a PEG, you can probably give them a little bit of solid just for them to enjoy the taste of the food.
So PEG and the duodopa has dual things. You can also increase the calories and you can also give the levodopa. Both the things can be done. PEG is simple.
You know, the misconception among patients is liquid is safer than solid, which is the opposite. People choke with liquid far more when they have incoordination or neurological or pseudobulbar cause of dysphagia. So I always tell my patient caregiver, please do not give liquids unless they are thickened.
Yeah.
And first, you cannot absolutely guarantee they will not choke even on solids. So it's always an ethical issue and an emotional issue. When do you tell this family, please do not put any food or drink in the mouth of your relative, you may risk aspiration. I think I go by their clinical presentation. If they have had a documented aspiration pneumonia, enough is enough. I'm not going to take a risk again. And I tell them, do you want your father or mother to end up with a pneumonia and a hospital admission? You don't want to do that. Okay? I also get my ENT person involved to show them what happens of the saliva pooling happening near their larynx, because a video film is better than 100 words showing them how this aspiration is happening. And yet, this is the most difficult decision. I think it's emotionally texting for the patient to say you can't eat anymore. It's very difficult. They get very sad, very unhappy.
So I couldn't agree more with you, because the aspiration pneumonia, once documented with the admission, hospital admission, is an indication for that. And of course, many of these patients will have siluria and the saliva will be there, and that also can be done. It's a pooling of saliva, because everything is slow in Parkinson. All the movements are slow, whether it's constipation or swallowing or everything. So that you have to look after that pooling of saliva, and that can be done by either botulinum toxin injection or by atropine drops or by glycopyrrolate. That's what three things which you use.
Regarding postural hypertension, what I do, any drug which is, if you're giving fluorocortisone or betadine, don't give all the medication before 3 o'clock. That will prevent the supine hypertension in the night, one. Second thing, when they're sleeping in the night, I ask them to use higher pillow. So they are not lying down flat. Third thing is, I ask them if your BP is above 180, 190, they should avoid sleeping because that will further aggravate chances of complications. Postural hypertension may be immediately more troublesome rather than isolated supine hypertension because they fall and injure themselves. So that has to be taken care of. So I ask them to keep their blood pressure on higher side, maybe 150, 160, sometimes 170. I don't treat it. Because if you want to treat that, then BP will go down and they will have more postural hypertension. So keeping blood pressure on slightly higher side is also preventive in these patients.
There is also literature whether this systolic blood pressure of 150, 140, 150 is more dangerous than the diastolic blood pressure of 100 in these patients. So the jury is still out. I think whether to treat or not to treat, we have now evidence that all these patients with supine hypertension should be treated because they have a acute as well as long-term complications. So level depends, it differs from person to person. Maybe 140 is something benchmark, you may not treat it, but certainly even an accelerated hypertension in a patient who is already having a compromised renal cardiovascular function, it has to be treated. Thank you.
And if you are giving antihypertensive, give it a short-acting rather than giving a long-acting. So short-acting antihypertensive.
Yeah, short-acting ephedrine or something like that, yes.
Yes.
Or nitroglycerin. Any more questions?
I think we close the session because we are already running about 20 minutes late. Let's break for a cup of coffee and meet in time again.
Thank you. Thank you for lovely discussion.
Thank you. A big thank you to the giants in movement disorders and Parkinson's disease. 2 tasks for the audience. Grab a cup of coffee and be back in 10 minutes. We will start the second session.
now, there's no definite cut. What's the, in terms of like the definition of advanced Parkinson? So it's one of there's a sufficient loss of postural reflexes, freezing of gait, postural deformity, impaired quality of life, and high burden of motor and non-motor aspect. As you mentioned in the previous talks, you know, there's a lot of issues between the pharmacokinetics of levodopa and delayed gastric emptying, dysphagia, in terms of, you know, the delayed gastric emptying, is, you know, like the levodopa is a large a neutral amino acid which absorbed in the jejunum, and there are lots of issues which delay the delivery of the levodopa to that area from the delayed gastric emptying. As the disease goes by, the windows narrow, and the patient will fluctuate, will have on-off dyskinesias, and the more they advanced, the line between on and off aspect will be very narrow, and the medication, oral medication, will be useless. So our aim is to have the CDS as much as we can, the continuous dopaminergic stimulation. And before attempting the strategy, it's very important first is to optimize the patient medically. We need to be careful. The device-aided therapy is only for Parkinson's disease. It's not for the atypical Parkinsonian syndromes. We see a lot of referrals, patients referred with levodopa, carbidopa, 300 milligram per day, not optimized well, and they're saying there's no improvement. Once optimized, we reached like 1,000 or 1,500 milligram, and there's no response at all. It's a red flag. And most of the neurologists or the family physician, let's go for the device-aided therapy. But there is no response with levodopa. Investigate. That's why we need to be careful. So once the patient, like Parkinson, fluctuates, we need to optimize them very well. You know, changing the frequency from 8 hours to 6 hours to 4 hours, or adding the levodopa, carbidopa dispersible tablets of controlled release, adding dopamine agonists, MAO inhibitors. And there is the on-demand therapies. Those on-demand therapies, we have the subcutaneous apomorphine injections, and we have the, which is the apogopan. We have the sublingual apomorphine, which is actually approved in 2020, and we have the inhaled oral levodopa. These are for emergency use. The maximum day use of those is 5 times per day. Once the patient, you think that he needs more than this, you need to proceed for the device-aided therapy. And we can use these methods with the device-aided therapy. I'll show later on. We have so when should a patient consider for device-aided therapy? We have the 521. Patient on high burden pills, we have more than 2 times off symptoms and dyskinesia. But the question here, shall we obey the 521 so we can decide to go for to proceed for device-aided therapy? In my world, no. Patient is getting for like, let's say 4 or 5 tablets per day. You have off symptoms. You have a lot of complications, mono and other issues. So I will not wait for the dyskinesia to happen to shift the patient to device-aided therapy. So the early, the better. Of course, I will just go by, now, deep brain stimulation was there since the 90s. We know the effect of DBS for primary bradykinesia, rigidity, and dyskinesias. And it's non-destructive, reversible, and actually it helps a lot and improve the motor symptoms. And we know from the study, from the early STIM test, the patients, like, you know, for the duration of PD for 7.5 years, and they have early motor complications, like less than 2 years, and they found a lot of improvement, actually more than the oral medical therapy. But again, saying that, you know, patients who are, let's say, did not have any fluctuations, the ST and DBS did not show any superior benefit compared to the oral treatment. Okay, so the question here, when there's early fluctuations, early motor complications, those who had DBS improved very well. And we know DBS also has improved a lot of the non-motor aspect, you know, in terms of sleep, fatigue, the ICD, hallucinations. Now, yes, DBS can help the non-motor aspect, but we need to not forget that once you start DBS, you are lowering the dopamine agonist. So this is a way, so those non-motor aspect components will improve, especially the ICD and the hallucinations. We have the device-aided therapy. We have the infusion therapy. So we have the continuous subcutaneous apomorphine infusion. We have also the Apogo, and we have the Deciptone. We have the levodopa carbidopa intestinal gel infusion. We have the Vialev Produodopa, which is the phospholivodopa phosphocarbonate drug, water soluble, subcutaneous, and the other one also for and here we have the Lesigon, the levodopa, entacapone, carbidopa intestinal gel. In terms of the continuous subcutaneous apomorphine infusion, you know, this was there since a long time, but this is the first Toledo study which has been shown the great benefit in terms of having the patient on time and less dyskinesias and less off time, and actually it's underused. And what the question here, the benefit for early fluctuations is marvelous. Even in the open label extension from the trial showed 64 weeks increasing amount of on time and less dyskinesias and less off time. And also in terms of improvement in dyskinesias, even the non-motor aspect improves. They sleep, restlessness, urinary dysfunction, gastrointestinal symptoms. Although the quality of life did not show improvement in terms of the Toledo and the open label extension, but the real world evidence showed a remarkable improvement in the quality of life. The second, we have the levodopa intestinal gel, the duodopa. Again, it's a gel delivered to the to the jejunum. And again, it's a remarkable improvement in terms of the patients having the level of levodopa constant. And according to the study, which has been done, a randomized controlled double-blind study, shows a remarkable improvement for 12 weeks into the on-time, less dyskinesias, and less off-time. And of course, in terms of the complication for the device-aided therapy, we have the abdominal pain and less likely at 5%, 6%, the peritonitis and polyneuropathy secondary to vitamin B12 deficiency from the dopa. Again, you heard about this, the discovery studies, and this is actually well proved that dyskinesias improve very well from the first 2 weeks and sustained to 12 weeks for the with duodopa. We know again in terms of the urine studies, in terms of the comparison, you know, all these pumps have shown improvement in the quality of life. But in terms of the levodopa carbidopa intestinal gel, we show more improvement in the dyskinesias, UPDRS4. In terms of the neuromotor aspect, we know apomorphine shows a remarkable improvement in the neuropsychiatric symptoms, you know, in the mood, the apathy. Even patients with mild psychotic symptoms improve with apomorphine because it has this piperidine moiety, which is antipsychotic. So usually most of the neurologists say, well, the patient has mild psychosis, intermittent, he's contraindicated for apomorphine. In my world, it's a relative contraindication. If it is intrusive hallucination, intrusive psychosis, he's totally contraindicated for apomorphine. But if there's a mild, intermittent, non-bothersome psychosis like hallucinations, which improved with decreased medications, when you start apomorphine pump, there's a remarkable improvement of that. And again, we saw the difference in the non-motor aspect improvement. There's, especially with the levodopa carbidopa intestinal gel and the apomorphine, again, in terms of fatigue, cardiovascular, gastro, sleep, the neuropsychiatric has been improved. But we saw a lot of improvement in the neuropsychiatric aspect with apomorphine infusion. And again, with DBS, we saw a lot of non-motor aspect. Again, it could be secondary from the reduction of medication and from DBS itself. Regarding the subcutaneous phospholevodopa carbidopa, again, the produodopa, again, to the trial has been shown remarkable improvement in terms of 12 weeks, in terms of the on time and the less off time, less dyskinesias. Again, in terms of sleep, our check was improved because it's 24-hour subcutaneous delivery of pump. There's improvement in remarkable in sleep and the architecture of sleep and less off time, nocturnal off time during sleep. Again, in the early morning akinesia, which we saw it actually previously with apomorphine. Again, same thing with the phospholevodopa carbidopa. Again, with also the 24-hour levodopa carbidopa intestinal gel infusion. We can do that 24 hours, short improvement. We don't forget also in terms of nocturia, it's very important. We see a lot of improvement with phospholevodopa, and that has been proved with the randomized control, even through the open label extension shows that improvement in the nocturia because of the D1 effect of the phospholevodopa. And we have the Lessigon again. Of course, it's been approved in the Europe, especially the first is Sweden, and actually it's again through the PEG, and you can be used over 16 hours and 24 hours. The difference is that the volume is less, it's only a smaller pump, but patients, we have criteria for this. For patients who's on levodopa, carbidopa, entacapone tablets, and they are still fluctuation, but they're responding very well, they are a good candidate for the Lessigon. But again, patient has side effects, severe hallucinations, severe diarrhea. They are not good candidates for Lessigon. So there's a lot, of debate in terms of what shall we use? Subcutaneous apomorphine, the levodopa-carbidopa intestinal gel, the phospholevodopa, again, DBS. So patient with resistant symptoms, severe resistant tremors, or dyskinesia, we know that DBS is the best modality. But we need to be careful. When you approach a patient with tremor, you have two types of tremors. We have levodopa responsive tremor and levodopa resistant tremor. Levodopa responsive tremor is open. All the modalities can be improved, even the apomorphine, the levodopa-carbidopa intestinal gel, DBS. But if it is a resistant tremor, DBS is a good option. Also, the MRI-guided high-intensity focused ultrasound is another option for that. Okay, so patient will have, again, troublesome dyskinesias. DBS will help, but what we forgot, even the levodopa-carbidopa intestinal gel infusion will have, the phospholevodopa, the apomorphine will help. Okay. Again, we need to be careful. Patient who has severe dementia, severe psychosis, severe hallucination, the device ethic, we need to be careful about that. Again, patient with minimal cognitive impairment, let's say mild forgetfulness, there's no psychosis, we can go ahead and with the levodopa-carbidopa intestinal gel or the apomorphine, but we need to be careful with the deep brain stimulation. Again, in terms of the aspect when you try to select a patient, in my world, the non-motor aspect is very important. In Parkinson's disease, we have, the tremor dominant, and we have the akinetic rigid, the PIGD. We know the akinetic type Parkinson, they have a lot of non-motor burden, severe dementia, severe hallucination. So again, this is for me a way that we need to select which device-aided therapy fits the patient. Again, the non-motor aspect, so we need to see what's the prevalent non-motor aspect of the patient is suffering, and that will help me choose the right modality. Patient who has severe hypotension, severe psychosis, hallucination, apomorphine is not a good option. We can go ahead with a levodopa-carbidopa intestinal gel, and DBS, yes, but again, if you have the severe psychosis, severe depression, severe dementia, DBS is contraindicated. We have this managed PD tool. This is the managed PD done by AbbVie and also collaboration with the International Movement Disorders team and the Economic Affairs. It helps to select the patient who are not well controlled on oral medical therapy. And it's good for the neurologist as a pathway for the referral to the movement disorder specialist in terms of so there's 3 categories. So if the patient responds very well to the medication and there's no fluctuations, that's category 1. And let's say a patient has the 5-to-1, which I mentioned, which needs optimization. If that's not well done by the oral therapy, then we go to the category 3, which is the device-aided therapy. So in conclusion, the research in PDs has increasingly focused on development. And of course, there's still ongoing in symptomatic treatment. Sub-Q levodopa infusion will broaden the current use for these treatments, not only for advanced Parkinson, but again for the early fluctuations. And it's very important is this shared decision making. We see a lot of physicians, we're focusing on one modality, for example, DBS. Yes, I have a lot of patients coming to me. They never heard about the infusion pumps, just DBS. And I see a lot of patients come to me and they're early. They don't want medicine, they tell me DBS. So the wrong information, so we need to be very careful. So I'll show you some videos here. This is a patient. So this is in his 60. He works in the military, and he came with he's advanced, and he has this type of gait. Gait initiation failure, severe freezing of gait. Again, when you see a freezing of gait, is very important. There are types of freezing of gait. There is the off freezing and the on freezing. This patient has off freezing of gait. So when he takes the levodopa-carbidopa, there's a remarkable improvement. So I told him, with apomorphine, you will improve remarkably. And there's remarkable improvement with apomorphine. And after 3 hours, the speed. And actually, I showed this in a conference. They told me when he did the DBS, I told him it's not DBS, it's apomorphine. So it's the right patient, because if he has an on freezing, not DBS, none will work, just the physiotherapy and collaboration. There's a lot of research in terms of the on-freezing regarding the stimulation of the peduncle pontine nucleus, but again, it's all on research and the spinal cord. And so There's another patient who comes with again, severe tremors, okay? And so I need to know, is this tremor is levodopa responsive or resistant? And she's on like every 3 hours levodopa carbidopa, and she said there's remarkable improvement, but the problem, the medication wears off, and she has on a lot of medication, she has dyskinesia, she's messed up actually. So I told her, and she has a little bit of forgetfulness and more of hypotension. So I told her the best modality for you will be the levodopa carbidopa intestinal gel, since the tremor is levodopa responsive. And there's remarkable improvement. 0 tremor on day 1 from levodopa carbidopa intestinal gel. And again, the patient here with unilateral DBS, we've done a long time. We don't do unilateral, most of it's bilateral. But this patient actually, he had a left STN DBS, and he's above 70. Again, having more of forgetfulness, a bit of psychotic events, depression, anxiety. And he did the unilateral DBS in the States, and the plan was to do another DBS, but because of his age and he has other comorbid issues, we did not go ahead. So we did a combination of levodopa carbidopa intestinal gel with DBS, and there's a remarkable improvement in his gait, the tremor, the bradykinesia. And actually his son told me, if I knew levodopa will cause this, I would not go with the DBS. That's from his mouth actually, because we shut all the DBS. He has still not using it. It's a remarkable improvement, his gait, and he's using a very low dose of levodopa carbidopa. So this patient is interesting. The last case, this is my last case. This patient is bothered by dyskinesia. Every time he's dyskinetic with very low dose of levodopa carbidopa. And he's one of those young onset Parkinson, but again, he was taking the levodopa carbidopa every 2 hours. And so his problem is not off. Please help me from the dyskinesia. I'm falling. He's dancing. Okay. So after levodopa carbidopa intestinal gel, there is remarkable improvement in the dyskinesia. Remarkable improvement. And that was sustained actually. This is after 2 weeks. And that's so remarkable. A little bit of dyskinetic on the hand there, but again, remarkable improvement. So my message here that, we need to broaden our thinking about how to manage Parkinson's disease. It's not, so every patient is different. We need to fit his motor profile, the non-motor profile, and put things together. And we need to look out of the box, take the other comorbid issues, and choose the right modality for the patient. Thank you so much.
We will leave the questions for the end. So we'd like to invite the second speaker. It's Dr. Vinod Mehta. I don't believe that we need to introduce much about him. He is a consultant neurologist in King's College London and King's College Dubai. And he's going to be speaking about apomorphine, a molecule with different phases. Thank you.
Thanks, Chairman. Some technical delay. I'm sorry about that. Always happens to me. I don't know why. Oops. Thank you, ladies and gentlemen. Thanks, Chairman. So first, I just want to start. James Parkinson's, I need to tell you, one of the marketing directors of Bahrain Specialist Hospital asked me, who is James Parkinson's? Who is Parkinson's? So I said, okay, I'll show you, come to to a session, you will know who is Parkinson's. He asked me, I said, I was going back to London when I first came to Bahrain Hospital. Who is Parkinson's, sir? What is Parkinson's? So Parkinson's is a name. So James Parkinson's first coined, described Parkinson's disease in 18th century. So you need to give, those days, those legends. You see the gentleman here, Sean Martin Charcot. He actually named the disease name of James Parkinson's. Can you imagine nowadays, sir? People are stealing their ideas. So he said, this man described Parkinson's disease. So bestowing the credit to James Parkinson's, the name was coined as a Parkinson's disease. Then some milestones you can see here. So first synthesis of dopamine 19th century, followed by all this formation of Lewy body discovered in 19th century. And if you look at the evolution of Parkinson's medications, 1960, proud to say that first levodopa was conducted in patients treated. I'd probably say that in England, not America, it's in England. So 1960, levodopa. Then you can see the evolution of the treatments for Parkinson's patients. And to make Rupam happy, Professor Rupam here, that to late 90s, the deep brain stimulation coming in. So you see in 1960, oral levodopa coming in to late 90s. But most of you don't know, especially the starter boy here, apomorphine was one of the oldest molecule. So it was actually in market since 18th century. So that means apomorphine is sailing with James Parkinson since there. So first ever, 1950s, it was being tested in patients with Parkinson's disease. So levodopa 1960s and apomorphine was tested in 1950. So it's a old molecule. And levodopa, every prescription I see, levodopa, Sinemet, Medopar. Is it a gold standard? Yes. In English, you always have yes, buts, ifs. But gold is not always golden. So all that glitters are not gold. Levodopa is gold standard, yes, but not always. Why? Look at this, we show lots of graphs and studies, wow, we start and all the stuff. Is it helping our patients? So we talk here, we go back how to convince our patients. So we need to bit of nowadays patients with chat GPTs and Google coming up with a wealth of knowledge. But all these studies you see here since last 50 years showed that it has 15% to 52% of dyskinesias within 5 to 6 years. And this is one of the biggest study here. You see, it showed if you give levodopa, Sinemet, over 600 milligrams, then it develops dyskinesias. In other words, Sinemet plus 100, 600 milligrams. So we all have to age gracefully apart from Dr. Naja. You're not aging, madam. You look very, you're inspiration to all of us. So we all have to age gracefully. So aging, as we age, disease progress. As disease progress, then the patient starts doing window shopping, doctor 1, doctor 2, doctor 3, doctor 4. So then what have to do, all the doctors, we have to, if we don't have that knowledge, increase. So we need to add on, subtract, increase Sinemet, subtract. Then someone said, go to this specialist, someone go to that specialist. So it's never ending. There the challenge comes. Once you go on increasing, and I want to show you this prescription in Dubai. Syncapone is levodopa, carbidopa, entacapone. Then you see syndopa control release, then Tidomet plus. Then again, levodopa, carbidopa, entacapone. One is made in India, one is made in Pakistan, another one is made in Turkey. So these doctors, because the patients are not showing to the doctors, and doctors are not asking, what you actually taking over. So they have like same medicine, different combinations, and it's, you can see if you calculate total levodopa equivalent, it's going towards 2 grams, 19 tablets. So I just want to show you this one of the patient, very VVIP, came to see us. See, Medopar, Nupro, Medopar. It's a concussion of levodopa tablets. Every research science is saying that more than 6 tablets, you get dyskinesias. Please don't. He's giving 16 tablets, 19 tablets. And he was telling us, my stomach is paining, my stomach is full, I didn't open bowels for 2 days. So $1 x-ray is the diagnosis. So you can see there is a huge Burj Khalifa. That's what Dr. Guy always say, huge traffic jam in the stomach. At least, we should use Professor Guy Chung Fei's opinion at the time. So you can see, instead of looking at his stomach, go on pumping him, concussion of these tablets. If you are Asian, sir, you get buy one, get one free, diabetes, high blood pressure. Then cholesterol. Then you go to another Baba in India, very famous, Ramdev Baba. He gave another Ayurvedic medicine. So all coming to Dubai, we see this. Dubai is only 3 hours from India. We're seeing this all in Dubai, the concussion of tablets. And the problem here, as we are talking here, delayed gastric emptying. If you don't open your bowels, so first of all, if you have your mother, father, or sister, you have Parkinson's, first ask them one question. When did you open your bowels? So that's a very important question. If they're not opening your bowels, delayed gastric emptying, then what happens is traffic jam. All your medicines will be in the Dubai traffic jam or Bahrain traffic jam. I'm not sure Bahrain have a traffic jam. So levodopa half-life is very short. So if it dies off in the stomach and you get all these fluctuations. So what we call all these fluctuations, if you see the blue one, you become hypokinetic. If you see the pink one, we get hyperkinetic. That's why Dr. Michel was showing the dyskinesias. If you look at here, this man, when he came to us, I admitted him. How can I see this man in a OP 30, 40 minutes? So that is, I want to show you, he just stuck up. He can't even walk. And when the team tried to move in, he can't even turn. So he got stuck up. That is hypokinetic. You see this lady here? Next slide. Touch your hands, madam. Touch your hands. That is dyskinetic. I want to show you another types of dyskinesias where levodopa induced. Mild, moderate. You see here, this is Professor Ray's, when I was a registrar time, becoming too old. Professor Ray's becoming younger. So that is ballistic dyskinesias. This patient has been treated as fits in even emergency department, giving high dose of phenytoin. So you see the range, mild, moderate, severe, ballistic dyskinesias. And this patient, you see she's stuck onto a fast levodopa pump there. So this is what we called, then she gets, this is a liver off pain. And see, suddenly she becomes unresponsive, she needs oxygen. So that is off-related pain. And you see this gentleman here, it becomes off-related dystonia. He closes his eyes, he can't move. And the hands, you can see the crawling going up like this. This is off-related dystonia. And so this is because of these tablets fluctuations. So when there is nothing in the brain, they become stiff, they can't move. And if there is too much going in, the stomach is a culprit. That's what we call fluctuations. So that's what we always say, tell my patients, if you want to go to London airport, Heathrow airport, or Dubai airport, would you be happy going in the traffic jam or flyover option? So delivery is the key. So, well, we're discussing about, Dr. Michel was telling about, we have clinical validated tools. To be honest, I know these are all done by, I don't believe in it because it's a treating consultants. We know when this patient needs advanced therapies. This is a guide to general doctors not to make the patient freezing, froze. At least that will guide. It gives you an idea of the progression of the disease and the time for device-aided therapies. Don't hold the patient, please refer. If you don't know, please explain and refer. So, and there's another one, Manage PD tool, that's another validated tool to help the general doctors to refer, to predict advanced Parkinson's refer. So if you look at this patient here, this doctor keeping patient with the different types of medications, it's not a good clinical practice because he's not honest and or he's not seeing the patient taking other medications. So when it comes delivery options, we have pump-related treatments now, pump-related treatments. So we have the pumps which deliver dopamine bypassing the stomach. We have apomorphine pump. We discussed about intrajejunal, and more recent we have, these are the three CAD pumps and chrono pumps. These are all computerized pumps which deliver precision medicine, precision dopamine delivery through the skin or through the jejunum to the brain. So apomorphine, as I said, one of the oldest molecules, and it has 100%, I would say 90% bioavailability by subcutaneous route, and morphine derivative, but it doesn't has any opioid. That's need to be noted. So it's one of the best, strongest dopamine agonist, D1 strongest. It has less D3, like pathological gambling, hypersexuality. So this is one of the potent dopamine agonist, and the best one is it bypasses the stomach, gives the dopamine through the skin to the brain nicely in continuous fashion. So we have apopen, and it comes in two forms. One is a pen form, and one is a pump form. Pen is, I would say, that rescue treatment. And I would say that it's like, you keep the pen in the pocket, like a flickenoid tablet for heart. So pen in the pocket, when it suddenly becomes off, when you go into immigration check or flight, then you can use the injection, on-demand therapy. And it will work within 6 to 10 minutes. It get a rapid, reliable on time for 1 hour. So it's actually as strong as levodopa challenge. You can do it, so 95% abortion of states. So it helps with early morning offs and also delayed offs as well. Say, for example, time to on. If you're not taking levodopa tablet, it's not going to the brain, it will help you to quickly reach the brain. So at King's College Center of Excellence, what we do the training of the patient and carer. For successful outcomes, you see Terry is the senior Parkinson nurse explaining to the carer and about each and every aspect of this pump and pen training. So if you see here, this gentleman, I'm sure I've shown you. So we follow strict protocols at King's Center of Excellence, that it's not like a chocolate, just go and take the pen. We follow the regular and see the effect when, we need to give antiemetic before we give, because it's a potent. So we follow the strong protocols for the best possible outcomes. You see, the man, so fantastic APO response test. I use between Medopar tablets, bit of a on time, whenever he needs it, he uses it. Still, I'm seeing him for last four years in Dubai coming in. This is, you can see this lady 35, like this, and you see APO response test. So we can help to reduce the medicines and add on in between. So this goes back to 2000, when I was a registrar. Those days, Professor Chowdhury's introduction of apomorphine to the world. Look at him dancing. So we're using apomorphine since 2000. Now the Cleveland America says apomorphine. What is this, Omar? Right. So I quickly go through the pumps here. We can see apopod. When compared to other fast levodopa pump or intrajejunal levodopa pump, apopod is one of the most, I would say that patient-friendly, less weight when compared to any of these current available pumps. Patient-friendly, the best thing of apopod is it's only 30 seconds. You can just do it, all will be done. Whereas other pumps needs at least 2 minutes to set it up. So no liquid transfer reduces the setup time. That's the most innovative of it. So we have best experience of, I don't want to quickly go through all these graphs again, Toledo studies, it's been bored for people at the moment. So there are several studies showed in Caucasian populations, it's worked. But I quickly want to show what nice guidelines. Before you keep a DBS or anything, at least try a bit of a pen rather than, I agree with Dr. Mishal saying that. So I just want to show you quickly, 47-year-old, 9 tablets, look at him when he come to side effects of levodopa. Then you see we need to admit him for a couple of days and slowly transit him from pump. So slowly reducing it and introduction of the pump so that that hyperkinetic state has been improved. So this is another patient of mine, Max teacher, he can't get up. And I'm just doing the Apo Go, that time, only available that time in India, response test. And you see, within 6 minutes, he can able to get up. And after 24 hours, a pump infusion, you see, he's going back and playing badminton, and you can see, giving a quality life to the patient. And the same patient I showed, that's a pre-Apo, we changed him to Apo afterwards. That pump we have, only pump we have in Dubai. Hopefully Apo pod will come soon. So then we can see, and he can able to come back. I just want to show you age, 85-year-old man. Again, see, he's getting this, whenever he gets this heart attack-like episodes, hospital admission, he can't walk. Post-Apo, he's going back. And you see, even a middle-class families can having a quality of life, and he's getting his activities back. So instead of that guy has been given death penalty, admitting patients like every 2 days, hospital admission, ICU admission, is getting quality of life. I don't want to go through this. I think Dr. Mishal has given a fantastic review of apomorphine. As yes, that's the one which can help before we go for any other device-aided therapies. First, I think Apo can be useful. I want to show you, ladies and gentlemen, I want to conclude, not just European data, Caucasian data. I'm proud to say that we collaborated with PRAI group here, Rukmini and the apomorphine guru of India, Professor Dameja, Rupam. We showed apomorphine was 12 months longest study in Indian patients that our results showed all consistent with Toledo study. One of the Indian patient study, our results showed, you can say that it only works for Caucasians, it doesn't work for Indians. It's not fact. So blood is red, we all have, but you need to try it. But India has that time, only DBS is an option. But we showed, Professor Rupam, and that yes, apomorphine is consistent with Toledo study. And again, there are several papers of apomorphine, Dameja, Rupam, Rukmini. We have published so many papers. To date is consistent with Toledo study. So I just want to conclude last 2 slides. Yes, there are some side effects, immediate side effects to look at nodules. That's why you need to have skincare. That's why you need a fantastic Parkinson's team. It's not just take the tablet and go. So you need to have a after-hours care. And that's what we pride that we have a best team at King's Center of Excellence. And the last one is empowering patients and arming clinicians. That's what we are doing in Dubai. We are empowering patients. Patients are talking. The word of mouth is a powerful tool rather than millions and trillions of marketing, which you can do. So I want to show, to win the heart of Rupam, 100-year-old gentleman. I've been called from London to fly to Jakarta. So very rich, 2 private jets, massive. He said they want to see Dad at least for 2 months. You know, look at him, he was in ICU. He was like this. And they want to hear about this pump. They say that he can't do Parkinson's tablets. He asked me, I said, sir, it doesn't work. Please. I said, no, you need to come. Please help us. So Professor Ray and I discussed so many times on Zoom. No, don't waste your money. No. I said, yes, age is not a criteria. Let's, instead of 10 medoparts, let's do a subcutaneous pump. So that was 6 months follow-up. He's getting back. And the family, look at the granddaughters looking at it. Sorry, it's not coming in, I think, the video. So he came back of ICU. He's coming back to, quality of life. we had a 12 months data of him as well. So age is not a criteria for device-aided therapies. But I'm sure if I can convince one man in this audience, Professor Rupam, would you do DBS for this, Rupam? No, thank you very much, Rupam. I won today. So thank you very much for your attention. I wantedly kept this video for you, Rupam. At least I want to see that, yes, no DBS. He's a DBS guru. He celebrated 101 year birthday. Happy birthday. So,
thank you, Dr. Vinod.
Thanks.
It was an amazing presentation. As Dr. Vinod is saying, I mean, I think maybe he should also talk about whether the patient required a tube after the RT tube, after the apomorphine pump or not.
Yes. See, that time he was on ICU.
Yeah.
So they declared the death. So they want to go for Duodopa.
Yeah.
I said, first we try at least this one.
No, he is now not on RT.
No.
He's taking orally. Because this was a question which was asked before. So again, want to re-emphasize that if the patient has got a very severe Parkinson's disease, motor symptoms are not being controlled, they may have very severe dysphagia. And sometimes a device-aided therapy may improve their dysphagia. So that, I mean, once you optimize it, then it becomes much better.
Excellent.
Amazing patient. I think that's the point, that age is not a criteria to stop treatment at all. You have to bring up the quality of life ever for all the patients. Whenever it is possible.
For everyone has a loved one. If it's my father, my mother, I don't mind selling my kidney, doing it if there is a quality of life. You know what I mean? So I think we need to give patients choices. We need to explain to them. Some are affordable, some are not affordable. They are giving on NG tube 20 tablets rather than they offered a flyover option, and it's really worked. Evidence. Thank you very much.
It's my pleasure to now introduce Professor Rupam Borgohain, who's my mentor. And he's been he's the DBS man in India. The passion for deep brain stimulation has extended and to the entire country and beyond. And he's actually trained a lot of people for deep brain stimulation. I think he's got one of the maximum experiences with deep brain stimulation, not just the deep brain stimulation. He's done a lot of research in other areas. Currently, he's the director of Parkinson's Disease and Movement Disorder Research Center at Yashoda Hospital in Hyderabad. And he will be telling us about DBS, what it is, the purpose, the procedure, and the setting up. Over to you, Professor Rupam.
Thank you, Mani. So, I'd just like to say that it's an honor to be here again, 5 times in a row. So, we have a lot of passion for DBS, there's no doubt about it, and this picture states it all very clearly. There's 6 movement disorder specialists and 1 neurosurgeon. It's very difficult for a neurosurgeon. There's a lot of passion amongst neurosurgeons for DBS, but to get a neurologist into that OR is very difficult for them. So here is the passion otherwise, and this is what has happened over the last 25 years. We've been doing this for 25 years. And how does it work? It works very well. You need to see this video to realize how good it is and how effective it is. This video was taken in 2003. And the patient was operated in 2001. You had a big clunky suitcase size programmer, put off the battery, within 5 seconds the tremor starts off. As you can see, in another 5 seconds it becomes humongously marked tremor, one of the most severe tremors you can actually see. And this is then what the patient has to live with. And this is what the DBS actually suppresses. And so it's very effective for tremors. There's no dispute about that. It's very effective for achinesias, rigidity. If you do the STN, it's much better than the GPI. And this has evolved with time. There was two schools of thought on this. Now I'm just putting on the battery. You can see this. And immediately, it's controlled. So this is what is so dramatic about this therapy. And if you see this 25 years back, you can realize where you're heading. And what has happened over time is that what has happened with the disease is this green dark line is those without DBS, motor symptoms, and the dashed line is those with DBS. And this is what seems to have happened, that there's a shift to the right. The motor symptoms, the motor complications become less, and it occurs maybe a few years later. What about morbidity and mortality? That also seems to have shifted to the right with a DBS. Now, this is not without controversy, but by and large, this is what people feel, that if you get a DBS done, they live longer with less complications, a better quality of life. And this is what is happening. This is our data. We've done about 1,000 cases in the last 25 years. And this is just to give an example of what happens to these individual patients. This lady was done in 2007. This is her dancing at her son's wedding some 8 years later, jogging around 10 years later. And this is her 2 years back. And she teaches French even today, 4 hours a day in Chennai. And this is her sister-in-law, who also has a DBS done for Parkinson's disease. No blood relation, but still both got it done. So that's what it makes, a difference. And this is Benabid, along with Per Pollock, and this is how the whole team started off. And they had the 30th anniversary of the first STN DBS in 23, and this is where we'd also gone to meet them. And this was Elena Moro. There's a big celebration for the impact STN DBS has had on patients worldwide, more than 50,000 at that point of time. It's had a lot of effect on the multidisciplinary and teamwork that we see, which was not there amongst individual neurologists before that. What has happened is that there are many units set up everywhere, and what has also happened is that there's a DBS neurologist. This DBS neurologist is something like, we are the general population, we are different, and then we are mad. The general population is the neurologist, the we are different are the movement disorder specialists, and the we are mad are the DBS neurologists. The rest of the movement disorder specialists actually consider the DBS neurology a little wonky, but that's because of the work they do, and we are quite passionate about it, to put it mildly. How does it go? How do you get electrodes deep down into the brain is basically, we do MRI planning, and this is getting better with years. Initially we did with images, now we do it T2 images, and this gets much better once your Tesla strings go up. This is the patient with a frame, our latest Lexel frame. The surgeon plans on the CT, he fuses with the pre-op MRI, and there can always be an error, so we do a general backup. We actually plan on the MRI console, and this is our MRI console. We get the images there, we plan, get the coordinates, transfer the target coordinates to the frame coordinates, and we check what the surgeon is doing. We generally follow what the surgeon does, but this keeps a check on him. Surgeons can get careless, surgeons can make errors, and so can we. And so to have a balance, having two sets of eyes on the coordinates makes a lot of difference. And we, I believe, are one of the very few centers where both of us look at the coordinates differently. So what about anatomical versus physiological mapping? What are the problems? That when we get into the brain, you can have CSF leaks and brain shifts can occur, and this can cause a problem. This is where physiology works, and physiology is like getting the electrodes into the right place. How do we do that? We do MER, that is intraoperative microelectrode recording, and we do microstimulation. We stimulate on the table and look at the rigidity, the akinesia, the tremor, and the movements. Akinesia looked at from the movements, and these are the records. I don't know if you can hear this. No, I don't think I have an audio, but anyway. So these are the MER electrodes in the STN. As you can see, they start bursting, and this is what we see out there in the electrodes. And this is when we hit this SNR, that is the substantia nigra reticularis. This is a regular firing, that is irregular bursting pattern. So we know exactly what is the vertical height. We can also look at the LFPs, and this was done as a study, and we were recording the LFPs intraoperatively. You can do both, and then decide. How does the LFP help? LFP helps basically in looking at adaptive DBS. They've been trying to do this low beta and seeing for the PDA kinetic rigid symptoms. Medtronic's been a good proponent of that, and it's approved for that apparently. And you have, now they're looking at the alpha also to get patients who have not got the beta very well. You can also look at the gamma in case of dyskinesia and others. But basically, what we do is we do the intraoperative recording and we do the intraoperative stimulation. And this is an example of the stimulation. You can see the patient is moving. This is the tremor, as you can see, without the current, and the movements are slow. Now, once you put the current on, he's getting dyskinesia in the leg. The tremor is still persistent. So not everything goes off immediately. You need to actually have a very clear idea of where you are. These are the low currents. You look at these cardinal features of Parkinson's disease. At the high currents, you look for the side effects, which is basically anterolaterally, you get the pyramidal tract, and medio ventrally, you'll get more of the sensory. So you can actually get a very fair idea where you are. Look at where you get the best response. Of the 3 microelectrodes, where you used to go in with 5, now you're going with 3 microelectrodes, you choose the best one with the best effects and the least side effects. And then you put in the final DBS electrode. The DBS electrode has also evolved with time, and these numbers are basically for movement disorders. We basically have a connector in between, and we have got now, what's new is the directional leads. This is to try to get you to the sweet spot if you're not bang on into the target. If your targeting is not good, you're a little off, this is what's supposed to help you. We really haven't seen that much of an effect. At least I've been a little skeptical. The younger generation are more enthusiastic about this. We need to see what happens in time. The electrodes have evolved. The DBS electrodes have evolved markedly. Multiple electrodes are there. Multiple directionalities are there. The pacemakers have evolved, and now they have got a sensing capability. The sensing capability is still not fully evolved because not everybody gets a biomarker like the beta wave to get it. So what's actually happening to the patient? This is a patient who was operated in 2004, much before all this came. And as you can see, off time he was very bad. On time he was very good. This is him 6 weeks post-op. His off improved remarkably, and this is one cardinal feature which I'd like to see with all advanced therapies. What actually happens to the off symptoms? The off symptoms, this unequivocally better with DBS, and Pei tells me that it's better after this thing. I have no knowledge about it, so I can't really argue or debate. So this is what we see repeatedly, and that's why we're so passionate about it. And this is the same patient after 9 years, this is the same patient after 14 years, this is the same patient after 18 years, and this is him after 20 years. So the effect is very consistent as long as the battery is on. The battery goes off, he crashes like no one's business until you get a new battery into him or get that battery going. So that is driven by the battery is not in doubt. The medicines come down markedly, which is another remarkable thing. They come down from 8 to 10 tablets to maybe 1, 2, 3 tablets a day. And this is what is very remarkable. We do for doctors also. This is a senior psychiatrist who was operated in November last year. By February, he is actually seeing so many patients that his son from UK, who's a vascular surgeon, says that my dad's not picking my calls. I don't know whether to complain or not to complain or feel happy that he's seeing more patients. That's a good dilemma to have. So let's see how it goes. And there's another one. This guy was operated in 2003. This is on and off before surgery. This is on and off after surgery. Sorry, off and on after surgery. So you can see that there's improvement. And this is him after, what gets better, as I said, is that the off symptoms get better. The off threshold goes up. The on dyskinesias come down. And so his good time becomes better in both the on and off. This is the same patient after 7 years. This is the same patient after 21 years. So he's on one single tablet of Syndopa. He's still working as an accounts officer in the state government. Not the greatest, but he's fine, he's good, he's cognitively preserved. And this is 21 years of full working life. So that's what you're giving to these patients if you get it done early enough. You don't get it, they're quite disabled. It's not really required. And this is what has changed. The CAPSID PD criteria is what we started off initially. Things got much better in the last 20 years. The genetics have come in, not contributed much, because we do know that what your outcome will be, but we will still do it, no matter what the genes. The axial motor symptoms have been another area where we have evolved. We do take up patients with axial symptoms, that is gait, swallowing, speech. Patient outcome measures are the main thing. The patient should be happier, not us only. So we do look at it. We look at the axial symptoms. We look at earlier DBS than compared to where it was before. Before we were doing it maybe 10 years down the line. Now we do it as early as 4 to 5 years down the line, as long as we can get a good on and off. We're convinced that you've got Parkinson's disease, we will do it. If we don't, we are not, with disability, with some complications, with what Dr. Mishala has defined so wonderfully as doing it when you're off, with some complications. We will not touch you if you are not having any complications, less than 5 tablets, or you don't have Parkinson's disease. If there's any doubt, we will wait. Even 10 years, we will wait. The other way around is also true. We tell the patients early on, they say, you told me 10 years, 15 years back to get DBS done. I was shit scared. A, B, I didn't have money. Either of the two, they will take some time and they will come back to you in much worse condition. This gentleman was an 84-year-old, 80 to 84-year-old, I don't know the age. He was getting these syncopal attacks in the sitting stage. This guy. You couldn't give him apomorphine. He's already getting hypotensive attacks. With 3 tablets of levodopa or 4 tablets, and we did a STN, and he came down to half a tablet 3 times a day with a midodrine, and he's happily walking around. So would you give him apomorphine? No. So that's a reparty on your statement. So yes, things do happen. This is a young guy, 24-year-old. He joined his MD radiology in our institute. Next day he came, got his DBS done. He had a genetic variant. So, and he's happily doing his neuroradiology residency 2 years down the line. So this question is, when do you take these patients and when do you not take these patients? I think there's no doubt that there is a lot of evidence showing that ST and DBS works very, very well, works very, very long. And the best advantage for this is the early STEM study, which showed clearly in 2014 that when you compare the two, between having patients on medicines or getting DBS done on each and every parameter, whether it's the UPDRS scores, whether it's the mobility, whether it's the dyskinesias, whether it's the levodopa equivalent dose, in all of them, STN was better, except for one. They had more complications. They tended to fall. But that was also manageable, and we did do that. So the FDA made it to 4 years, and it's still superior to the best medical therapy that patients get with Parkinson's disease once they get complications. Do patients survive more? We are not really sure. The study is being done. This is 106 patients who underwent ST and DBS, and 41 who exercised their choice. They said, if you won't get ST and DBS done, they look like they died earlier. And patients with ST and DBS survived longer. This is a choice. You can't force patients. You can only tell them. That's true. And the persistent effects are very well seen when compared to baseline. 15 years later, you can see the time spent on dyskinesia is much less, when off state is much less. This is 15 years later, so STN works. We have the data for that. Other medical therapies have to evolve for that duration, because they evolve much later, but we'll see how it goes. Axial symptoms initially were not improving. Now we find that some patients do improve, even though this is camptocormia getting better, which is not supposed to be happening with ST and DBS, but we do see this in the rare patients. It's not always, it's not persistent, but we do see this getting better. Gait also we see getting better, especially if it's in the off time. On time, rarely. Let's be very honest, not everything improves. Some patients get and we do struggle quite a bit with the the gait problems later on. We manage by playing around with the frequencies. This is a patient who was operated in 2005, reading a paper 6 months back, walking around some 3 months back, and this is a son getting operated 20 years later. He's 42 years old, he's an IT expert. It's a genetic Parkinson's disease. So you can do the second generation and you can do more as time goes on. But basically it does work well. This was our very first patient who had actually undergone a thalmotomy, worsened with time. He was really bad by the time he came to us in 2000, 10 years later. This is him after DBS 5 years later. This is him after I missed that. Sorry. This is actually the very first patient, so I wanted to show you this because he was very bad, both in the this was his on state before surgery. Off, 3 people used to take him back and forth. And this is his, after 2 months after surgery, he got much better. This is him 5 years later. Sorry, I'm not missing out. And this was him some 20 years later. He survived 20 years after surgery with 40 years of Parkinson's disease. He died in the first year of COVID, not because of COVID, but otherwise. So this is a guy who was actually a leader in Microsoft, team leader. He was benched because of his Parkinson's, got his life back, and he's back to doing what he does best. So these are younger patients, 50 odd years, and you need to get them functional. It's nothing else but getting them fully functional that's required. What's the current situation? This is what is the current situation as far as 22 was concerned, and even now I think they are saying that the advanced PD of the resistant fluctuations, DBS is the method of choice. Focused ultrasound was supposed to be unilateral. Now I believe they have approved it for even both sides, but let's see how it goes. And others like the GPI and all that are somewhat on the line. Let's see what goes. And this is basically more of the same. And the German criteria which came out in February this year, they said same 5-to-1 criteria you follow, which has been told very many times. They should improve before surgery. Otherwise, you don't take them up. Bilateral tremor, as I showed you, get better, as I showed you. And ST and DBS is preferable. The GPI does look easier, but it's not the one you should be doing. The improvement is much more with that. What about the ablative procedures? There are very few studies. They're coming out now. Let's see what happens in the long term. Let's see when they develop this 5-year, 7-year data, and even 15 years like ST and DBS. Then we can have a head-to-head comparison as to what is the utility of each and every procedure. But as of now, they should be done only unilaterally according to the German guidelines. Let's see how it goes now. Finally, as Dr. Mishal has said, this is the only thing I want all the physicians to remember. 5 to 1, patient has a problem, please get it done. At least suggest to the patients to get it done. We have patients who come to us 9 to 10 years later. I've been to dozens of neurologists. Nobody has mentioned DBS. This today is a great disservice to the patients. I don't think it's warranted, and I think we need to think about it seriously. Thank you.
Thank you very much for this very interesting and practical approach of a patient with advanced Parkinson disease. And so now this year we're celebrating 30 years on DBS. That's congratulations. Thank you very much. So I think we'll move the question to the end. Now we'll move to our third speaker, and that's Dr. Karolina Popolevska. She's from Department of Neurology in University of Medical Science in Poland. So, welcome.
Thank you for the introduction. Once, ladies and gentlemen, it's a great pleasure and great experience to be here. Once again, Dr. Mehta, Prof. Rai, thank you for that kind invitation. And I really I really have to say that I'm really impressed by work both you and Prof. Rai are doing here to improve the care for people with Parkinson. It's really great. Congratulations. Just give me a minute. Here. Okay. So today we already heard a lot about advanced therapies, but in my talk I would like to focus on holistic care for people with Parkinson's disease, which is generally crucial. And because of that, I and Professor Chowdhury developed something which we called a stepped care protocol. And I will tell you about it shortly. Oh God. Oh no, we have to restart computer.
While we're preparing for the next speaker, Dr. Mishal, he is leaving the floor. So if you have any question for Dr. Mishal before he leaves.
I would like to ask a question actually. It was very interesting when you had a patient who had undergone DBS and had also taken up levodopa-carbidopa intersynergy. So do you think you are going to see more and more where you have to give combinations of the device-aided therapies?
Yeah. So your question, you're saying that you're seeing more benefits in combination versus monotherapy. So actually, I don't go for the duo, actually. Mono is best, but again, which I've been shown, it's been seen actually. And I have few patients like, with duo DBS and apomorphine DBS. Now, the question is, from my point of view, when there's a combination, I think there's more improvement, okay, in terms of like using the DBS from one point of view and do it up. But again, we need a lot of studies for that. But from from the practical point of view, there's a lot of improvement. And actually, I have now one patient on DBS. She's actually now more than 10 years, and she was doing fine. But now she has well on DBS. She's taking levodopa carbidopa entacapone. She has been followed by another doctor, and she's bombarded again with the tablets. She told me, I've been on DBS, and my aim is to stop all the medication, and I'm still taking oral medication. Now saying this, we see a lot of patients on DBS done in the right way. They're doing fine, but there's other part of patients that maybe it depends on the profile. So I suggested for her levodopa carbidopa gel, and again, remarkable improvement. So yes, combination for the right person, the right time is the best modality. Yeah.
Thank you. Any other questions? Okay. If there are no more questions, then I'll ask Dr. Karen.
We can go back to my talk. Okay, so today I would like to focus on comprehensive care for people with Parkinson's disease. We heard a lot about advanced therapies. So as we all know, the Parkinson's disease is a complex, progressive, neurodegenerative syndrome rather than a single disorder with rapidly increasing prevalence that is expected to double over the next 2 decades, as is shown in that graph. And also it is estimates that PD incidence is projected to rise from 5 to over 35 new cases yearly per 100,000, so as you can see. So another major problem is early onset PD, so the PD diagnosed before the age of 50 with totally different phenotypes. So as you can see here, with a higher non-motor symptoms burden, higher risk of impulse control disorder, more genetic cases, much more frequent depression, anxiety, and huge financial and societal impact. And there is also, as we heard yesterday, a racial variation. And recently, Dr. Mehta with Professor Chowdhury published a very interesting case where they showed that Emiratis appear to have a higher rate of young onset Parkinson's disease compared with expert. So also it shows how big problem it is. So the need for stepped care protocol came actually from this international survey led by Professor Chowdhury. And in that survey, we collect data from, as you can see here, many countries. In this survey, we ask physicians from general outpatient clinic, from movement disorder clinics. We ask questions regarding the comprehensive care for PD patients. Today also Professor Odin mentioned about Chowdhury dashboard. As you can see here, it consists of 5 vitals: motor, non-motor vitals, vision, gut and oral health, bone health, comorbidities and co-medication. And the survey showed that, for instance, gut, oral and vision health were recorded in less than 20%. Bone health was recorded in less than 20% too. DEXA scan was performed in less than 15%. And you can ask me why it's so important. We talk a lot about gait problem, we talk a lot about falls. So also when we consider comprehensive care, we have to remember that actually we should perform regular DEXA scan to diagnose early osteoporosis and start the proper treatment to avoid fracture. That's why it's so important. To fill this gap, we developed the stepped care protocol, which bridging together motor, non-motor assessment with a dashboard. And stepped care itself consists of 3 steps, which are outlined here, including, once again, motor, non-motor assessment, subtyping, and dashboard implementation. So the first step itself actually include a very simple motor assessment with Heniard staging and a self-completed NMS quest by patient. NMS quest consists of 30 very simple yes-no question, and it is worth noting that patient completed before the visit in the waiting room, so it's not time-consuming. Also, the first step includes question about dyskinesias and gait problem. You can ask why Heniard staging? We have so many other scales which assess motor status of patient, because we know that Heniard staging scale is one of the longest standing category-based scale, very easy to use, applied worldwide, very short. And here you can see on that picture Professor Yar with Professor Hohen, the main developer of that scale. So in our validation data, which now it is under the final review, the stepped care protocol showed the overwhelming support of using this stepped care protocol in everyday clinic. As you can see, we collect data from 20 centers, and it showed overwhelming support. 92% of physicians and almost 99% of patients were in favor. So now let's talk about subtypes. We talk a lot about particular non-motor problem, but generally speaking, all these problems can be gathered in some specific subtype. And years back, actually, Professor Chowdhury developed this concept. So firstly, he recognized 7 subtypes of PD according to the pathophysiology. And according to the pathophysiology, of course, dopaminergic dysfunction leads to the motor deficit, we know that. And based on that, we can distinguish tremor dominant type, akinetic rigid type, and postural instability and gait difficulty and mixed type. But in turn, non-dopaminergic dysfunction can be grouped into now 3 main subtypes: a cholinergic one with cognitive problem, a serotoninergic with sleep, mood disorders and fatigue, and noradrenergic related with dysautonomia. So from the 7 subtypes, we can distinguish 3 main ones. So once again, cholinergic subtypes with severe cholinergic deficit, which are associated with dementia. Serotoninergic, recently named as a Park sleep type, with excessive daytime sleepiness and insomnia. And noradrenergic subtype characterized by dysautonomia, pain, anxiety, and REM sleep disorder. And we have to remember that all these symptoms should be addressed in our everyday practice. And this taken us to the step number 2. So now we talk about cholinergic subtype. So actually, to recognize those subtypes, we don't need any sophisticated tool. It can be very easy recognized in our everyday clinic. So for instance, cholinergic subtype can be potentially recognized by performing very 2 simple tests. So first test is intersecting pentagon copying and naming animals in 90 seconds, which is actually the test for lexical fluency. And the campaign study published by Cambridge Group showed that people with Parkinson's disease who had problems with either of these tests from the beginning could rapidly progress to dementia in approximately 8 years, as it's shown in this graph above. And here you can see the example when patient has this is the patient at the beginning of his disease, and you can see how big problem he has with drawing intersecting pentagon. So in this step, we ask about drawing pentagons and naming animals in 19 seconds. And we use this from this campaign study protocol. And in this movie, the first to your left, you can see how patients struggling with drawing this intersecting pentagon. In the middle, patient doesn't have any problem. And here also there is a problem. So you can see
just below.
How quickly it can be checked. And also in the second step, we recommended to perform upward sleepiness scale. I will show you why later. Also, when we consider cholinergic subtype, the cholinergic subtype, but also general. We talk a lot about problem with gait and falls, and actually it is very difficult symptoms to treat. Of course, we have to exclude dyskinesia, we have to assess it is unrelated, but also we cannot forget about proper exercises. And very good exercise, you can see here, actually this patient doesn't have any severe problem with gait, but even when patient doesn't have a problem, we can give very simple cue that, gait problem can be overcome by walking with horizontal stripes in the floor, as you can see here. So actually it can be very good advice for PD patient general, but especially with those with a problem with gait. As you can see, stepped care can advocate personalized subtype-specific therapy, and for cholinergic subtypes, this treatment should include, I will also talk about it later, but we should avoid anticholinergic drugs especially in those groups. We generally should avoid anticholinergic drug in PD patient, but in this particular group especially. Also, when patient has cognitive dysfunction, we should consider early use of rivastigmine, also cognitive behavioral therapy if it's available and required. Very important, early bone screening to ensure optimal osteoporosis management and avoid fractures due to the gait problems and falls, as well as addressing frailty and apathy. And also we should do the proper exercises cue, especially when patient has unrelated freezing of gait. Now a few words.
Big steps, Baba.
And here once again you can see these exercises with horizontal stripes. And now a few words about Park sleep subtype, which is related to serotonergic dysfunction as shown in the PET studies with DASB ligand. Also in this study, Dr. Mehta and Professor Chowdhury was involved many years back. And the real importance of recognizing Park sleep in the clinic using the Epworth sleepiness scale is to avoid potential event of sudden onset of sleep, especially when we're using dopamine agonist, especially pramipexole or ropinirole. We also have to remember to detect sleep apnea and make appropriate life choices to our patient. And a crucial clinical implication is to avoid, for instance, road traffic accident, as well as drawing if swimming alone. So let me explain. So in this subtype, the Park sleep subtype, some narcoleptic event may occur because especially the use of dopamine agonists with high D3 receptor activity in this particular subgroup of a patient can be dangerous and can cause sudden sleep attack, resembling actually a narcolepsy-like syndrome. And it can potentially lead to car accident, drowning, head injuries, or suffocation during taking the meal. And we have to remember that pramipexole and ropinirole show high D3 receptor activity. Of course, Pramipexole and propinerol are very effective drugs. Pramipexole with an excellent antidepressant effect, but we have to be particularly cautious about this drug in this group of patients. So we have just published a retrospective analysis of PD patient treated with dopamine agonist. As you can see here, approximately 43 of the PD cohort reported a high likelihood of dosing while stationary in car, showing a clear risk of falling asleep with driving, operating machinery, or swimming. So this shows how careful we need to be when prescribing dopamine agonist and why it is important to use Epworth sleep scale, and the abnormal cutoff is 10 and especially 12. So we have to be very careful with that. So to summarize treatment of the PARC sleep, we have to be careful with the dopamine agonists with high D3 receptor activation like pramipexole or propinerol. We can use rasagiline, for instance. I think that some slight changed because also here we have fatigue. I don't know why it happened, but also we have to address fatigue. So as you can see, the rasagiline is a very effective and safe drug to treat fatigue, but also methylphenidate or modafinil can be considered. So going back to the summarization, we have to also make some proper lifestyle modification with caution regarding driving or swimming. We have to review of somnogenic drugs or sedative that patient might be taking, and of course we have to screen the patient for sleep apnea. And when we have advanced stage, we have to think about advanced technique as well. And now let's talk a bit about noradrenergic subtype, the last subtype, which is characterized by RBD, dysautonomia, mainly orthostatic hypotension and urinary dysfunction, anxiety, pain, abnormal cardiac MBG, and from motor perspective, it is associated with akinetic rigid syndrome and general freezing of gait. Yesterday also we talked about problem which can happen during the sleep, and here you can see which actually we called RBD, REM sleep disorder, and here you can see the two examples of this. So REM RBD, it's sleep disorder where patients act out their dreams during the REM sleep because they don't have this typical muscle relaxation. So the treatment of noradrenergic subtype should include a management of dysautonomia. We talk a lot about orthostatic hypotension. For RBD, we can consider melatonin, but usually in higher doses, up to 10-12 milligram, or clonazepam. For anxiety, we can use, for instance, venlafaxine or reboxetine. Also pain. Pain can occur in this specific subtype. I don't have a lot of time to talk about in detail, but also we have to address these symptoms, for instance, using duloxetine or pregabalin if needed. And now all these bring us to step 3, where we focus on oral gut and vision health, the bone health, and co-medication, and especially anticholinergic drug and comorbidities. And here on that slide, you can see the list of a drug with this anticholinergic effect And please avoid the drug with a stark mark here, because this is the drug with an anticholinergic index higher than 3. So we have to be particularly careful in cholinergic subtype patient, but also we have to remember that these particular drugs can cause a lot of side effects, problem with cognition, confusional state, problem with gait and falls, and also most recently a very important paper were published showing the association between anticholinergic burden and risk of acute cardiovascular events. So the authors state that drugs that have more than 3 points are related with very strong risk of potential acute cardiovascular event. So really we have to be careful. I talk a bit about bone health, which is very crucial, and also we should address it. Broadly, 2 out of 5 women and 1 out of 6 men over the age of 50 have osteoporosis, and the bone health must be checked to prevent fractures because of gait problem and falls. Also, we talk a lot of Dr. Fay had a great lecture. I just mentioned, please remember about the Helicobacter pylori infection, which can be easily diagnosed and treated, and left untreated, it causes a problem with levodopa absorption, so also it matters. Another problem is the proper take of levodopa. Please avoid dairy consumption after levodopa intake. Also, we have to tell this our patient, because we know that dairy flattens the levodopa absorption curve, as you can see here on that graph. Also, it has to be addressed. And these are all contained in the Chowdhury-Mosten dashboard. Sir Nicholas Mosten, it's a very famous judge from London, and he collaborated closely with Professor Chowdhury. He was a divorce lawyer of Lady Diana and Paul McCartney, and now he suffers from PD. And together with Professor Chowdhury, they created the dashboard. You can read about this in this paper, but I know that also the application will be available soon, just to help the patient, caregivers, doctor ensure the best treatment for a PD patient. And also the stepped care is integral to success of all advanced therapies and specific research which are now underway, because we know that all advanced techniques are very effective, improve motor, non-motor status, but also we have to remember about this all particular thing which I mentioned before. So to conclude, the stepped care management of Parkinson's should include holistic motor and non-motor assessment and subsequent clinical subtyping with a dashboard-based personalized care. Such history is a part of dashboard for PD and may avoid important complications in PD, such poor levodopa response and delayed time to on, falls and fractures, possible aggravation of cognitive dysfunction, sleep attack with potential consequences on driving and occupation. So stepped care proposed to combine non-motor subtyping with the use of dashboard, and it's very relevant and needs to be implemented. Thank you for your attention.
Thank you, Dr. Carolina, for the extensive presentation. So we are quite a lot behind in time, about 1 hour. So I will ask our next presenters to please be on time. I will now call Professor
Dr. George,
Chaudhry.
1 moment. I will borrow 1 moment of your time. We will be presenting mementos to most of our speakers at the end of this conference, but because Dr. Michal has to leave, I would like to invite you to come up on stage, and I would like to invite the chairpersons to present the memento to Dr. Michal. Thank you so much.
So next speaker is Professor Ray Chaudhry. We really do not need to introduce him as well. His work speaks for himself, and please, Dr. Chaudhry, thank you.
Does it work? No, that's not me. Go back. This. Okay, thank you for asking me to speak. I'll be very brief because I know time is short and you're bored. So I'll try and do it in 10 minutes if I can. Thank you if you keep that. So I was asked by Vinod to talk on phospholevodopa, phoscarbidopa. This is a very important topic. This is something we want to bring here. I was involved in the development of this molecule in 2015. And now we're very happy that it's come to clinical practice. A lot of the work is Dr. Vinod Mehta's work, who's acknowledged. So here we have the house of Dr. Parkinson. It's important to know that he described this condition in the 19th century, 1817. This is his house in Hoxton Square. You can go there and you can see the inscription below his house. And I organized a meeting there in 2017, which was the 200 years of Dr. Parkinson, which is why we have a career. And he speculated that Parkinson's treatment could be something other than the mouth. What is treatment other than the mouth? That is infusion, non-oral therapies, which is what we're going to be talking about. And along with the colleagues that you know, Dr. Carolina, you've just heard, King Vinod, and Professor Perodin, we've just published this paper, which is about device-aided therapy. I'm not going to talk about this. This is the use of also what we hope to bring from Dubai to here when the service gets acknowledged. This is Lasijon, which is levodopa combined with carbidopa and entacapone straight into the stomach. But I'm going to be talking to you about phoslevodopa, phoscarbidopa, which is this pump and the infusion that goes into the stomach just like that. Small, tiny pump, small, tiny injection. It's something similar to what Vinod showed you about apomorphine, but it's a new form of infusion therapy which is based on levodopa, the gold standard. Why is it important? Because if you compare levodopa infusion, which involves a surgery, when we need Dr. Guy to go into the jejunum, the levodopa carbidopa infusion is a small needle, just like insulin for diabetes, into the skin. So it doesn't require a surgery, and it requires a small pump like that. And the other thing, at this moment in time, it's the only treatment we have, which gives you 24 hours cover, 24 hours cover for treatment. How does it work? This is the pump, this is the solution. These are the different things you need. Actually quite easy to set up. You just have the insertion device, put it on the skin, one quick little clip, and there you go. And then you attach the pump to that little clip, and the infusion starts, and miracles happen. What sort of miracles happen? So here we have the team. You can see Commander Guy, King Vinod, Hasna, Therese, Clara, Afzal, Kamar, and the Center of Excellence team. This is how it works. Now this is where I have a problem. Now it works. You can see the syringe the needle being drawn out of the syringe. There, this is, I think, Clara or Therese, one of them doing it. And the syringe goes into the pump. Yes. Look at that, how beautiful it is. The syringe goes straight into the pump. And then they monitor the dose of the pump there. And then you put this on.
I know, I will give it, take.
You will see there, I think it's Therese now, who will come in, and there she puts, there it is, like that.
Not all ball and all the time.
And the infusion is on.
She also needs to get connected.
And then you just connect it to the pump. So very straightforward. Very easy to do. And immediately the treatment starts working. And then you have, it's simply, this is borrowed from one of Carolina's patients. You can look how it looks like. The great advantage, you can put the pump in your jacket and walk around. So it's great for body image. And like I said, 24 hours treatment. This is fantastic. This is the only treatment in the world we have now that gives you 24 hours cover. It might have plus and minus points, but it is still very effective. Now I want to show you the story of Pavel. This is the story of Pavel. The story of Pavel starts here in Poland. Poland is where lots of stories start. And here you see Pavel, a 39-year-old man. He's tried all forms of treatment, even gone to the great gods of deep brain stimulation. He was scared by the German DBS teams. So he said, I don't want a hole in my head. Can you do something else for me? Yes, sir, we can do some needles for you, like insulin. And so there you see, 39 years old, very, very sick, very, very badly affected, can hardly walk. Look at that right hemidystonic walk. Yeah? And the story of Pavel is a success story, because you see now where the story of Pavel evolves. Then Dr. Carolina goes in and gives her Produodopa. 2 days later, 2 weeks later, now he's doing manic, Facebook, Instagram, all social media, and that's 1 month
Pięknie. A
later.
jeszcze niech się pan tutaj przejdzie, tylko ręce wzdłuż ciała.
Going to
Tak,
work.
oho.
Same man.
Super.
Many will say, Doctor, you did miracle. And then, this is the story of Pavel continues. This is him, 3 months, running, miracle. And this is again, the story of Pavel, 1 year. So you can see the drug effect lasts for so long, which is great. Now we have 2 years data coming out, and we know this collecting data, I'll show you that, which is going to give us the first ever real-life evidence of phospholevodopa, phoscarbidopa at 1.5 years to 2 years. Okay, some other assessments. Sleep is very important for us. If we don't sleep 6 to 8 hours a day, the likelihood of dementia goes up by almost 30%, sorry. And we have here in this book showed beautiful demonstrations of how therapy, infusion therapy, can help with insomnia, can help with other forms of sleep. And Carolina already showed you the videos of REM behavior disorder. Here's a patient who came to see me just the other day. This is what happens. He fell out of his bed. And you can you cancel the audio? Guys, can you cancel the audio? Stop the audio, thank you. You can see this man falling out of the bed with bruising all over his head because of REM behavior disorder. We can help this with phospholevodopa. There's new data that's coming out showing phospholevodopa, phoscarbidopa used through the night can help with REM behavior disorder. That paper is not yet published. I've reviewed it, and it's likely to come out very soon. And we have also published, this is a paper that I published last year, how phospholevodopa, phoscarbidopa can help your sleep. So your Parkinson patients will refresh their lymphatic system by sleeping better by using this treatment. So that's another benefit of this drug. You can see the benefit, oral drug, 2.52, phospholevodopa, phoscarbidopa, 7.9, a great difference in the sleep quality of these patients. Okay, what about other things? Another thing you might want to look around, although you might be bored, is that if you look at the dark blue area, that goes down from about 77.7% to their 27.8%, meaning the patients are sleeping very well first thing in the morning. We call it early morning off period. And that, again, is a great benefit of using this drug. So in my practice, I always look at sleep because that's what makes this drug different to anything else we have. Sleep benefit is a fantastic plus point of phospholevodopa, phoscarbidopa. Some more videos. Dyskinesias. Here you see a patient with severe dyskinesia. This is again one of Carolina's patients. Thank you for the video. You see her, this is on oral therapy. And you will say, why not deep brain stimulation? I say, why not skin? There you see her after the phospholevodopa, phoscarbidopa, and there you see her again. Fantastic effect, right? Full dyskinesia reduction. And there you see another patient here. This one is posture. See her posture. Severe, what we call severe opistotonic posture. This happens when you get severe dyskinetic syndrome. This is her on a different type of therapy. This is her when she's given a test dose of phospholevodopa, phoscarbidopa, lying in bed, and this is her now.
Dobra, I tu niech się pani
So,
zawróci.
another great beneficial effect on postural
Dobrze, jeszcze raz się
instability.
zawrócić.
Very few drugs can help with
Dobra, i
postural
sobie tutaj
instability
usiąść
or
teraz.
postural problems in Parkinson's. It appears phospholevodopa, phoscarbidopa can, but we need to have more studies on this. Okay, some more videos. This is gait. This is work by Per Rodin, who showed for the first time that gait can improve with phospholevodopa, phoscarbidopa. Beautiful study there. And you see here this patient with severe gait difficulty. He has initiation problem. He has difficulty with ambulation. And the same patient here with phospholevodopa, phoscarbidopa now is able to walk.
Dobrze. Niech
So
pan się
gait is also another area, as Per showed, can improve.
I niech pan
Now we have more patients. This is another patient of Vinod's patient who came to King's Dubai. You can see she's very, very disabled, can't walk, completely bedbound. And then following phospholipidopa, phoscarbidopa, we have a great benefit. You can see her walking is initiated, and she's doing the step walking. She's walking over the horizontal stripes there. You can see, and you see the same woman. I'm, trying to get into the gate. You can see her ambulating. You can see the dramatic differences in these patients in gait as well. So you get the picture. And then we have another patient also with gait. This is again from the Polish kingdom. You see another patient with dyskinesias and marked gait issues. She needs a stick to walk. And the same patient after phospholevodopa, phoscarbidopa, able to stand unassisted and able to walk normally without a stick. So you can see the effect on the carers in there. Okay. Now what about urinary function? This is what we want all our Parkinson's patients to have a nice, good flow of urine. Okay? Because many patients with Parkinson's have urinary dysfunction. Now we've just published this paper showing clear effect of phospholevodopa, phoscarbidopa on urinary function, particularly on nocturia. Nocturia is when we get up to pass urine at night. Many of us do it. When you're older, it's normal. But both from a randomized trial and from an open-label trial data, there was very significant improvement of urinary function with phospholevodopa, phoscarbidopa. So that's seems to be another great benefit. Very recent paper from Fasano and others, and Tove Henriksen, just published actually, literally a few weeks back, showing that phospholevodopa, phoscarbidopa can be also effective as monotherapy. Monotherapy. 96 weeks follow-up there, you can see that 35.7% are maintained just on phospholevodopa, phoscarbidopa. Remember, these patients were taking a whole range of other drugs, whatever drugs you're using here, oral drugs, other drugs, all stopped, just phospholevodopa, phoscarbidopa, maintained at 96 weeks. Great, great concept that we should also think about, that in some patients you can maintain monotherapy with this drug. This is the latest review on phospholevodopa, phoscarbidopa, just come out 2 weeks back. I and several others reviewed this paper, and you can see that amongst the side effects, because no story is just happy, but there are bumps on the way. These are the bumps. The bumps are mainly skin reaction and sometimes psychosis. Those are the two main issues. Of course, there are device-related issues, etc. And I will show you the different types of skin problems that occurs in phospholevodopa are asymptomatic and symptomatic. Asymptomatic is infusion, erythema, and nodules, and sometimes with pooling of the drug. Symptomatic are with pain, itching, and very severe cases, you can have neutrophilic or lymphocytic panniculitis, and that's something that needs to be prevented. Here's an example. You can get this sort of inflammation from this injection site, but you do not have to fear. This can be treated very effectively. So for instance, we have, as I said here, I'm sorry, it's sort of got, be very, very, very vigilant. That's all you need to do. What we do, soap and water skin wash, use a low pH soap. You can buy them in any body shop, low pH, because the pH is what makes the skin reactions. The pH of apomorphine and levodopa is very different. That's why the skin reactions are also very different. Antibiotic creams are required, and sometimes you need changing in needles daily rather than every 3 days. And this leads to much better effect and avoid cellulitis. But in some patients, cellulitis might occur, and this is something to be kept in mind, that you have to be very, very careful about the skin, particularly if the patient is diabetic. That's where it matters. Now, a lot of patients are worried about psychosis. That can occur. Some patients have hallucinations, illusions, paranoid ideations after this drug. The important thing, like this patient, again, one of Dr. Vinod's patients, paranoid delusions, what we did was the nighttime dose reduction by about 70%. And in some patients, and I know they're doing it in Scandinavia, you might even have to stop the nighttime dose for a few days. And you can see this patient who was severely disabled and very apathetic, very scared. At this time he was hallucinating. Here you see just after reduction of the nighttime dosing, feeling very good? He's happy.
Yes, very
It's a
good.
little bit dyskinetic,
And
but all the
these
psychosis
movements
is
you
resolved.
see,
So once again,
yes.
you have to be
Is
very
that
vigilant
because
about
we're
the
all
side
staring
effects
at you,
and
or?
know what
Oh, why?
you're actually
And how's the shoulder?
feeling.
Is the shoulder feeling,
So,
sir?
dosing, dosing, dosing. It's all in the dosing. Sometimes we're too careful with the dosing, go too low. Sometimes we go too high. There's a nice table which AbbVie provides us with, but you have to use that with your clinical judgment. And you have to know the patient's body mass index, and based on that, you fashion your dosing of phospholevodopa, phoscarbidopa. So how about duodopa versus phospholevodopa? Well, phospholevodopa earlier, it's non-surgical, it improves sleep, nocturia, gait, dyskinesias. Less stress for the carer, and younger active patient is very important because it's body image, you don't have a tube sticking out in the front of your belly, whereas duodopa, and no polyneuropathy reported so far. Duodopa, lesijon, if phos fails, clearly, you need a surgery, and then you can debate the individual benefits of lesijon versus duodopa. That's not the topic of my talk. talk, a nighttime pump is not usually tolerated very well. If you've got a pump, then usually we take them off overnight. So that's another potential benefit of this therapy. So what we're now trying to do, I'm sorry that doesn't go off, this is the Real FOSS study. The Real FOSS study is led by Vinod and from King's Dubai, along with these centers which we have recruited, Poznan, London, Lund, Brasov, Padua. And what we want to do is that we look at real-life study on the largest sample of phospholevodopa, phoscarbidopa in the world, and we will look at their tolerability and efficacy data in about 6 to 8 months' time and up to 1 year. And you can see that both, we're very happy, Perodin, Angela Antonini, Christian, part of Carolina, have all agreed to join this team with Vinod and myself. So we will have this data coming up, which will be a great benefit for all patients who might go on to this therapy in the future. Finally, I want to finish off with this nice picture. You can see Afzal and Therese in there in Sweden. Very recently, we had a meeting, Perodin and I organized in Lund, and here is this poster, which is a highlight of all the research and care that's being done in Dubai. So if you want, a copy of that will be available for you. There's a beautiful poster that was produced by the King's College Hospital, London, Dubai, PR team, and the communications team. So I'm very happy we were able to showcase that in this big international meeting in Sweden earlier this year in August. Thank you for your attention.
Thank you, Professor Ray. That was an amazing talk. And I think there's a lot more to come with phospholevodopa, phoscarbidopa. Maybe in conjunction with the next talk, that is the Parkinson's kinetograph, which is going to be done by Dr. Vinod Mehta.
There will be a joint.
So I think the stage is kindly set right now, just like in adaptive DBS. Probably the kinetograph can be used or modulated with the phospholevodopa, phoscarbidopa pump to have an adaptive phospholevodopa, phoscarbidopa pump too. It may be expensive.
Thanks, Chairman. Ladies and gentlemen, before I start, I just want to ask you, how many of you have iPhones here? And how many of you have Apple Watches? See, there you go, Clara. Good. You know, why is it iPhone, Apple Watches are ruling the world? Answer. I know you're all hungry and angry as well. So I'll make it very short and simple. So why do you want Apple Watches? Come on, ladies here. So someone wants to monitor their heart rate. Someone wants to monitor putting on weight, how much steps they're doing. Agree or don't agree? Agree, right? So I think technology is taking over. So technology is something, we lose it or use it. So I need to explain, when I first came to King's Dubai, so first Emirati patient, I think my patients are, most of them are watching on Zoom. I got a text message from one of our excellencies are watching. So, you know, one of the mother, son came and said, brought the barber and said, doctor, why is it only you looking at my mother and seeing my mother and treating my mother? Why doctors look at the computer and treat my mother? Why? You know what he meant? He meant was insurance writing up and not looking at the patient, looking at the computer and talking quickly because for insurance approvals. And also second question, the son, another daughter who is she works for DHA, Dubai Health Authority. She asked me, Dr. Vinod, can I tell you one thing? Why is my dad, I'm living with my dad for, every day. And you see my dad 10 minutes, 20 minutes, 30 minutes. That's not what the Parkinson's is. We know as a carer, we know as a patient what happens so 15 minutes coming to you is not what all Parkinson's. So why I'm saying this is that every day sugar levels as Parkinson's progress, you see that stage 1, stage 2, stage 3, dopamine fluctuates with what you eat. Dopamine fluctuates stress. Like sugar levels. Sugar levels can't be same all the time, right, sir? It fluctuates with what you eat. It fluctuates with what you drink. Same thing with the dopamine. Fluctuates with stress, sleep, and in drug interactions. Say, for example, if you take cholesterol tablet, dopamine fluctuates. So once I just show you the slide, as Parkinson's progress, and the doctors will start giving you cocktail of pills, 1 blood pressure tablet, 1 sugar tablet, 1 cholesterol tablet, 1 Ayurvedic medicine from Kerala, and 2 tablets. We don't know where it's going, which part of the body it goes, liver, kidneys, pancreas, we have no idea. So all comes back. So patients coming to us like either hypo, whether badly treated, or side effects of the medications. So, what in England, to see Professor Ray Chowdhury, the god of Parkinson's, where is he? Is an 18 months waiting list. And to see me, another 12 months waiting list. To see Professor Carolina, maybe 2 years in Poland. so what we are lack of doctors, what we're doing is we empowering nurses, nurse Parkinson's, nurse specialists, and caregivers and all the stuff. So what we did, we validated a tool. Like, you're talking about managed PD, we're talking about this, we're talking about, these are all like, when we sit together, we got these ideas. But this is a watch, NHS England, we validated a tool, like a ECG. How many of you know aware of ECGs? ECG for the heart. Everyone knows of ECG, right? So Holter monitor. For the heart, we monitor Holter for 3 days or 2 days. That can give you the silent arrhythmias. Whereas Parkinson's, it fluctuates every day, what you eat. So what we did, England, we validated a tool, a Parkinson's watch, which you have to wear for 7 days. 7 days a week. Because Parkinson's fluctuates every day. So 7 days gives you an average like 4 months of what's happening with the Parkinson's. So we incorporate all these shoddy medications, what we're giving. Say, for example, Cinemet, all will be incorporated to the watch. Then we give the watch to the patient. 9 a.m. to 9 p.m. You have your loved ones, husband will watch the wife, mother, father, but you all have to sleep 9 p.m. to 9 a.m., right? How much you love your husbands. So you have to sleep. The watch will watch the patient. The watch will watch the patient 24 hours for 7 days. Then you need to send the watch back to us. Afzal is the king. Where is he? The PKG guru. Yeah? Oh, yeah, man. So we send the watch back to Afzal, and Afzal will upload the watch to a computer. Then what happens? We got the complete 7 days. Morning, afternoon, evening. How the medicine, 8 o'clock medicine you take, when it's going to the brain, or is it working or not. We get a complete data. So I just want to show you an example. Very 50-year-old Caucasian gentleman. He thinks too much. He knows everything about Parkinson's. You don't trust doctors, by the way. No one trusts doctors. I don't know why. Yeah? I don't know. We are on the wrong job. So he's saying, that's Dr. Vinod. I'm sailing with Parkinson's for 10 years. And I know my condition very well, not you. I said, thank you very much. Yes, I agree. So I said, look, tell me what's happening. He takes his last tablet at 10 o'clock. Then he needs to get up after 2 o'clock. Get up, his sleep is a problem. He can't move. He takes sleeping pill. I want you to just see here. If you see the last dose of Sinemet at 10 o'clock, then he takes, every time he gets up not sleeping, clonazepam. How many of you know clonazepam here? Sleeping tablets. Do you think taking sleeping tablets good or bad? Layman, very bad, right? You can't take sleeping tablet every 3 hours. So I said, look, you don't trust me, you don't trust doctors, at least trust the technology. Look at Professor Ray and I taking him through his kinetograph report. Listen to him. So he's saying that he gets up at 12 o'clock, he thinks clonazepam is not working, and he go on taking every 3 hours clonazepam. That's what he's saying. And early morning, he was zombie. He can't drive, he's falling asleep. So if you focus here, ladies and gentlemen, see, that's how the tablets is taking. You see here, from 10 o'clock onwards, there is a huge white dip here. You see here. So that's your black line. If the tablets are within your stomach, it goes below the stomach. It's crossing above the line means it's going to the brain, crossing the blood-brain barrier. You see here, from 10 o'clock until early morning 4 o'clock, there's a huge white gap. So that means there is no petrol in the brain, no dopamine in the brain. That's what we call as early morning offs. So what would you do? Would you do control release or immediate release at night time, 10 o'clock? So immediate release Sinemet works 3 hours. Control release works for overnight. So what would you do? Do you give more clonazepams or change the 10 o'clock Sinemet plus Sinemet control release? Sinemet control release. So that's what we did. So based on the PKG report, it's very evident what we call as early morning offs. So it's not a sleeping problem. It should not a sleeping problem. We should continue continuous dopaminergic delivery. Simple $1 medicine is a treatment for him. He doesn't need phospholevodopa, he doesn't need deodopa, he doesn't need sell his kidneys. Yeah, just one change of continuous pharmacokinetics of the medicine. So again, 65-year-old Emirati lady. So very high profile patient coming to me. We have lovely daughters, very high profile, very educated. Dr. Vinod, my mom is under your care for last 6 years. She's absolutely fine. But 4 o'clock, she's coming. I'm not happy, sweating coming in. Another daughter comes back, said, no, she's fine at 8 o'clock. I said, look, I don't want to rock the boat because 74 years of Parkinson's is stable. So look at here, very predictable. Predictable means when daughter is saying that mom has a problem at 4 o'clock, between 4 and 6. So what I did, we did a kinetogram here. You see that there is a dip at 4 and there is a spike at 8 o'clock, 6 o'clock. You see that right? One dip going down, one yellow one coming up. So then I said, look, that is not what we expect. So then they said, Mama, promise on me. So tell me what's happening. What she's doing, she's sleeping off. She's missing the dopamine at 2 o'clock one. When she's not taking dopamine, she's getting a dip. When you're taking all two together, she's getting side effects. So she said, I'm sorry, I'm sleeping off. I am not compliant with my medications. And same thing she said, look at the sleep pattern here, ladies and gentlemen. Blue, nice purple lines coming in. Thursday, beautiful sleep. Friday, beautiful sleep. Saturday, Sunday, there is a white line. You see in that right white line? I asked her, what is happening? She said, I want to test the watch. She took the watch off. Very clever. So, so when watch is off, so watch watches you and also will give us a objective evidence to convince patients that you're not compliant with the medicines. And she said that, no, I can't get up, allow my speech. So what we did, we stick rotigotine patch. So 2 milligrams or 4 milligrams of patch, that will help. She can sleep off, no problem. So I always say it's a patient's aid and doctor's guide. So, and also patients will believe and they're admitting their mistakes. So it's always good to make patients to convince that what is right, what is good for them. So you see this man, I showed you this video before, too many side effects. If we see like this ballistic craniocervical dystonia, you see all flames on the top, flames, means dyskinesia. So what happens? The watch will help you hypokinesia, akinesia, and dyskinesia. So that will help us to optimize the treatment. And I just want to show you this lady here. If you look at Professor Ray and Guy, look at it when she came in. She can't even stand. She's confused, completely forget about the daughter's family. She can't even. So the question here was, what is it? They don't convince. I said the only problem is we need to show the medicines are not working. They're saying that she's dead. There is no treatment. So we did the kinetogram here. Ladies and gentlemen, if you watch, all the medicines she's taking well below the black line. Well below the black line. What does it imply? It's all in the Dubai traffic jam. Yeah, Bahrain traffic jam. So what's the problem here? Is it a medicines or is it a constipation? Constipation, yes. So check X-ray. I don't know what is dinar to pound. Yeah, maybe 0.25 dinars. X-ray. I don't know what is the cost of X-ray here in Bahrain. Yeah, so X-ray will give you an answer. So, but what happened was she lost weight. She lost 20 kilos. So I convinced, based on PKG, the best treatment for her is intrajejunal levodopa infusion. So she becoming independent, stopping. You see the difference, right? Nicely, after we done the beautiful, all the graph is going up nicely to the brain. So that's the advantage of patients who's losing weight, that if you lost 20 kilos, intrajejunal levodopa infusion, a flyover to the brain from the stomach will help to gain the weight. If you look at before she came, now she's enjoying her life. So these diaries, how many of you say your doctors come and say that use your diary off time, use your diary off time, yeah? So those are obsolete now. No, there is no time for patients. Patients are very busy. The technology will monitor you, and we should use the technology properly. So, as I said, this is the paper we published that, how the device-aided therapies in the world are, revolutionizing the treatment. And I would say that it's a patient's aid and doctor's guide. No doctor will stop you if you can show that there is a problem, can you address it? So, patient's aid and doctor's guide. I say that, Ray and I and Guy and we are the first, and we have like over 200 patients on watch in Dubai. After UK, we launched in King's Parkinson Center of Excellence in Dubai. We are planning to bring to Bahrain very soon, inshallah. So I think patients are believing the watch better than me. So I think watch is winning the hearts, not me. So you see here, I want to watch this video, how a son explaining to the barber the watch. What does it imply? How educating the carers. See, look at, I'm sure you understand Arabic. She's asking, no, don't stop. I want explaining. My dad, please continue. See, I'm calling as Dr. Rashid. He's not. See, what does it imply? That implies that educating, empowering patients, that that's a way to take the medicine forward, how to treat patients. So it also, the PKG also gives you, look at here, before treatment, after treatment. First 6 months before, the movement is 3,500, after optimizing 5,000. So it also gives you objective evidence of efficacy of the medications. We published this paper on showing the government of UAE that how much money we can save using technology. The paper is in press now. You can see here, ladies and gentlemen, after PKG, number of hospital admissions reduction, number of scans reduction, number of follow-ups reduction, total economical burden. So to the government of UAE, we are showing that, inshallah, in a few weeks' time, that how much money a government hospital can save using the technology. Every time aspiration admission. So we can literally save efficacy and safety and tolerability. And I told you, we have American guidelines, Parkinson's disease, European guidelines, Parkinson's disease. Now what we are proud to say that we are bringing UAE Middle East guidelines for Parkinson's disease, what we call Ramadan regime. So from once we get this one, every Muslim Parkinson's patient in America should follow Middle East guidelines. Every Parkinson's patient in UK should follow Middle East guidelines. So that's what we call Parkinson's regime. Next time I share with you once we published it. So ECG for the heart, EEG for the brain epilepsy, and I say PKG for Parkinson's. Thank you very much. George.
Thank you very much. I think you've done a wonderful job about this new wearable device, and we hope to introduce it to Bahrain and use it. Thank you very much.
Thank you.
So now we'll move to our last speaker, and hope he will be very, very short because we are running behind time. And it's going to be Dr. Dani Rabia and Dr. Muhammad Al-Mahdi, and they're going to talk about Bahrain PD landscape. Please, welcome.
Okay, assalamu alaikum everyone. Good afternoon. First of all, I apologize for my name. My name is Da'i, and I know it's a very weird name to pronounce. And I promise you it will be the hardest thing that we'll hear in my presentation today. Yeah, can you hear me now? Yeah. So I'm the medical advisor for Parkinson, for AbbVie here in the Gulf countries. And we are covering the 5 countries all together. And my presentation today will be presenting about how we as an AbbVie are committed to neuroscience patients and Parkinson's disease as well. So at the beginning, let's speak about what is AbbVie. AbbVie is a company that came out from Abbott in 1888, and it's won 35 years in the market. And the new company that came from the mother one with AbbVie have been in the region here and have been globally since 2013. So we're almost 12 years old, the company, and we're having around 50,000 employees across the globe. In addition to, we are serving millions of patients. And when you look to the area we are focusing or operating to serve patients, we are working in the immunology, oncology, neuroscience, eye care, allergy and aesthetics, and another specialty areas. And when you look to the R&D or the development that we have done and invested, we invested over the period of the 12 years more than $50 billion for the R&D and developing new molecules to serve patients. And last year, we invested $10.8 billion for getting a new molecules in the pipelines. So as of now, we are currently speaking about 90 plus compounds that in the development phase, 50 of these compounds with a program that aim to be there in the market soon, and 80% of these molecules are very novel in the terms of the mechanism of action for serving the patients. And if you look here, you can find that these are the latest discovery that we are aiming for. The phase 1, phase 2, and phase 3 trials that are conducted for the other molecules for the neurodegeneration, neurorehabilitation, psychiatry, in addition to migraine. And as we are here focusing on the Parkinson disease, we can look to the products that we have in the market. We have the LCIG or Duodopa, the intestinal gel for 16 hours for serving patients with advanced Parkinson disease. And then we will have a new molecule that will be introduced to the market. We already launched this product across 60 countries globally with the support of the expert, top eminent godfathers, Professor Uden and then Professor Ray, who helped us to develop this clinical program of the studies to see the impact on the patient in terms of the efficacy and safety and how we can manage the advanced Parkinson disease symptoms for the patients. Not only that, we'll be having as well an oral treatment that will come as a selective D1, D5 dopamine agonist that will be helping patients by giving more efficacy and also to limit the tolerability and the side effects when it comes to the dopamine agonist and an oral, and also be having something called DMT or disease modulating treatment, which can also help stopping the progression of the treatment. By in the future, we'll be having the treatment working on the mitochondria, and it can be like a rate limiting step for the progression of the disease that we're aiming to get after our clinical program and to see the impact in terms of the efficacy and safety. Today we will be speaking about the ViLab, and to be honest, I think I have been trapped to speak about Professor Ray and Dr. Mehta, so I will try to not to disappoint you and be up to the level when it comes to speaking about our product. We're having the ViLab, or in other countries we call it Duodopa. It's a pump that can provide a patient with a continuous dopaminergic stimulation over 24 hours, and I do believe this is the subcutaneous pump that's now in the market that can help the patients. And this vial is, if you look here, you can find it's like a 10 milli vial that can provide the patient with a 24 hours of dopamine. And when you look to the pump, we provide the pump with all the answers that have been discussed by Professor Ray for free. And the good thing about this pump, it can be programmed over 3 rates, which means we'll be having like a high rate, base rate, and a low rate. And what will be the impact for having such type of rates? It will give you a tailored treatment plan for the patient based on the percentage of dopamine or requirement that he needs to have it per day. So in the morning, the patient can have the base rate sitting at home. If he wants to go for an exercise, he can use the high rate so we can increase the rate. And then if the patient is going to sleep, he will be having the low rate. So it will be having a new body attached to the patient 24/7, giving him the required amount of dopamine he needs in order to manage his symptoms when it comes to the motor fluctuations and on and offs. Finally, we will have our support program, and I do believe Professor Ray, when he was presenting, he said that every story, which have a good one, has like the bad side of it, which will be the efficacy or tolerability to the treatment here. And we are speaking here about the skin adverse events and the infusion site reaction that might happen because of the cannula presenting in the skin for a 24/7 period. And we're having a dedicated program that we'll be discussing with you how we can help you as a physician and also the caregiver and the nurses to mitigate such adverse events in order to ensure you are having the best experience with the treatment itself. So as of now, we are having, as a neurologist, we're having the oral treatment, and then the patient will jump into the surgical treatments when he goes to Professor or Dr. Guy for getting the PEG tube so he can get his Duodopa, or to the neurosurgeons in order to get his deep brain stimulation. And now, by having the ViLab in the sub-Q, it can be there so the patient will not get a dramatic change, so your patient will get oral treatment, and then you can discuss with him that you can get another treatment, which will be non-invasive, subcutaneously implemented 24/7. And afterward, the patient can go for the surgical ones or the more advanced ones when it comes to the deep brain stimulation and as well the LCIG, the 16-hour pump. When we tested the treatment itself to know how it works, we can look into the PK/PD or the pharmacokinetics or pharmacodynamics of the treatment. And you can look and see here when we compared it to our LCIG intestinal gel, which covered the patient over 16 hours, we can find the curve of the levodopa or the phospholevodopa, post-carbidopa, up to 24 hours, which means one vial can cover the patient for 24 hours, giving him a steady state supply of dopamine, and then I can program the pump within the therapeutic window and the needs of dopamine, so I can just play around it to ensure that the patient will be always in a good on without dyskinesia or getting offs. I'm not going to take much to speak about the trial itself because Professor Ray and Professor Berouden were the ones who permitted the clinical programs or the treatment itself. But if you look to here, the outcomes, you can find there is an improvement when it comes to the on time. We are increasing the on time, decreasing the off time was almost 6 hours, which counts almost 30% of the total day of the awakening time of the patient. And this adjustment by increasing the on and decreasing the off didn't come on the expense of the dyskinesia, especially when it comes to the troublesome one. So why we're getting that? Because at the end of the day, we are giving a continuous dopaminergic stimulation module with the pump that can ensure that we'll be always into the therapeutic window. And one of the things that was interesting for us to assess, or having one of the primary outcomes in the trial, to look into the morning akinesia. Why? Because the patient during the night time will be attached to the pump, getting his low rate of dopamine. So in the morning, there will be no rigidity, and also there will be improvement due to the sleep time or nighttime motor symptoms as well. So we as a company, we had a vision which we call it PACE, or patient at the core. Why? Because we get the patient in the center, and we're having a holistic approach to look into who are dealing with these patients and how we can commit to them and support them. So when a patient is having Parkinson, he's having healthcare professionals, PD nurses, caregivers, family members, everyone is interacting or trying to support such a type of patient with his disease. So that's why we have formulated a lot of clinical tools, virtual tools, and also educational materials, in addition to in-person and physical support to the patient during the implementation in the office, in the hospital, or as well during at home. And I do believe we have partnership with Professor Ray and Dr. Mehta in King's in Dubai. And to be honest, we are proudly can announce that we are having the best practices across the globe by having the least discontinuation number. I think I was discussing with Professor Berouden and Professor Ray to see the discontinuation rates across the globe. When you look to the trials, we have 40% discontinued. When we supported our Advocare program, which our nurse team to support the patient and empower the patient, we reached it with 25%. And when you look to the launched country in the Gulf countries, the launching currently, which is UAE, we are having now, as we speak, 90% discontinuation rate, which ensured that we are partnering and doing a strong partnership with all the Center of Excellence that we are having there. So I will discuss with you how we are getting to support all the holistic approaches of the patient, so we can speak about how we can early identify the advanced Parkinson's disease before getting to how we can support the patient at the implementation. So we're going to be with you starting from the identification, implementation, then the treatment adherence until the end of the journey. So at the beginning, I do believe the expert here can refer to the 5-to-1, which we always use in order how to assess the patient. And based on that, we have formulated with Professor Berouden and Professor Ray a clinical assessment tool that can help you to assess and early identify the advanced Parkinson's disease patient by having the non-motor symptoms, motor symptoms, and along with the daily activity in a very simple questionnaire that you can do online. And based on that, you can have 3 recommendations, either to optimize the oral, or add more oral, or add the patient on advanced therapy, or refer him to the movement disorder specialist or the specialized doctors to implement the advanced therapies. Finally, we delivered a solution aimed to build patient confidence and simplify their experiences. So we have a very practical solutions here, as you can see, which can help the patient to know how to manage his skin advent and infusion sites, in addition to a mat that can help the patient and empower, as Dr. Mehta was referring, that we're always trying to empower the patient and empower the caregiver. We will provide the patient with a home organizer, so the patient, if he wants to travel, go anywhere, he can just have his co-organizer where he can travel easily. In addition, a demonstration unit or a demo kit that can be helpful for you to orient your team and also to orient the caregiver and the patient before the implementation. In addition to, we'll be having a lot of educational material that we presented in terms of hard copies, soft copies in English and in Arabic as well. And all of that will come under the Advocare program, which we have already presented in UAE. And now we are trying our best with the collaboration with the health authorities and as well my colleague in the marketing to push to have someone here physical to support the patients during the implementation, and as well to give a home visits after discharge, so we can follow the patient to ensure that the patient is getting the right treatment, and also to mitigate any skin adverse events that can happen in the future. So I think I tried my best to be as fast as I can, and I hope if you have any questions to respond to it.
Thank you very much for finishing on time, and we are really very late for our program, for our lunch. So I think we will have no questions at all.
One question, Your Chairman.
Oh, okay.
Yeah, for Abifa. See, for cash patients, this is very expensive. So you need to look into, as I said, at the end of the day, quality of life. We all KOLs will speak, we show all the graphs. But the reality is, you need to come up. There are so many patients who can't afford. Yeah, so it can't be a rich man's medicine or an insurance man's medicine. We should make it affordable to all patients. That's the way you should make it available to all eligible Parkinson's patients. Thank you.
Thank you, distinguished chairpersons. Thank you, ladies and gentlemen. I urge you to walk through these majestic doors, take your right, ride an elevator one floor down, where you will find your lunch waiting, and our ushers will help you find it. You have a 30-minute lunch break, at the end of which we will meet here for the third conference. Thank you so much, ladies and gentlemen, for being on time. We are very grateful for Bahrain Specialist Hospital for its hospitality, for hosting us, and filling our tummies for the afternoon with a full lunch. Sitting right at the end will make you even more drowsy. I would like to invite all the participants to fill up the first 2 rows. Just a humble request. Thank you so much. We will start the session, the 3rd session, Anatomy, Clinical Pearls. It's my privilege to welcome Prof. Rajendra K. Damija, Prof. Perodine, and Dr. Mohammed Al Ben Falah up on stage to chair this session. Apologies. Yes, of course, you join us, Prof. Because Dr. Mohammed is not available, we would like to invite Dr. Taha Al-Durazi, renowned neurosurgeon, up on stage, sir. And Prof. Perodine up on stage. I would the last but not least, especially after lunch to keep him busy, we will invite our gut consultant, yes, Dr. Guy Chongfei up on stage to chair this session. I've caught him by surprise.
Okay. Thank you very much. Shall we make a start, ladies and gentlemen? Has the program changed or it's the same? So the first person to talk is, welcome again, Professor Carolina. Oh.
Is it changed in the program?
Okay. Sorry. I beg your pardon. The change we have is we have the speaker from earlier before the lunchtime break. It's our pleasure to welcome our host, Dr. Mohammed, and also our good friend, Dr. Mohammed Al-Hadi, to give us an update on the landscape of Parkinson's disease in Bahrain. Thank you very much.
You told me it's already there. Yeah. Carolina, so you should be presenting then. It is not uploaded from the other side. Get my laptop. Hmm? With what? Thank you, Sajid, for saving us, please. Hello, everybody. We welcome you again to the beginning of the third session in the first international Bahrain Movement Disorder Symposium. We are going to go briefly through what was in the previous session. It is the advanced Parkinson disorder landscape in Bahrain. So, as we said, as of the total census of population in 2024, we have 1.5 million population in our beautiful kingdom, Bahrain. And half of the population is composed of local Bahrainis, Bahraini nationals, and about 800,000 population expats. So as we know, that Parkinson disorder, Parkinson's disease, is a disease of mainly old age, and as the population of Bahrain and even worldwide, the old age is increasing. We have increasing aging population due to, of course, increased healthcare facilities. So this is the normal aging. From the start, we see that there will be normal difficulty in walking, normal deterioration of some of motor functions, but this is not usually attributed to Parkinson's disease. However, this also shows that the aging population in Bahrain is increasing to 3.7% of the total population above 65 years old. And also within this sector, there is increase in the number of Parkinsonian patients. So we should be diagnosing the advanced Parkinson's disease. Mainly, early diagnosis is very important to know that one of the most important criteria is bradykinesia, possibly tremor or rigidity. So, in advanced Parkinson's disease, we are taking too many pills, inability to perform a daily activity without help, no response to oral treatment, developing prominent non-motor symptoms, and wheelchair dependence. And as the disease progresses, we have more and more symptoms, especially motor symptoms and non-motor symptoms. Then we see that there is narrowing of the levodopa therapeutic window, meaning that the effect and the response to dopaminergic agents is decreasing in duration. There are lots of duration, and there is even fluctuation of response. So the unpredictable nature for motor improvement in advanced Parkinson's disease, mainly of short duration of, as we said, wearing off the effect, on-off phenomena, delayed on, or no response. So the important thing is to identify the advanced Parkinson stage. Why? Because we should do a timely initiation and early management of Parkinson's disorder. The second thing, improve quality of life and facilitate better patient planning and support, and reduce caregiver burden, which is an important topic. So the burden of advanced Parkinson's disease, it is divided between three things. Number one, patient perspective. Number two, caregiver perspective. Number three, doctor perspective. So what we see is that most of patients in early Parkinson's disease complain of like bradykinesia and slowness. And with advancing of the disease, there is fluctuation of response. And also the caregivers usually have difficulty in dealing with caregiving for Parkinsonian patients. So the burden of Parkinson's disease is very significant. Socio-economically, we lose our functional ability, we lose our working force, and at the same time, there is dependence, and we need more caregivers with the advancement of the Parkinson disorder. So that's important of having a movement disorder specialist. So that to properly diagnose the patient, proper staging of his condition, and the proper initiation and management of his polypharmacy, which helps him to improve his motor disability. And as we said, we have huge unmet needs in this domain in Bahrain. We need to construct and do, like, as we said, a society for Parkinsonian patients to raise the awareness among society about the symptoms of Parkinson disorder. There are lots of patients we see having emerging the bradykinesia, not necessarily tremors. They don't know that they have Parkinson disorder. We discussed this before in one case with Dr. Khaja. We were discussing this, that we have patients underdiagnosed in the country, and we need to get them because otherwise they become heavy burden on our society. So we have the unmet needs in the diagnosis, and then the unmet needs in the therapeutic variety. And as we said, that we are, we should do the tests that could help us to early detect the Parkinson's disorder, like the smell test. And we should do necessary to improve our care and support for our patients, especially the societal advocacy, and we should do our best to improve our care to our Parkinson patients. Hope I was not long for you, especially after the heavy meal. Thank you.
Thank you very much, Dr. Hadi, for this overview of the state in Bahrain. Can I call the next speaker, who already, Dr. Kalarina, to talk to us about the anatomy of the head, neck, and face. Thank you.
Can I ask for help? Because I can't find my folder. Okay, ladies and gentlemen, we are after lunch, so I will go through this anatomy very quickly. My job is to talk about face and neck muscles. So here you can see the lateral view of the face, face muscle and all relevant nerves. So let's start with the orbicular oculi muscle. I think I will not read the origin, insertion, and nerve supply because you can just read it from the slide. I will focus on action and then on ultrasound pictures. So orbicular oculi muscle, as you can see, consists of three parts: orbital part, palpebral part, and lacrimal part. And generally speaking, the palpebral and the orbital parts narrows the palpebral fissures, and it thus an antagonist to the superior levator palpebral and the superior and inferior tarsal muscle. And the palpebral part is responsible for the blinking reflex, and the lacrimal part serves the directional drainage of the tear fluid. And of course, we do the botulinum toxin injection in case of blepharospasm, for instance. Here it's a procerus muscle. I have a habit to use this muscle all the time. So the action is depresses medial end of eyebrow and wrinkles skin of the glabella. Another muscles, face muscles, it's zygomaticus major and minor muscle. So major muscles, generally speaking, we need these muscles for smiling. So the zygomaticus major muscle rises the upper lip to bar the upper teeth, and at zygomaticus minor, drawn the upper lip backward, upward, and outward, and is used in smiling. So generally speaking, those two muscles are responsible for our proper smile. The next is risorius, and the risorius muscle's function is to aid the facial expression by pulling the corner of the mouth laterally via its contraction and an outward and upward motion. Another muscle is orbicularis oris, the marginal part you can see there on the left side. So bilateral, it's also, it brings the lips together and close the mouth. And also this muscle is important for mastication because it works in cooperation with the buccinator muscle and the tongue to prevent the food from escaping the teeth and accumulate in the oral vestibule during eating. So actually this muscle is important when we masticate. Here you can see another muscles. Here you can see from the left epicranius muscle, the frontal belly. Here in the middle you can see the corrugator supercilii, and here you can see the levator labii superioris. So here we have the face anatomy. We will have the workshop after this session. So then you will see how important all those muscles are, especially when we have a focal dystonia, focal or segmental dystonia like blepharospasm, Meges syndrome, also hemifacial spasm, maybe, which is not typical dystonia, but also it is treated by botulinum toxin injection. And now we have the neck muscles anatomy. So generally speaking, we can distinguish three compartments: anterior, lateral, and posterior compartment. And in anterior compartment, the most important is scalenus muscles, which are here. We have three parts: anterior, middle, and posterior part. And please notice that when we inject those muscles, especially when patient has antecollis or antecaput, we have to be very careful because underneath is a brachial plexus. So underneath here you can see the ultrasonography, and number 2 shows us the plexus brachialis, brachial plexus, and 1 and 4 are the scalene muscle. So during the injection we have to be very precise not to inject the brachial plexus, and action is the anterior and middle scalenes rise the first rib, and the posterior rise the second rib when the cervical vertebrae are fixed. When all these three muscles acting together flex the neck laterally, and 3 acting together on one side, they laterally flex the neck and rotate slightly to the same side. but it's very important muscle when we have patient with antecollis, antecaput. Here we have the lateral compartment. So the first muscle is sternocleidomastoid muscle. You can see it here. Here you have origin, insertion, and nerve supply. And generally, when both sides of the muscle act together, it flexes the neck and extends the head. And when one side acts alone, it causes the head to rotate to the opposite side and flex laterally to the same side. So it's called ipsilaterally. And what is important, it is also an accessory muscle of respiration along with the scalenus muscle of the neck. And here, of course, we can argue it's not a place, but I think for instance, I'm very supportive for using ultrasonography when I'm doing injection of the cervical dystonia. I know that it doesn't, we don't need it because we have like two teams. One team is using ultrasonography and second team only use the anatomical points. And actually, two of those methods works very well. But for instance, from my perspective, I was trained by using ultrasonography, and here SCM, it's a sternocleidomastoid muscle. You can see it. You have to put probe like this. And what is important here, that underneath, maybe it works? Oh, the underneath, it's carotid artery. So I just feel more comfortable when I see where carotid artery is. Here we have a venous, and here we have a muscle. Of course, you can say that you just can absorb a bit when you put the needle to the neck and see if there is any blood or not. Then you can change direction. But I think bigger problem is that when you accidentally put the needle to the carotid arterial wall, then you can cause the dissection of the wall, and it can be the issue. And here now we go to the posterior compartment. So the first big muscle is of course trapezius, and the function. Generally, trapezius have two functions, two effects. So movement of the scapula when the spinal origins are stable, and movement of the spine when the scapula are stable. And its main function is to just stabilize and move the scapula. And here we have levator scapula, just generally underneath. And here you can see all function. So when the spine is fixed, levator scapula elevates the scapula and rotates its interior angle medially. And when the shoulder is fixed, levator scapula rotate to the same side and flex the cervical spine laterally. And here we have ultrasound. So all these muscles are essential when we treat the cervical dystonia. And here you can see the ultrasonography picture. So here you have trapezius, and underneath is levator scapula. We can call it like waterfall sign. And the posterior compartment, so splenius capitis. Actually, the splenius capitis muscle is a prime mover for head extension, and the splenius capitis can also allow lateral flexion and rotation of the cervical spine. So it's just here. And here we have semispinalis capitis, which is underneath, and when acting bilaterally, it causes extension of the neck and head, and acting unilaterally, it causes rotation of the head and neck to the opposite side. And here we have ultrasonography picture. So here we have a splenius capitis, it's a first muscle. Here we have longissimus capitis. It gives us like triangular shape, so we know that we are there. We have to hold probe like this, here you can see, and underneath is semispinalis capitis muscle. And the last one, the obliquus capitis inferior, very small muscle, but also very important. When contracting unilaterally, the OTSI muscle rotates the atlas and therefore also the head to the same side. And it also causes the extension in the atlantoaxial joint, which leads to retrocaput, particularly as a result of bilateral contraction. And what is important, the OTSI is the strongest rotator of the head. So also it can be considered to inject this muscle. And it is very like deep muscle. So here you can see the picture. So first of all is splenius capitis, here it's semispinalis capitis, and here it's OTSI. And also here, when we plan to inject this muscle, we have to do the ultrasonography duplex, because sometimes the vertebral artery is somewhere here. So also it has to be checked before injection if this area is clear and safe for the patient. And the last muscle is semispinalis cervicis, when patient has a collis, because according Professor Goyal has a talk about it, we have Colcap protocol, so we can have lateral caput or lateral collis. So here is a semispinalis cervicis, and the main function is to help the head and neck extensor to extend the head and the neck when contracting bilaterally. And here we have the ultrasonography picture. So first, actually, you have to find like 4 layers. So the first layer is skin, then the small triangle is trapezius, then it will be splenius capitis, semispinalis capitis, and underneath is semispinalis cervicis. And there is multifidus, which means some collective tissues. Okay, that's all. Thank you.
Thank you very much, Dr. Carolina, for that very informative and comprehensive talk, which I think will become more useful as you do the Botox injections later on. The next speaker is Professor Sampath Kumar, who will tell us all about the anatomy of the limb musculature. Thank you.
So Professor Sampath is the head of the Department of Neurology at Narayana Institute of Movement Disorders and Parkinson's Research Center in India. Over to you, Professor Sampath.
Very good afternoon to everybody. First of all, my special acknowledgements to King's College, especially Dr. Vinod and PRAI India and Bahrain Specialist Doctors Hospitals and on-stage persons. So when you talk about anatomy, I think it is better rather than slide. We put it on demonstration, which is the best thing whenever you speak about anatomy. So when Vinod told to talk on upper and lower limb muscles anatomy, so we thought like, I think, why should be Botox has to be injected? What are the indications? And where are the conditions where you look for? So before that, I think just to stimulate, which is the most poisonous and lethal to the man as come to the concerned is concerned, which you feel among 4. Botox is the most poisonous when compared to things, compared to cyanide, saline and all. Such a toxic molecule being converted into the very therapeutic molecule. So that's the great about Botox and formulations. This is how it is being produced, the developments, which indications for the various indications, over the period of time timeline. Similarly, it got approved for the both upper and lower limb spasticity and cervical and cerebral palsy. Coming to the preparations and timeline and all, the indication is of going to the muscle each one by wise. What are the clinical neurological indications where we can go for Botox injections. The first, you can come to the upper limb. Most of the times we go for post-stroke spasticity, traumatic brain injuries, and cerebral palsy, and focal hand dystonia, and stiff person syndrome. And recently it is not yet approved, but still in pipeline, the essential hand tremor. Coming to the lower limb, mostly go for post-stroke spasticity, again traumatic brain injury, cerebral palsy, and stiff person syndrome. So discussing the total muscles of upper and lower limb is not valid when it comes to the clinical conditions, because each time in each condition it is a contextualized based upon the context which muscles to be injected based upon the intended action which you require from the injections. So that's what we come to the first to the post-stroke spasticity, where we give commonly the Botox injections. In case of the upper limb, most of the times I think we all gone through our medical school and all, classical upper motor neuron lesion in upper and lower limbs usually goes patient with have adducted shoulder, elbow being flexed, elbow and ankle wrist being flexion with forefinger extension, sometimes thumb into the palm deformity, and lower limb usually goes to the hip extensions, knee extension, plantar flexion. So these are the common muscles you feel in post-stroke spasticity. So based upon that, you don't inject when a patient comes to you to all the muscles of upper and lower limb. So you just goal assessment you do, what intended you give which muscles to be there and all. For example, patient comes with severe disability of upper limb. Most of the times patients are more concerned about their walk, some people, but people with housemate, people at all, they're most concerned with upper limb actions. So some people have different goals to regain the function. So for example, patients try to perform the actions with the proximal upper limbs, shoulder gone to the adduction. So they consider the most things and all. Not only the adduction, sometimes the hygiene of the axilla, that also came into the picture to go for inject the muscles and all. Suppose when elbow being severely being flexed and completely pronated, you can't perform the distal hand movements and all, despite the pronation and all. And similarly, the distal hand movements, which routinely we do in the household movements, cannot be performed when being flexion and half up in this and all. So some people, especially working style people, they can't walk properly when they have severe lower limb spasticity. So this is all, what I said is basically, this guy post-stroke, 1 month came to the OPD. He is absolutely fine, non-aphasic, but still is so disabled. And especially his daughter is so concerned. He's a physiotherapist, daughter is a physiotherapist. So concerned because still my father is not able to walk independently, not able to perform activities. He is basically an engineer. So he can't doing the activities which was doing. And not only the activities he's doing, he's very unstable and walking is very, very disturbed and his recurrent falls and all. If you see classically, patient has the right spastic hemiplegia. If you see the gait, the abductions are waddling gait at and followed by the knee extension and inversion foot happens at all. And similarly, the foot, the hand, if you say, the slight adduction at the hip, shoulder, elbow being flexed with pronated, wrist being flexed with finger extension, thumb into the palm deformity. So with this deformity, he came to us. So we just asked the patient which muscles to be injected, what are your intentions to look for. He said, sir, I need to walk, I need to perform all the activities with my right hand, what I was to do and all. So then we set the goal and say a single sitting you cannot give to the all muscles which are, again, the dose of Botox will goes to more than 600 in a single sitting. So again we prioritize which injection should be given and all. That's why the goal attainment scale has to be done whenever it target the muscles. So coming to the upper limb spasticity, especially shoulder adduction, the 4 muscles we always keep into the picture is pectoralis major, then followed by your teres major and latissimus dorsi. So most of the times we try to inject into the pectoralis. This is a major muscle which is responsible for the shoulder adduction and internal rotation. So whenever severe adductions with dislocations with severe internal rotation, then we'll go into the teres major muscles and all. So this is how the patient comes with post-stroke with severe shoulder adductions and all, and almost mount to the chest by the shoulder and all. So pectoralis major, I think very simple muscle. You don't require much of anatomical landmarks and all. So just when the patient has to hold the axillary fold muscle, hold the muscle and try to inject. It's a very visible muscle. You don't properly require topographic anatomical site. You don't, I require like ultrasound and EMG guided, especially muscles of anterior chest, pectoralis major and all. So basically we try to give and should be a little careful when inject the Botox into the pectoralis major, because if you go deep, it goes with pneumothorax. Sometimes if you go superiorly, sometimes it can produce brachial plexus injury. So very superficial muscle, tough muscle can be hold and try to take the precautions whenever inject the things. Of course, teres major. Most of the times, simple landmark is inferior angle of scapula. Okay, so it's not getting it. So in case of teres major, take the inferior scapula just 2 centimeters above the inferior scapula at the border, teres major will be there. Then latissimus dorsi, sometimes in extreme shoulder reductions and all, inferior angle down to the inferior angle 3 centimeters is latissimus dorsi. So because both our muscles almost overlap, very difficult to differentiate. Only thing is inferior angle above 3 centimeters is teres major, 6 centimeters down is inferior angle of scapula is latissimus dorsi. So then, of course, just not, our work is not being done when try to inject injections and all. You try to advise the patient to go for certain procedures which can keep the muscle active. For example, shoulder rectors try to keep the muscle into the abducted position, try to keep the hand in stretch positions and all, which keeps the muscle in proper actions and all post Botox therapies. Of course, elbow flexion is always done by brachioradialis and your muscles of brachioradialis, biceps brachii and brachialis muscles and all. And simple thing which to differentiate biceps brachii from brachioradialis is, the brachioradialis is one which flexes the elbow while in semi-supinated positions and all. That means thumb being up directed, you try to inject, that is the brachioradialis muscle comes. In complete supination, the elbow flexion is done by the biceps brachii. That's how we should differentiate brachioradialis from this brachialis and all. Usually don't go to the brachialis muscle unless there is severe elbow abduction with simple pronations and all. So brachioradialis, of course, very prominent muscle, I said, keep the thumb slight flexion, thumb being point forward, try to prominent muscle over the lateral quadrant. Little bit careful, the extensor carpi muscles also it's lateral to the brachioradialis. Then biceps, of course, very targeting muscle, you can try to put into the compartment. So this is how we try to give the biceps brachii. 2 sides will try to give. Usually I don't use EMG or just go for anatomical localization, try to give the Botox injections. We take the 2 sides, biceps. That's how we finish with these things. Similarly here. Then brachialis, very rarely we go for elbow flexion for brachialis. So the doses, of course, was there. And of course, I said each injection followed by the positioning has to be done to keep the muscle active. Then comes the pronated forearm, and this is mostly done by the pronator teres. It's little special landmarks we require is basically radial. That one thing we can always pronator teres is one should be careful. Take the landmarks, radial styloid process and head of radius, tangential of middle epicondyle. So almost middle 1/3 pronator teres will be there. This is how pronator arms comes. This is how we try to give the pronator teres. When I ask the patient to do the pronation supination movement, you almost needle in the muscle. You can almost check like EMG guided and all. So whenever in doubt, anatomical side, so palpate the muscle, identify the proper anatomy, inject the needle and try the intended activity. The muscle, if it's in the needle is intact muscle, the almost action will be there by direction of the movement. That's a very, I think, when you are sure about your anatomical landmarks. The flex wrist, again common. It can be done by both flexor carpi ulnaris, flexor carpi radialis. The flex wrist. The carpi ulnaris, of course, few landmarks we always goes to say. What is the landmark? We always goes is basically take the ulnar styloid process and medial epicondyle. Line joining and medial 1/3. So be little careful what the flexor carpi ulnaris and flexor digitorum profundus. The ulnar styloid medial epicondyle is flexor carpi ulnaris. Ulnar styloid olecranon is flexor digitorum profundus. The most medial muscle is almost flexor digitorum profundus, is almost near to the bone. So we'll take the tangential. So medial lateral is of course flexor carpi ulnaris. Little bit another muscle which always goes to flexor carpi ulnaris. Another common deformity in post-stroke spasticity is thumb in palm deformities. This is how thumb is being flexed with extended with all this into the palm. Very, very severe disability. patient, even though has not much of shoulder adduction, elbow flexion, when thumb in palm deformity cannot perform any activities with his right hand. So the four muscles we always target is flexor pollicis longus. The landmark searching is a lateral epicondyle and radial styloid. Distal 1/3, we can decide to go for flexor pollicis longus. Then upon is, of course, adductor, we can always go to the middle, first interosseous. And extensor pollicis longus, when patient goes with distal 1/3 compared to the 2/3 landmarks, we can go radial styloid. Opponents in the come to base AB epipenzels. So then comes sometimes clenched fist, which I said like all fingers goes to the clenched fist and all. I think the long flexors of the all fingers, both superficialis and profundus, gone to the flexion. So targeted muscles are flexor digitorum superficialis, flexor digitorum profundus. The flexor digitorum superficialis, I think, is not one side. Look at, because there are 4 tendons, muscles, bellies, which goes to the 4 fingers, especially for the proximal interphalangeal joint. So how to target is basically the line joining radial styloid midpoint to the 1/3 side. But you try to go to the ulnar side and try to inject 1 centimeter middle, lateral, this goes to 4 heads of things, and try to look into the each tendon muscle actions for the flexor digitorum superficialis. This is how I think the 2, 3, 4 goes for middle, index, ring, index, flexor digitorum superficialis. Don't go deep, there is definitely the injury to the artery. Of course, profundus, I said, most middle muscle, landmark being undercondyle and olecranon process, whereas flexor carpi ulnaris goes to the middle epicondyle. So this how I think positioning is normal, thumb in palm. So coming to the lower limb spasticity, I said most of the times lower limb, if you see the post-stroke spasticity, most of the times it goes to the flexor, complete extension at hip, extension at the knee, and plantar flexion, slight inversion of the foot. So target the muscle. Most of the times we go, the spasticity being the human component. In case of adults, we become hemiplegic, unilateral, we try to account for these things. But in case of cerebral palsy, the pathology being diplegic, that means both lower limbs, that's why they go for adductors. That's why we don't inject most of the times post-stroke spasticity for the adductor component muscles. But similarly, being the spasticity of both lower limbs in cerebral palsy, because the complete scissoring, even for hygiene proper, we try to go for the both adductor component and all. So most of the times which you see is adductor spasticity, hip adductors, followed by hip knee deformity, knee complete extensions. Very rarely we go for toe clawing and striatal toe, hyperextension of the great toe. The plantar flexion inverted, sometimes we don't go for the deformities. So which I show striatal toe, equinovarus deformity, knee extension, flexed knee, flexed hip, and adductor thighs. So here is, I think, post-stroke, after 3 months he came to us. If you observe, I think right lower limb is just dragging, slight inversion of the foot. He's almost not able to hold the things. And right upper limb, I have seen the completely elbow being flexed. He's walking very unstable and just tripping like he's walking. There is because complete knee, slight hip flexion and knee flexion deformity with inversion at the ankle. So he's very unstable. So we try to target to the both gastrocnemius soleus and T inversion tibialis posterior we've gone for. Of course, upper limb is required. So coming to the muscles which flexed hip, usually we don't commonly give injections for the flexed hip in post-stroke spasticity. If you want to give, mostly we try to go to the iliopsoas and rectus femoris. Iliopsoas is very common muscle. We try to go for the distal to the inguinal ligament, just lateral to the femoral artery, 4 beds. We try to go injections to the side. And of course, the rectus femoris, if you take the landmarks, anterior iliac spine, superior border of patella, take 1/3 divisions, middle 1/3, middle side to the rectus femoris. There are 2 things which you consider for flexors of hip. So adductor thigh, usually, I said we don't go for in adults post-stroke spasticity because it's unilateral, but adductor's thigh usually concentrate for the patients, kids of cerebral palsy. The few landmarks of adductors already see. Then extended knee, it's again because of vastus lateralis, the quadriceps muscles and all. Most of the times, we try to keep the tone of extensors of knee because extensor of tone quadriceps is required. not fall while patient is walking and all. So extensor knee we don't target in patients usually in case of post-stroke spasticity. Then flex knee, of course, very rarely see. Again, I said like hamstrings, how to inject. There are only few landmarks you take: ischial tuberosity and medial 1/3 of the spear. The most medial is semimembranosus, distal 1/3. Then of course, semitendinosus. Most lateral hamstrings to go for is a biceps. Then equinus foot deformity, because I said like most of the times you get some of the patients, which video I shown, all patient goes completely plantar flexion with elbow being, ankle being inverted. So they will try to concentrate gastrocnemius soleus for the plantar flexion. For inversion, we try to concentrate on the tibialis posterior. So this is soleus. Of course, soleus is the most deep muscle overlapped by the both heads of gastrocnemius. And gastrocnemius, of course, two bellies, you can target it. So most of the times in Botox, the two muscles which you don't require landmark, you can just target is, one is gastrocnemius, one is biceps. So gastrocnemius, both middle heads, you can target it all. And one thing just I want to know, when to inject soleus and gastrocnemius, there we do try to go Silowski test. When knee, bottom limb being completely extended, try to do dorsiflex, that's the gastrocnemius. When the knee being flexed, with the dorsiflexion is soleus. So that's how to differentiate when to inject soleus and gastrocnemius. This should very rarely see striatal toe. We try to concentrate on the extensor hallucis longus. So this is how various muscles are being targeted for post-stroke spasticity in case of upper and lower limbs. Cerebral palsy, I think this is, I think if you observe the disability, then you will come to know how to give. So this child, I think when try to walk, when talk initiates more of spasticity, increases patient become more of ambulant. There's the one classically seen, complete scissoring of legs, which see the adductors are being both adductors, both right and left, and plantar flexion, slight inversion. This is more when patient starts to walk and pays to hold in the shoulders and all. So that's how. So definitely we try to go for adductors component. In case of post-stroke spastic adult, it is a unilateral. We may not target unless some people are very particularly they're interested to go for when they want to go bike the ride, want to sit on the chairs. Is not possible. That's why we target both adductors in case of cerebral palsy. Somebody they have flexed wrist, pronator forearm, elbow wrist, thumb in palm, again seen in distance and all. Jump postures, gait abnormalities CP. So this is equinus, again commonly seen in pediatric cerebral palsies. Equinovirus, we target tibialis posterior. And of course, calf muscle has to be injected for this plantar flexion. Posterior tibial. This child again, if you see, is going to the, invariably going to the scissoring. And try to hold it, the spasticity increases. Most of the times, human lesions, when frost goes, the spasticity increases. That's why we injected into the gastrocnemius muscles, not into the depth of soleus. This whole targeted muscles we give into 15 units each of the both heads of gastrocnemius. Two sides we target to the gastrocnemius on each side. This again hip adductor scissoring, how it goes. We try to concentrate on the both adductor magnus, adductor longus and medius. Very rarely, sometimes we go into stiff person syndrome when medications are not of much effect. We try to target both upper and lower limb muscles, especially biceps brachii, triceps flexor carpi, brachioradialis deltoid. In case of upper limbs. And again, lower limbs, hamstrings and all, very rarely. And another condition where the Botox is much indicated in case of routine practice is writer's cramp. That's where we, apart from spasticity, some of the residents have asked us, say spasticity you are giving Botox, for dystonia you are giving the Botox. The more thing is difference is both are pyramidal and extrapyramidal. Only thing is increased tone in both agonist will target. So targeting muscles may different, but the action is almost continuous. That's a writer's cramp and all. So here is a person, I think when you, if you observe, and start writing, yes, very difficult to hold. The wrist is going to the almost flexion. The thumbs is, with the hold, the how he's holding, that itself shows not able to hold and it goes for flexors.
Professor Kumar, I think we are running over time, so...
So this again will go for component muscles, extensor dystorum superficialis, flexor pallidus, and flexor longus. So this is how we try to give for vitus cramp, identify the muscle and all, for extensor hallucis longus. The view, I think, we're not, but it's essential hand tremor, where you go concentrate on flexor colpinus and all. So this how I think we're not able to completely revise the anatomy. You should revise based upon the patient condition, what you really look for based upon goals assessment. So ultimately, we have to relax, release, and revive the muscle. So this triple R we always used to call. And of course, the mission which is impossible, we make mission possible in all neurological conditions with very versatile vial of Botox. So thank you, and my best wishes from Neurology Narayan Department to the both King's College London and Bahrain Specialist Hospitals for further prospects of collaborations. Thank you.
Thank you very much, Professor Kumar. It's our now great pleasure to welcome Professor Goyal. Is he around? Oh, there is, yes. Who's from the Institute of Movement Disorders and Parkinson Center in Delhi, and who's going to tell us his wealth of experience and knowledge on dystonias. Professor Goyal.
Thank you, Chairperson, for the introduction. Thank you, Professor Ray, Professor Mehta, and entire King College Dubai team for inviting me over here. I've been given the task to talk about caput and column concept, and my talk by Dr. Karalan has helped me to reduce my slides, because a lot of muscles we have already discussed. So let's see how we can save some more time. I have no disclosures. So when you talk about cervical movement, what movement can happen? You can flex your neck, extend your neck, tilt on side, and shift. So, and permutation and combination of all these. These are the basic movements of the neck. So I will skip it here. So the concept of caput and column is, there are two ways the movement can happen at the neck. One is at atlantoaxial joint, other is a cervical. So those movements which happen at the atlanto-occipital joint, they are called caput movements. And those which happen at the cervical level, they are called collis movement. What are the different movements? So this call cap concept was given by Rachel in 2014. And anti-collis, which is an uncommon movement, was basically to describe this concept. And there are about 11 subtypes of cervical dystonia which can happen. You can read some of these, and I'll show you this picture. So you could have a laterocollis, which is cervical, and laterocaput. And similarly, torticollis and torticaput. Anticollis and anticaput. Retrocollis and retrocaput. So one movement is at cervical level, other movement is at atlanto-occipital level. This is classic two pictures of anticollis, but you see both movements are different. What is the difference? The anticollis cackle type, which is column type, and the position is mainly because of the cervical movement. Do you have a pointer? It won't work here. So in this position, if you see at the lower triangle, the movement is completely at the lower cervical level. Whereas the occipito-atlantis, there is no movement, no angulation. So this is cackle type. Other is, so what are the muscles which are responsible for this? Anterior scalene, levator scapulae, middle scapulae, longus colli, and sternocleidomastoid. And you could see, you could inject anything between 30 to 50 units of botulinum toxin for individual muscle. Other is a cap type, that is caput type. So here the predominant angulation of the neck is at the occipito-axial joint. And the angulation at the cervical is straight, as you could see from the line. What are the muscles? Predominantly longus capitis, longus colli, and sternocleidomastoid. Third, which is enterocollis, is very typical. So there is a flexion movement at cervical and extension movement at collis level. So as you could see from, so it's a double movement. So as you could see from this video also, it's doing this movement. So what are the muscles which are responsible here? So muscles are sternocleidomastoid, both sides, splanus capitis, oblique inferior capitis, semi-spinous capitis, splanus cervicis, and trapezius, which is a descendant part of the trapezius muscle. So this is the whole list of different muscles which are required to be treated during this concept. So let's look at what are different muscles. I think we've already talked about this, so either I repeat the muscle or we could move forward. Yeah. So as you could see, there are scalene which are three: anterior, middle, and posterior. Anterior is predominantly which we use, but let me show you the other diagram. Please remember, between anterior and middle, you have brachial plexus and vasculature. So don't inject at the lower end of the cervical, so stay a little up so you can prevent the injury to the neuromuscular bundle. Second is levator scapulae. As you could see, it starts origin from C1 to C4, transfer processes, and insert into the medial border of the scapula. So when you have scapulothoracic joint, it draws scapula supromedially. When you have cervical joint, it lateral flexion of the neck, as we see. Levator scapulae muscle action also depends on what is the position of the neck. If the position of the neck is anterior to the 90 degree, it will flex the neck. If it is posterior to the 90 degree, then it will extend the neck. So it's a very atypical type of muscle in that way. To feel levator scapulae, everybody can feel trapezius. So when you put your fingers in the trapezius, and the muscle which is anterior to this is this levator scapulae muscle. Normally, you cannot feel levator scapulae because it's a thin muscle. You can easily palpate this muscle only when it's hypertrophic. So as you could see from here, this is the trapezius and this is the position of the, so in this video, I think you will be able to see it. Could you see between, this is trapezius, I'm holding, just anterior to this, between my finger is levator scapulae. And you go about 1.5 to 2 centimeter deep. Longus colli are deep, some of the deepest muscle in the neck. So longus capitis in the upper portion and longus colli. So longus colli starts from around C3 and goes up to T3. They are long muscle, upper, middle, and lower portion. Where it is required? When you have anti-flexion. To inject this, let's look at the anatomy. So this is the trachea, this is esophagus, and this is spine. Here it's carotid, so your needle has to go through this and goes down up to the longus colli. So what you do, you retract the trachea on one side, and then you put your needle and it will go into the right place. Sternocleidomastoid, I think we have been explained very well. To just show you this video, how I inject is, you can ask the patient to turn on the other side, hold the sternocleidomastoid. I inject usually upper 1/3 of the sternocleidomastoid because when you inject lower down, it will have higher incidence. If you inject lower down, it will cause dysphagia. So preferably upper 1/3. What I do, I inject 2/3 dose in the upper 1/3 and 1/3 dose in the middle 1/3. In the upper 1/3, I go from the posterior border of the sternocleidomastoid. What should be thickness? Hold the muscle in your hand and judge the thickness and go into the half of the width, so you will reach in the middle of the muscle. So let's look at this video. Half the width. So I inject from the posterior. Half the width? Half of the width. Then longest capitis. Longest capitis is in the superior portion. In the similar fashion, you can approach the way we were approaching the other longest coli. So the longest capitis is the muscle which is very deep into this, and the approach will be same what we saw in the previous one. But now you are at almost atlantoaxial joint or C1 level. So again, you have to be bothered when you hold the finger, you hold the sternocleidomastoid, feel the carotids, and go medial to the carotid. And so you are going below the trachea and below the esophagus by the time you reach it. In FSS type, as we saw, splenic capitis, I think we have already discussed. Here I want to tell you is that the landmark I feel is, you can feel the mastoid process. I go about 1 inch behind the mastoid process and about half an inch below. This is the location of the lateral portion of this muscle. I inject in 2 ways, 2/3 in the upper part, and 1/3 I go 1 centimeter down and 1 centimeter medial. So 1/3 dose I inject at that place. Oblique inferior capitis is, as we'll just learn, is very strong muscle, especially if there is a retrocaput. So this is the red color muscle, which starts from the spinous process of axis and goes to transfer process of atlas. So it goes from here. To inject it, ideal would be to go about 1.5 inch below the occipital margin and about 1.5 inch lateral. Then you can inject and ask him to do this movement. You will be able to feel the muscle. Splenic cervicitis is a long muscle starting from T3 to T6 and starts from lower down and goes up to C1 to C6. So paramedian muscle, wherever you put the needle, and if you do this extension of the neck, not caput, then you will be able to feel the muscle. These are 2 points where you can inject. The depth has to be judged by the EMG. Trapezius, I think we already talked about. Thank you very much.
Thank you very much, Professor Gail. It is a great pleasure to welcome my friend and paddle player, Dr. George Kapsas from King's College Hospital in Dubai. And in his spare time, George is also a specialist neuroradiologist at King's College in Dubai. And his latest hobby is that he's just become a father 6 weeks ago. So congratulations, George.
Thank you. Can you please change that? All right. Okay. Visible? All right. Good afternoon. I'll try to be brief as it is the last presentation in this session. So, as Professor Ray said, Professor Guy said, I will be talking about neuroimaging in Parkinson's disease. I will not bore you with what Parkinson's disease is, you already know, but I will point out that Parkinson's disease is characterized by nigrostriatal dopaminergic degeneration, so loss of dopaminergic neurons, and this loss is from lateral to medial. So the putamen is the first one to be affected, and the caudate nucleus is affected later. And this, we will see later, is quite important in the imaging. So the diagnosis is a combination of patient history, physical examination, etc. And neuroimaging may not be warranted for people with Parkinson's disease. However, in patients with atypical findings or lack of response, then doing imaging is a good idea. The list of techniques employed in Parkinson's disease is quite long, as you can see. It could be SPECT, PET, structural MRI, diffusion weighted or diffusion tensor imaging, spectroscopy, fMRI, even sonography, but we don't use them in routine clinical practice. The ones that we use is SPECT, PET, and structural MRI. So let's start with the most widely used examination, which is iodine 123 eye of Lupin SPECT, also known as DAT scan. So it is very sensitive and specific for the differentiation between Parkinson's disease and essential tremor or vascular Parkinsonism. However, it cannot reliably help distinguish between Parkinson's disease and atypical Parkinsonian syndromes or among atypical Parkinsonian syndromes. And this is what the exam looks like. This is a normal person, a normal specimen with, you can see the uptake is normal in both left and right. And this is a patient where we can see that on the right there is decreased putaminal activity. As I told you earlier, the putamen is the first one to be affected. Then here we have bilateral putaminal depletion, and we only have in the caudate heads some uptake, and then here even in the right caudate head there is depletion. As you can see, we are just eyeballing here, so it means that it is a qualitative assessment, and this is not good. That's why newer software has allowed us to do quantification. So a new DAT scan can analyze automatically the uptake and compare it with the normal distribution, and we can see where our patient lies in comparison with the normal population. For example, in this patient, you see the red dot is very much lower than the median. FDG PET. So FDG PET is most often normal and shows preserved metabolism in the putamen. This is useful to differentiate between PD and PSP and MSA, atypical Parkinsonian syndromes. However, there is another PET scan, the 18-fluoride DOPA scan, which uses a specific tracer, and it will show us that the loss of dopamine production. So it is a technique that is very much alike DAT scan. However, it has higher quality, and we can directly measure the dopamine synthesis, and it has patient benefits as well, as there is reduced scanning time and radiation exposure. However, the caveat is that it's a very expensive examination and you need a cyclotron nearby, because the half-life of the radio tracer is only 110 minutes compared to 13 hours for the DAT scan, sorry. Finally, in structural MRI, we don't have too many findings specific for the Parkinson's disease. One sign that has been lately described is the absent swallowtail sign. In the SWI sequence, normally the nigrosome 1 has high signal. In patients with Parkinson's, and it looks like a swallowtail. However, in patients with Parkinson's disease, the normal high signal of the nigrosome 1 is no longer visible, and therefore the swallowtail sign is absent. In my opinion, this is a very hard, the specificity is quite low actually, because the patients usually move, and the high resolution SWI sequences, they take too long to finish. So although sometimes it can be helpful, it is not the most important examination for the diagnosis. So let's see now what we said that neuroimaging can be useful. What can it be useful for? It can be useful for the differentiation between Parkinson's and other conditions which are mimics, and also Parkinson's and atypical Parkinsonian syndromes. The list of secondary Parkinsonian syndromes is long, drug-induced NPH, hypoxia. I will speak mainly for normal pressure hydrocephalus. It's a very common condition, and it can really sometimes cause confusion between Parkinson's disease. Is it Parkinson's? Is it not? So the typical pattern in normal pressure hydrocephalus is this, is a so-called DESH, disproportionate enlargement of the subarachnoid space in hydrocephalus. We have enlargement of the sulci in the base of the skull, and we have crowding of the gyri in the superior aspect of in the cranial aspect of the skull, and at the same time we have enlargement of the ventricles. However, if you look at this patient, it looks very much like NPH, but it's not NPH, it's atrophy. And I can tell because I can see that there is also enlargement of the sulci in the convexity. However, we have some metrics which are quite specific for the differentiation between atrophy and normal pressure hydrocephalus. One is Z-Evans score, which is we take a coronal cut at the level of the anterior commissure, and we measure the craniocaudal diameter of the ventricular system and the craniocaudal diameter of the whole brain, and this ratio should be less than 0.42. Above 0.42, it is highly suspicious for NPH. Another metric is the brain-to-ventricle ratio. At the same plane, we measure the craniocaudal diameter of the ventricle versus the diameter of the cerebral parenchyma above the ventricle. This should be less than 1. When this becomes more than 1, again, NPH. Finally, at the level of the posterior commissure, we measure the callosal angle, which should be more than 90% to be normal. If it is less than 90%, again, it is highly suspicious for NPH. Vascular Parkinsonism, when we see also all these white matter lesions, they can also cause vascular Parkinsonism, which can be easily actually differentiated clinically from Parkinson's disease. Regarding now the differentiation of Parkinson's disease from atypical Parkinsonian syndromes, and which are the atypical Parkinsonian syndromes: progressive supranuclear palsy, multiple system atrophy, corticobasal degeneration, and dementia with Lewy bodies. Regarding progressive supranuclear palsy, the most well-known radiological sign that you all know is the hummingbird sign and the Mickey Mouse sign. Right? The midbrain looks like a hummingbird here and also like Mickey Mouse on the axial plane. However, this can be quite misleading. This patient, he does look like he has a hummingbird here, and also his midbrain does look like Mickey Mouse, but he is a patient without Parkinson's disease. He has just atrophy of the brain. So how can we be sure that this is indeed a hummingbird sign? We have devised this metric, which is the midbrain to pons area ratio. We measure in the mid-sagittal plane, we measure the area of the midbrain and the area of the pons. The normal ratio is 0.24. The proposed, as the midbrain atrophies, this ratio becomes smaller, and therefore the cutoff is 0.16. So below 0.16, we can discriminate PSP from PD or MSAP. There is another ratio which is more complex. I will not go into it. Multiple system atrophy. So there are two types of multiple system atrophy: Parkinsonism and cerebellar type. In the Parkinsonian type of MSAP, the radiological finding that we usually see is that there is reduced signal in the globi pallidi in the putamina in comparison with the globi pallidi. You can see there is a rim of low signal in the putamina. And another newer sign, more specific, that was described is the black straight line sign. So you see in this normal patient, the putamina are still quite low signal, but in Parkinson's disease, in MSA P patients, the putamina, they become atrophic and linear. Also, MSA-P also very often coexists with MSA-C, and in MSA-C the characteristic finding is the hot cross band due to the atrophy of the transverse pontocerebellar tracts and of the median pontine raphe nuclei. Corticobasal degeneration, not many specific findings. The most specific finding is the asymmetrical atrophy in the posterior frontal and parietal lobes, which we can also see in FDG BET as reduced uptake. Finally, dementia with Lewy bodies, we only see generalized decrease in cerebellar volume. And it is the mesial temporal lobe and hippocampi are relatively normal in size, and therefore we can distinguish it from Alzheimer's disease. And finally, one case which is quite interesting, a patient 72 with clinically suspected atypical Parkinsonian syndrome. You can see a very typical looking hummingbird. Look how atrophic the midbrain looks. But when we go on to do the ratio, you see that the midbrain to pons area ratio is 0.24, which is normal. And why is that normal? It is normal because we have marked atrophy of the midbrain, but also there is marked atrophy of the pons. And if we look at him on the axial plane, you see very, very significant atrophy of the pons, of the MCPs, of the cerebellum, and the hot cross band sign, which are findings of MSA-C. And on top of that, we see the thin black vertical lines that we see in MSA-P. So this is most probably a combination of MSA-P and MSA-C. So to conclude, MRI, SPECT, and PET are the modalities mostly used in clinical practice for the imaging of Parkinson's disease. The most specific findings are the absent swallowtail sign, dopamine deficiency in that scan, and also in the 18-fluoride PET, and preserved metabolism in the striatum in the FDG PET. Neuroimaging can be helpful to differentiate from secondary Parkinsonisms, especially normal pressure hydrocephalus. And specific findings can help in the differentiation from atypical Parkinsonian syndromes. For PSP, as I told you, do not trust the hummingbird or the Mickey sign blindly. Do the midbrain to pons area ratio, it's much more specific. For MSA-P, remember the putaminal hypointensity that looks like vertical black lines. For MSA-C, it often coexists with MSA-P, and when we see the hot cross band sign, we should think that this patient has MSA-C, and maybe he will have MSA-P as well and some Parkinsonism. For CBD, the asymmetrical atrophy in the posterior frontal and parietal lobes, and for DLB, generalized decrease in cerebellar volume. Thank you.
Thank you very much, George, and keep it to time. Also, just because it shakes doesn't mean it's Parkinson's disease. And also, I don't often get mistaken, Professor Chowdhury, but it's clear what sleep deprivation of fatherhood is doing to you. Thank you.
Thank you.
At the end of the session, I think maybe we should, I don't know, Vinod, quick coffee and then head off to the Botox session. Any questions to any of the speakers? Thank you very much. Thank you.
Honorable Chairpersons, I would request Prof. Paradine, Dr. Taha, Prof. Damija and Dr. Gai to remain on stage to present few mementos to some of our guests. Remain on stage. I would also like to invite Professor A. Chowdhury on stage to present mementos to our guests. Thank you so much, professors. I would like to invite Dr. Mohammed Al-Khaja on stage to receive his memento. Dr. Mohammed Al-Khaja. I would like to invite Mr. Ali Jafar Najm to receive his memento. I believe he's not present. Thank you so much, sir. Thank you so much. Next, I would like to invite Dr. Mohammed Al-Khaja to present mementos to the faculty. We will first have some of our esteemed guests, and their mementos will be collected by Bahrain Specialist Hospital staff and Dr. El Mahdi on behalf of them. The memento for Dr. Majed Ardate will be collected by Dr. Mohammed El Mahdi. Dr. Majed Ardate. I would like to invite Ms. Hekmat to receive the memento on behalf of Dr. Qasim Ardate. Round of applause, ladies and gentlemen. I will release you for coffee very soon. I would invite Dr. Mohammed El Mahdi to receive the memento for Dr. Adil Al-Jishi. I would like to invite Ms. Hekmat to receive the memento for Dr. Najjar Rashid Al-Zayani. I would like to invite Dr. George Kapsis to receive his memento. I would like to invite Dr. Taha Al-Duraj to receive his memento. I request Dr. Mohammed Al-Khaja to remain on stage. While I invite all the faculty up on stage to present 3 special mementos for our pharma partners. May I invite all faculty up on stage, please? Prof. Ray, Prof. Paradine, Dr. Carolina, Dr. Guy, Dr. Vinod Mehta, Prof. Rupam, Prof. Rukmini, Prof. Sampath, Prof. Vinay Goyal, Dr. El Mahdi, Dr. Taha. Prof. Dameja. We are very humbled at your gestures. We are very thankful. I would like to invite Dr. Dai on behalf of AbbVie Pharma to receive the mementos. I want to invite Ms. Bhavina Patel on behalf of GSK to receive her memento. Global Kinetics Pharma. Round of applause, ladies and gentlemen. I would like to mention Mr. Omar from STADA, who is not, oh, he is here. Do please join us on stage to receive your memento. Thank you so much. I request the faculty to be standing for us to take one group picture. Then we are done. We will head for coffee break.
standing next to whom, Mohammed? Well done, Hasna.
Thank you, ladies and gentlemen. We will meet you in 5 minutes for the workshops.
बोलो बोलो आप
Ladies and gentlemen, finishing their teas, coffees, I would humbly invite you to come inside the conference hall so that you can be grouped into 5 groups. We have 5 exciting workshops. Ladies and gentlemen, let's come inside the conference room. We have a workshop on migraines, a hands-on workshop, which will be headed by Dr. El Mahdi and Professor Damija. I would request the duo to go to their station, migraine. Professor Damija and Dr. El Mahdi. We have a spasticity workshop headed by Professor Rupam and Professor Sampath. I would like to invite both of them. We have a dystonia workshop headed by Professor Perodin and Dr. Carolina. I would like to inform both of you to your station. We have a PKG workshop headed by Dr. Vinod Mehta, Professor Ray, Mr. Afsal and Ms. Bhavina Patel. I invite you on stage. We have advanced therapy workshop headed by Senior Parkinson's disease nurse specialist, Ms. Terese and Ms. Clara. I invite you to go to your station. We request the Bahrain Specialist Hospital team to help us with grouping the attendees into 5 groups. Each station will be 15 minutes. We will rotate amongst the groups. Ladies coming in, have a seat in the front row. We will divide you anyways now.
Professor Goyal, and you should be with the, one of you should be in the, yes. No, you should stand there as well. Yeah, Rukmini, you should come with the migraine as well. I think, Dai, take a seat. You got your session, take a seat. There is Hekmat. Ask Hekmat to...
She's getting the attendance.
Hammer. Could you please all ask the delegates so that the team will help? So we divide the sessions into 5, please. So we have, it's a very good opportunity. Ask the, Mohammed, ask the neurosurgeon to be, sir, please come, it's past city, sir. Which one is your like it? You're like skull, right, sir? You're a skull man. Yes, so, where is the dystonia? Oh, yeah, dystonia, that one. This one is a migraine. So that's your, that's head and neck. Thank you very much, sir. No, you want head and neck. Sorry about that. Wrong one. See, you have a dots. You have those, yeah, please, Hami, that's very important. You know, so that they can show. I think IT guys, ask IT guys, could you please keep that one, should be changing as well here. Huh? So, Afsal, keep all this one in the rotations. Yeah, please. Keep the scenarios there. It's not easy, Bhavina, to organize all this. So you all get a chance to rotate. See, we have a migraine session. Someone is asking me how to inject Botox for migraines. So we have a workshop migraine, we have spasticity, and we have dystonia on the other side, and we have the device-aided therapies. Can I request you, all of you, to join, please? Please. All of you should come and join the groups, please. Hekmat. Yeah, so first all of them should come. All of them, please. Tell in Arabic as well, like Hekmat. No sitting, please join us. At least see what we teach. Come on. Please join us in groups, please. All of you, madam, the blue one. Please come in here, the headache. And one of you should go there so that you rotate, so that, you know, we won't be overcrowded. We won't be overcrowded. Please, Kama, you should be here. Yeah, Guy, please, thank you, Guy. Hello, madam. You should go, someone should go there. Mohammed, send that madam to that side, please. They should display international movement disorders as well, please. Display, change it. So, who is maintaining the timer? So, see, just go through the anatomy and start basics, Rupam, no? Right, excellent. So, who is maintaining the timer? Right, okay, good. Please free to ask questions if required. Don't worry about, don't be shy. Ask basic questions. take a deep basics, Rupal, very good. Yeah, where is the pain? Yeah. Sometimes you get pain here, sometimes you get pain here, sometimes you get pain.